Hello friends and colleagues, my name is Milton Leon from Hong Kong.
And my name is Ze'ev Shoham from Israel. It is our pleasure to open the 15th Ovarian Club meeting, which takes place via the internet as the pandemic still, unfortunately, prevents us from face-to-face meeting.
The short program we composed for the meeting will start with a state-of-the-art lecture on endometriosis given by Professor Philip Konix, following by a few lectures on recent innovations in reproductive medicine. We will hear today about PGT-A, the genetic of the endometrium, future of IVM, luteal phase support, metrics of ART, AI in digital health, and we will finish with a lecture on the global pandemic and a new age of telemedicine.
We would like to thank the speakers for their time and efforts willing to share with us the knowledge, and to all of you joining us today. So without any further delay, let us start with the program. Hello everyone. It is our pleasure to host today Professor Philip Konix. Professor Philip Konix is Professor Emeritus in Obstetric and Gynecology from the KU Leuven University in Belgium. He also serves as a consultant at the University of Oxford in the United Kingdom, University Cattolica in Rome, and Moscow University State. Philip is also served as the Director of Research at the Latifa Hospital in Dubai. He started laparoscopic surgery in 1986 with pioneering early interventions, most specifically deep endometriosis. His research is mainly in the field of endometriosis and prevention of adhesion formation. His actual focus is pathophysiology of endometriosis, more specifically the genetic epigenetic aspects and the peritoneal microbia. And he discussed with us today some aspects of endometriosis. So Philip, please go ahead.
Diagnosis and treatment of endometriosis remains debated. The difficulty of endometriosis is the absence of knowledge of pathology. Endometriosis is the only disease defined by routine pathology. Endometrium like glands and stroma outside the uterus, as Samson said 100 years ago. This has been challenged recently by the addition of fibrosis, addition of hemocytic-related macrophages. It means that stomatosis is excluded by definition. Mullerianose and cholecystoma is beyond this topic, is pretty rare. But it means that the problem of any pathology which is defined by pathology is that we do not have any idea about accuracy, because the golden standard cannot compare to anything else. There is not a 100% agreement between pathologists, and the transition between pathology and genetics, epigenetics, and to understand which changes are reversible or irreversible is pretty difficult. So if you have an endometrium-like tissue by histology, it comes from the genome, the nucleosomes, epigenetics, intercellular pathways, cell-cell interaction, blood hormones, cytokines, immunology, and many other factors. And then you can say, if it looks like a duck, walks like a duck, and talks like a duck, but it is a komkommer, it's not a duck. Epigenetics, a long story about epigenetics. It's the stable, heritable traits or phenotypes that cannot be explained by change in DNA sequences. Remember at this moment only that some parts of the DNA are more exposed and more easily translated, and there are some additions like metionins, like I'm going to change the ease of translation. Just to give an example how important it is one of our last hypotheses. If you have a deep endometriosis, and we have arguments to say that the center are cells with genetic epigenetic mutations, but the periphery are cells which only look like endometriosis because of these bad cells in the centrum. Which means if you take this out, these cells are going to reverse to normal cells, which is an argument not to be that aggressive for surgery. The pathophysiology is poorly known because there's no animal model. We need to know the start of the disease, how it develops, when it develops to one or another type of lesions, and what the symptoms are. This is the prevention. This is the therapy, radicality type of surgery. To start with, endometriosis looks like an endometrium. You have to know it's the fastest growing tissue. You have shedding and retrograde menstruation, specific hormone sensitivity, peristalsis. There's a junctional zone, and during pregnancy you have invasion, typical change of immunology, and you have these changes in the spiral arteries, and if you have no changes, at that moment you get preeclampsia. All data of 20 years ago. We are not going to review the history of endometriosis. It starts 150 years ago, and after all, we do not know much more than so long ago. It was the deep endometriosis, this was Cullen, Samsung, the cystic ovarian, and then you have a lot of very interesting case reports. And then we know that it was a very frequent cause of gynecologic surgery. In 1970, we began to know that typical lesions are so frequent. 85, we knew the subtle lesions. And then 91, deep endometriosis, which is still poorly defined. Observations on endometriosis, there are a lot of them. You have a visual appearance, can be subtle, typical, cystic and deep, occurs in women without endometrium and in men. It's clearly an hereditary disease. The natural history is not very well known, nor the epidemiology. It's a heterogeneous disease, come back to this later, and it's associated with pain, infertility, adenomyosis, change in the plasma peritoneal fluid, endometrium, and so on. And the lesion itself, it's clonal, and there's an altered biology like estrogen and progesterone resistance. And for endometriosis, which is beyond the talk of this talk, and the adenomyosis, it is almost the same. There are a lot of associations which are published today, like for instance atherosclerotic cardiovascular disease. I think today we do not have enough evidence to consider this. Also a discussion which is beyond the topic of this presentation, but the difficulty is to have large databases in order to judge endometriosis. What is clear is that endometriosis is a hereditary disease. Familial clustering, the twin studies, heredity. If your mother has endometriosis, you have 6 times more probability of having endometriosis. If your mother has severe endometriosis, if even much more. Genome-wide scanning and linkage analysis has shown a lot of loci, all in the regulatory regions, but it's too early to make a real conclusion. What I think is one of the most important aspects is that endometriosis is a clonal disease. It's one cell who develops too many cells. And this is true for cystic, for deep, and what's even more important for typical lesions, that if you have 10 typical lesions, there are 10 different clones. Clonal is one of the keys about endometriosis. Then you have the big problem between association, is this a cause or a consequence? A decreased natural killer cell activity and increased CO125, which is well known, 4 months after excision, you have this kind of low natural killer cell, which remains the same, but the high CO125 has decreased. Gives a suggestion that the CO125 is a consequence and the natural killer cell is something which is prior to endometriosis. For all the other associated factors, endometrium, fertility, plasma, cancer and so on, we don't know. Pregnancy, we begin to have an impression that after surgery for deep endometriosis, the increased pregnancy complication rate, like preeclampsia, is not going to be improved, which is an argument to say that this is something which is prior to the onset of endometriosis. The lesions are heterogeneous. We have bone complications during endometriosis, one of the important publications of Antonio Setibal. And there you see that at the end of pregnancy, occasionally you have very severe complications. So which means that some of these lesions behave differently. What is not so surprising if you see that some of these lesions have from 0 to 100% progesterone resistance. We have the very nice data of Rear about dioxin and endometriosis. Not that well confirmed in the human, but I think the data are solid, are still there, which means something that acts at the level of the genome is going to affect endometriosis. We have the recent data that even after menopause, 5, 10, half of them more than 10 years of after menopause, starts to develop deep endometriosis. And this in the absence of circulating estrogens or in the absence of estrogen intake. There's a reason why I would say today the theory of Samson, of retrograde menstruation and implantation, is historical speculation. Whatever the original cell is, it doesn't explain metaplasia, it doesn't explain progression, it doesn't explain hereditary aspect. It's absolutely incompatible with the clonal aspect. It's not compatible with deep endometriosis starting 10 years after menopause, and does not explain the effect of dioxin and radiation. This is the reason why we propose the genetic epigenetic theory. And this is a very complicated slide we are going to explain. Key is genetic epigenetic changes. Whatever the original cell, endometrium, stem cells, bone marrow cells, this is the predisposition, infertility, changes in endometrium, immunology, associated changes in men and in Rokitansky. They can implant. This is the subtle lesion of microscopic lesions, and we consider this as normal cells, not as a pathology. But if in these cells or in these lesions something happens, genetic or epigenetic changes triggered by oxidative stress retrograde menstruation or bleeding in the lesion or infection, at that moment you are going to start the disease. That's why these lesions are clonal and that each lesion is different, which means that the typical and the cystic and the deep are different pathologies. In order to understand, you have to grasp redundancy of molecular biology. You can go from one place to the other with the motorway. If the motorway is blocked, you take the secondary roads. And if this is blocked, you are going to take the tertiary road. But each time it takes longer and you can deliver less good. Which means that before a problem becomes apparent, you already need several incidents, and that initial incidence remains invisible. This means that these cumulative genetic, epigenetic incidents start with inherited risk. This is the risk to develop endometriosis. These are the changes in endometrium. This is the associated infertility. These are the pregnancy changes. These are the changes in immunology. And then during life, because of radiation, pollution, oxidative stress, infection, you get more and more lesions. And all of a sudden, you have this one lesion too much. And then you start the endometriosis. And the endometriosis does have a specific set of defects. And these lesions are variable according to the types of endometriosis, according to the estrogen production, progesterone resistance, repetitive tissue injury and repair, which means bleeding in the lesions, and also the recurrence risk. After it starts, these lesions start to grow, and growth varies with the genetic epigenetic changes. What is the genetics of these lesions? And they develop in an abnormal environment, the peritoneal cavity, with all the immunology, cytokines, inflammatory, oxidative stress, and so on. And also you can have new incidents in these lesions, again by bleeding and oxidative stress in lesions. What is recent and what we think is very important is infection as a potential cofactor in this mechanism. It's very clear that you have a progressive changing microbiome from the vagina to the cervix, to the uterus, upper genital tract, and to the peritoneal cavity. And you see that in women with endometriosis you have more infections, you have an altered microbiome, and in women with endometriosis you have specific infectious agents like HPV molecules. And this came to the model that this microbiome is something which is going to add to the risk of having genetic epigenetic incidents. And this altered microbiome is also going to produce growth factors which influence the growth. In conclusion, in order to understand pathophysiology of endometriosis, we have to separate the initiation and the growth of the lesion. The initiation starts with the genetic epigenetic incident. In women who already have incidents, each lesion is different and clonal. The incidents are driven by oxidative stress, retrograde menstruation, and infection, which means that endometriosis are at least 4 different diseases: the subtle, the typical, the cystic, and the deep lesions. The growth in natural history varies with the incidence, varies with the environment, for instance the peritoneal cavity, and is probably self-limiting. Recurrence rate is the risk of new incidents in women who already have endometriosis and thus have a lot of incidents which are already there, which are at risk. It's unclear whether immunologic changes are a cause or a consequence, and probably both. Since endometriosis cells can migrate to the endometrium, changes in the endometrium become ever less clear. Growth and natural history, everything we know about the peritoneal cavity, the angiogenic factors, VEGF, THF, cytokines, growth factors, low-grade inflammation, all this remains true. This is one of the old first stories where you have this, the chicken allantoic membrane, where you see this kind of angiogenic factors. We have this data about PP14, which inhibits natural killer cells. It's like endometriosis, which shields itself from the attack from natural killer cells. When we have understood the pathophysiology, we come to the clinical aspects. And the clinical aspects of endometriosis is how to prevent the disease, how to diagnose, which treatment, medical, surgery, and infertility, and what does the patient think of, which information should the patient have. Is the diagnosis okay? The individualization of treatment, and the quality of surgery. And quality of surgery, it means that you need a surgeon who is skilled, without complication, no adhesion, and right indication. And video registration should be mandatory. This in itself is another lecture. The prevention of endometriosis, first, reduce pollution. This is something that should be investigated in deep lesions, because these are the only lesions where you have a clear diagnosis without doing surgery. You have the prevention of oxidative stress, which means less blood in the peritoneal cavity and in the endometriosis lesions. No withdrawal bleeding, for instance by continuous oral contraceptives. No bleeding in the lesion, which means early surgery, no delay in diagnosis, and which is very important for adolescent endometriosis. Unclear whether antioxidants and food intake play a role. Probably yes, but not very well understood. Infection should be paid more attention to, vaginal infections, cervical infections, and endometritis. The diagnosis of endometriosis is mainly symptoms and clinical exam. Biomarkers are not useful today. Imaging is beyond this topic, because in order to discuss precision, stratification, sensitivity, specificity versus predictive values and the prevalence of the disease and what we are investigating is another discussion. It's very important to know when to do a laparoscopy, and this is the problem of adolescent gynecology. Are we going to accept a diagnostic delay and repetitive bleeding within the lesions, and there's more endometriosis, or risk to develop more lesions? The diagnosis should be associated with surgery or not. The study of the somatic nerves dissection is also beyond this topic. And what I think is a common mistake is a prolonged medical therapy without a diagnosis. In order to understand medical therapy of endometriosis, we should realize that there is not a single blinded trial which is performed. Because if you give, for instance, GnRH, if you don't know which women are going to have placebo and active drug, the woman knows within 2 weeks. All trials are done in women with pain and proven endometriosis, which means after laparoscopy, which means that most of these women did not have endometriosis anymore because it had been removed by surgery. And all these trials affect menstruation with a carryover effect. in order to say that of all the data which we have about medical therapy of endometriosis, there is not one really valid study. When we try TNF-alpha, it has no effect but a strong placebo effect. The second point was very important for medical therapy is individualization of therapy. It's very clear that if you give estroprogestins in a woman with progesterone resistance, you only stimulate. It's also clear, and this is one of our recent papers, where you see that 20% increase the lesion and decrease the lesion in 80%. What is very clear here, if you make mean standard deviation, you are not going to see. Even with box and whisker plots, it is difficult to see. Which means that all the data which we have today with means and standard deviations and estroprogestin treatment are not very valid. This is something that has indirectly already been proven that the progesterone receptor status predicts the response to progestin therapy. What is logic? This genetic epigenetic pathophysiology is also an additional argument not to delay surgery, especially in the adolescent, and not to start IVF too liberally. In fact, sticking needles in endometriosis lesion, at least they go bleeding in the lesions, which is another oxidative stress stimulus. The management of endometriosis today is the management of a benign tumor or surgery. The suspicion of endometriosis because of the symptoms or knowledge. We know that if a woman is infertile, they have 50% typical lesions. Medical therapy without a diagnosis for longer periods, I think, is a mistake. And after surgery, I think, and this is one of the biggest advantage today, is that if we can prevent recurrences by understanding, it may change surgery, it may change the surgery and the concept of peripheral metaplasia. If you go for this kind of small lesions, you see that subtle lesions, 5 bursts of a layer. For cystic ovarian endometriosis, what has been taken poorly into account are the intra-ovarian steroid hormone concentrations. It does not take into account that most of these lesions have no endometriosis cells, only hemosiderin-laden cells. Also the vascularization inside the cyst of young women and the role of THA is poorly taken into account. Whether we have to do stripping versus superficial destruction is something which remains debated. Stripping has a lower recurrence rate, but more ovarian damage. The invasion is only 1-2 millimeter, which might be an argument for alcoholization, and it remains unclear whether the capsule is fibrosis or endometriosis. It's one of the reasons that we think that THL has a role in adolescent endometriosis, a role which should be explored in the near future. Deep endometriosis, defined as 5 millimeter under the surface, which means that you have this kind of overlap between the typical lesions and the deep lesions around 5 millimeter, which means that this definition are going to include a lot of typical lesions into deep endometriosis. There are 2 types. You have this kind, what we would call a typical lesion, which is a little bit deeper, and this is mainly fibrosis, and then you have the other type, which is mainly glandular, which means at least also the deep endometriosis are different. The problem of deep endometriosis is the diagnostic accuracy of imaging, which we are not going to discuss here. The majority of nodules of more than 1 centimeter are treated by bowel resection. And there you can argue whether this is necessary, but since bowel resections are associated with anorgasmia, which we consider a complication, there is a problem. That's the reason why we prefer to have try and see, and if you can excise, it's better, and it can be done in the large majority. This is the first message. Clinical indication. If suspected, you know there are other endometriosis lesion. Imaging is useful to plan surgery, not to decide about surgery. The final decisions are made during surgery. Since we have small nest of endometriosis at distance from a deep endometriosis nodule, completeness of surgery is a discussion which keeps to go on, but we think that since you have fibrosis around the nodule, and if you take out the nodule, this is more than sufficient, as we suggested more than 10 years ago. This is what today we have as hypothesis is a nodule surrounded by metaplasia, since the recurrence rate after excision, incomplete excision, or even after a large bowel resection are very similar, which means that these cells at the periphery are not going to develop into endometriosis. So you see how that pathophysiology is affecting our surgery. Complete incision of endometriosis anyway is an illusion, and it's probably not necessary. And then you can ask yourself, feasibility of excision cannot be predicted, and therefore follow the borders of endometriosis. That's why we suggest try and see. In fact, what we did in the past at Leuven University and in Oxford and in Rome, which means that for the rectum we have less than 1% bowel resections. For the sigmoids, it's around 10%. And there you can argue about what's necessary or not. What we think is important is a fixed strategy. First, lateral excision around the ureter, extend to the uterosacral and the pararectal space, and then posterior extension up to the ischial spine. Leave the bowel nodule attached to the uterus, and then you begin to dissect between the bowel and the rectovaginal space. This is very clear, like you see here, progressively. This is more than 10 years ago. There is already a defect of the muscularis. And if you continue, this is this kind of large glandular nodule, and afterwards you suture this in 2 layers, in 1 or 2 layers. For the sigmoid is different, because in order to have a plane to work on, it's better to attach the sigmoid to the round ligament in order to have a fixed plane for surgery. We are not going to continue to discuss in detail the surgery, but as even a sigmoid endometriosis can technically be done. I show here, this is beginning of the section with the CO2 laser. Once you're a little bit deeper, you continue with the laser up to the muscularis, and when this is going to be done, when you reach the muscularis, sharp scissors, and the sharp scissors is going to have excision of endometriosis. This is an argument to say that the nodule is much more bigger than it looks from the outside. It's technically difficult surgery, but it's feasible. As a conclusion about sigmoid endometriosis, it's feasible. It's technically difficult because it's very mobile structure, and there's little or no advantage over resection. This is the reason why I would say for the sigmoid, go for an absolute extensive liberal use of bowel resection. For the rectovaginal endometriosis, this is an example, all the same thing. This is a big nodule. You first go to the pararectal spaces, the section of the pararectal space, you see the nodule attached here. I show this just to show feasibility. And feasibility is, you continue. Important is to do the lateral spaces first, and you need to do this first so that the central part of the nodule remains attached to the uterus, and that when you start to dissect this part of the uterus, you have a clear indication what is bowel and what is nodule. And when this is done, at that moment you start to dissect. And when this is done, you start to dissect. This is more the lateral part. Just to emphasize, that's important to do all the lateral parts completely, because we have done the left part was complete. The left part, you see, it's still hanging here, so we cannot have a clear dissection of the central part of the nodule. And when everything is done, at that moment you start the excision of the endometriosis from the bowel, which can easily be done. It's not this kind of straightforward surgery, but it's feasible. And when everything is done, at that moment you go for dissection from the rectovaginal space and you suture with 1 or 2 layers. An alternative, and these are videos received from courtesy from Marco Basso from Sao Paulo. This is the discoid excision, where you can do this in 1 or 2 layers. Even double discoid excision is something which is done today. This is one. The second aspect is that if you do not use this, you can use electrosurgery, which is very close technically as what we did long time ago with the CO2 laser. And it means that if you use this in the right condition, the electrosurgery and excision of a nodule makes that excision of nodule becomes feasible in almost all nodules, which means that with experience and with technique, bowel resection is going to be the past in surgery. Conclusions for deep endometriosis. We know that sexual problems are a complication. We know that the necessity of a bowel prediction cannot be predicted beforehand. That's why we think, try and see if excision can be done, and at that moment almost all rectovaginal nodules can be excised. My interpretation today is that the future is going to be the disc excision with the circular stapler, because it's faster, you never open a bowel, and it replaces extensive surgery, which can be hard for many surgeons. A bowel resection is easier, is faster, is better standardized, and we recommend a liberal use for the sigmoid, but not for the rectum. 2 words about infertility. For infertility, the big question is when to do a laparoscopy. In our vision, we should always do a laparoscopy if it's associated with pain, if there is a cystic ovarian endometriosis or a suspicion of a deep nodule, and if infertility is the only symptom, you know that this woman has 50% probability of typical lesions, and even then I would favor to do a laparoscopy. When you have to do IVF anyway, maybe you can avoid to do a laparoscopy. The pregnancy rates, we know this after microsurgery of cystic ovarian endometriosis done by Stefan Gott in the 80s. And you see that we have something like 60% cumulative pregnancy rate. Which means that in conclusion, understanding the pathogenesis of endometriosis, at that moment you begin why we have endometriosis, why we have recurrences. It's clear it's a benign tumor. We begin to know that adolescent endometriosis should be treated more or considered more with more care than is done today. Prevention becomes possible, which changes our therapy of endometriosis. For medical therapy, it's important that each lesion is different and that oral contraceptives will stimulate some lesions. But endometriosis remains a subtle and important surgical disease. The subtle lesion is clear. The arguments to be less radical for deep endometriosis are there. Nerve pain and distant os nerve discussion, that's for another presentation. And after surgery, I think we have to use medical therapy to reduce bleeding and prevent recurrences. Thank you for listening.
Hello, I'm Norbert Gleiche, MD. I'm the Medical Director and Chief Scientist at the Center for Human Reproduction here in New York City. And I'm also a guest investigator at Rockefeller University, amongst some other titles. It's my pleasure to introduce this program today as moderator and presenter. After I will give you a brief introduction, Mia Young, who is a guest investigator at Rockefeller University as well, and a junior scientist here at the Center for Human Reproduction, will give the main presentation. And the topic, as this slide demonstrates, is newly arising questions about PGT-A. Results of previously refused transfers of abnormal embryos and human self-correcting data in gastroloids, so-called artificial embryos, and early-stage embryos. The concept of transferring so-called abnormal embryos or embryos that by PGT-A were declared to be chromosomally abnormal, arose at our center here in New York in 2014 after we saw, probably by coincidence, within a very short time period, 3 or 4 young couples who went through a series of IVF cycles, each of them, and ended up with only abnormal embryos. And statistically, that seemed to us totally impossible. And we at that point decided to start on an experimental basis in the early stages to offer transferring some of these embryos. And with that introduction, I will take you through the rationale for the study that we were lucky to find wonderful collaborators for at Rockefeller University with Professor Brimanlu's laboratory and Mia as the principal investigator, because we now have a very good explanation why those transfers, which we for the first time reported at the SRM meeting in 2015, so this is exactly 5 years ago, we now have an understanding why it is that we can transfer embryos that by PGT-A were declared to be chromosomally abnormal and end up with perfectly healthy babies. So my conflict statement, which we here in the US have to present before every presentation, there's nothing in this talk where I have a potential conflict. So what I will show you is our experience with transferring chromosomal so-called abnormal embryos by PGT-A, where patients were refused such transfers at the center where they produced those embryos. And I think there's an important, not only medical, but psychological point to be made here. These embryos exist, and like the embryos I will be talking to you about, there are thousands, probably hundreds of thousands of embryos currently frozen all over the world that could be transferred if just the IVF centers wanted to transfer them. The history of abnormal transfer of abnormal embryos, as I said, started in 2014 here and was reported first time in October of 2015 at the SRM. Shortly after that, Italian colleagues reported in a research led in the New England Journal a very similar experience. We reported 5 healthy pregnancies. They reported 6 healthy pregnancies after transfer of what they called mosaic embryos. Then there were a whole bunch of additional reports, and in 2019, Pasquale Patrizio from Yale, in collaboration with us, and this organization actually published a worldwide survey of cases and reported over 400 healthy babies born by that point. My guess is that by now we probably have the 1,000 babies number exceeded. In all of these children, there was not a single child born with chromosomal abnormalities after birth and after transfer of embryos with alleged chromosomal abnormalities. So let me tell you what a transferable embryo is at CHR. Our preferred embryos are monosomes because if it's a correct diagnosis, they are presumed not to implant. We also now transfer trisomies, except for 15, 18, and 21, because they obviously are known to survive. We make a risk assessment with other trisomies because some indeed can give you an increased risk of miscarriages, and we discuss this with the patients, and then it is up to them to decide whether they would like to have an embryo transfer. We are also transferring all segmental abnormalities with risk assessments, and we do not transfer any sex chromosome abnormalities. The more abnormalities an embryo has, the lower the pregnancy chances, but we do still transfer up to embryos with 3 abnormalities. So we obviously prefer embryos with single abnormalities ahead of 2 abnormalities and 2 abnormalities ahead of 3 abnormalities. We do not transfer more than 3 abnormalities in an embryo. Now, patients, in our opinion, also have the right to demand transfer of their embryos. They're under US law, their property. If we would not agree with such transfers, like, for example, with a trisomy 21, a Down syndrome. And in those cases, patients have to sign against medical advice consent in addition to the usual consent for transfer of chromosomally abnormal embryos. Now, therefore, we have a hierarchy of selecting embryos. Our preferred, because we see the highest pregnancy rates, is with single segmental abnormalities, single monosomies, followed by single selected trisomies, then 2 abnormalities per embryo, then 3 abnormalities per embryo. And I want to give you here the summary of a study that we just submitted for publication, where we summarized the data of 50 couples who transferred their embryos to us between 2017 and 2020 because their own centers were not willing to transfer them. We received 249 so-called abnormal embryos that were refused transfer. And out of those 15 couples, 40 had transfers. 112 out of those 249 embryos were transferred. That means that more than half of those embryos that were transferred to us are still in our freezing in our cryopreservation unit. And it also means, and this is a very important point to make, that the pregnancy rates I will show you and the live birth rates I will show you from those transfers that their own doctors didn't want to transfer represent less than half of what the potential is of their embryos, because more than half of their embryos are still frozen. Their mean age, also noteworthy, was 42.4 years. So this was not your average good prognosis patient population. And here's the summary. We had 15 clinical pregnancies for a clinical pregnancy rate of 37.5%. Amazing, isn't it? Those were embryos that are destined to be disposed of. 37.5% clinical pregnancies. We had 6 normal offsprings born for a live birth rate of 15%. What happened to the other pregnancies? We had 7 first trimester losses for a 17.5% miscarriage rate, not that much above the average miscarriage rate in spontaneous conception, which is generally listed at around 15%. And this was a surprising finding. 3 pregnancies for almost 10% rate, 8.7.5% rate of pregnancy loss was occurring often amniocentesis. That was obviously very disturbing. One of these pregnancies was indeed a twin pregnancy. This is a very disturbing finding and led us to change our policy, which required in the informed consent that patients signed mandated early pregnancy diagnosis by either CVS or amnio. And we, after we saw these numbers, we no longer mandate this, even though we still recommend it. And as I mentioned, we still have 137 out of 249, meaning 55% of embryos here. Therefore, the expectation is that these patients who were transferred still have half, at least, of their pregnancy chance in our freezers. I don't have the time to go into details, but this is one of 2 slides that summarizes in our manuscript the PGT-A diagnosis and then the pregnancy karyotype is confirmed either after birth or through CVS or through amniocentesis. And they were very frequently corresponding when we had miscarriages, for example. But they were obviously discrepant when healthy babies were born, and this is the second half of that pregnancy list. So in conclusion, there is really no better evidence, in our opinion here at CHR, for why PGT-A should not be used than the birth of healthy babies after their embryos were declared ready for disposal. There is no better evidence. Imagine if those patients had disposed their embryos. They would not have experienced those pregnancies and those live births. And in our opinion, that is not only unethical, but it simply doesn't make any sense. And therefore, what this little introduction to Mia's talk, I think, represents is pretty convincing evidence that if those embryos already have been created and have been tested as abnormal, don't discard them. Don't keep them in the freezer. Start transferring them. You will be surprised how many pregnancies and live birth you can still get out of them. And secondly, the value of PGT-A as a diagnostic test obviously appears further diminished. That is my introduction. And now to the main part of our session. It is my pleasure to introduce Mia, who will be talking to you about some of the basic science work in artificial embryos and in true blastocyst stage embryos, and will present to you, I think, convincing evidence that embryos have an amazing capacity to self-correct themselves, as has been previously reported in mice. The same or a very similar mechanism exists in human embryos, and this at least partially explains why we have success with transfer of such embryos. Thank you very much.
First, I want to thank Dr. Glasher for his very nice introduction, and also I want to thank the Committee of Ovarian Club for this invitation. And today I'm just going to present to you our work in self-correction of mosaicism in both human embryos and our gastroloid system. So gastroloid is the development model we developed from human embryonic stem cell to recapitulate the first few cell lineage and differentiation in embryogenesis. And we think it's a great model for us to study the aneuploidy cell fate. So what is aneuploidy? So aneuploidy is a chromosome aberration. So basically the cell will have either extra chromosome numbers or missing chromosome numbers. And the aneuploidy is often caused by chromosome missegregation during either meiosis or mitosis. So when as you can see in this figure, if missegregation happens during the cell cycle, the daughter cell will end up have the abnormal chromosome numbers. And if the missegregation happens during the first few lineage of embryo development, this will cause the embryo to become mosaic embryos, which means the embryos will have both the normal euploid cells and also the aneuploid abnormal cells. And as a matter of fact, mosaicism is actually very common in human embryo development. A systematic study shows among the more than 800 embryos they analyzed, 73% of those embryos are mosaic embryos. As you know, in clinical setting, the biopsy sample is often used to test the aneuploidy status, and the aneuploidy is often used as a criteria to differentiate the embryo quality, and often aneuploidy cell embryos will not be transferred. However, if you see the embryo here, this is day 6 embryos with the lineage staining with all those lineage markers. And those very bright dots in the middle, they represent the inner cell mass of the embryo. As you can see, inner cell mass only take up a small portion of the embryo, and the rest of those cells are trabectoderm cells. And since the trabectoderm cells are the majority of the blastomeres in those embryos, so can really the aneuploidy status of the trabectoderm represent the whole embryo? And nobody has done any cell lineage specific behavior analysis of those aneuploidy cells. That's why we want to see what's going to happen to those aneuploidy cells if they differentiate into the different cell lineage. And since it's almost impossible to study the aneuploidy cell fate in human embryos due to the ethical issue, so it's very difficult to know what's really happened. And there's a study in mouse from Magdalena's group from Cambridge. They used the mouse as a model to study aneuploidy cell fate. So basically, in this study, they used this drug named reversing to treat the blastomeres of the mouse embryo. So this drug is a metatic kinase inhibitor. Basically, this drug will inactivate the spindle assembling checkpoint of the cell. So after treatment, the blastomere will turn into aneuploidy state. So basically, in this study, they found those blastomeres which turn into aneuploidy, they show much higher apoptosis rate than the normal blastomere. And this apoptosis rate is even higher in the trifactoderm lineage. And they also made this mosaic embryo by combining the both aneuploidy blastomere and euploid blastomere together to make a chimera embryos, and then found the pure aneuploidy embryo can develop to blastocyst. However, they won't develop to term after they implant this aneuploidy embryo to the recipient female mice. However, if they mix the aneuploid blastomere with normal euploid blastomere, this often will develop to term and give rise to an offspring normal mice. So to me, this is very amazing study. They kind of recapitulate what really happened to our observation in clinical setting. Like Dr. Glasher said, we have successfully achieved the live birth after transferring the mosaic embryos. So we want to use our gastroloid model to study what really happened in human development, since the mice cannot be a perfect model for human, because mosaicism and aneuploidy in human early development is very specific phenomenon that didn't happen in mouse. So in our laboratory, we developed this gastroloid model using the human embryonic stem cell. So basically, we use this technology of micropattern chip. So we see the cells on the micropattern, as you can see here. So we found out the confinement of geometry itself can be enough to trigger the self-organization of those cells. So basically, after the BMP4 treatment, so BMP4 is a key regulator of the first differentiation, first cell lineage and early differentiation of human embryo. So we see after the treatment of BMP4, those micropattern cells are differentiated into the inner circle are the SOX2 positive ectoderm layer, and then the out layer out of the SOX2 circles are the brachyury positive mesosome layer. And on the very edge, we can see the GATA3, which is the extra-embryonic marker expressed on those outer layer, meaning those cells are the trifactoderm-like cells. So this model is actually very highly quantitative due to this confined geometry. Therefore, we can easily use some computer programming to detect the gene expression of those cell lineage markers in a spatial temporal way. So we think this is a perfect model for us to study the aneuploidy cell fate. So basically what we did is, first we need to generate a population of aneuploidy cells. So we used the same drug that was used in the mouse study. So this drug is reversing. So we treat the human embryonic stem cell, human ES cells with the reversing. And after 48 hours of the treatment, 95% of those cells turn into the aneuploidy cells. And then we want to see if those cells are still keeping the pluripotency characteristic. Are they still the human embryonic stem cell? So For confirming that, we see the cell on the micropattern for 48 hours under the pluripotent median culture. And as you can see, for both the control untreated cell and also the treated aneuploidy cell, both pluripotent marker was on. You can see the MANOC and OCT4 were on for both control and treated micropattern. And then we want to see how the cells, how healthy are those cells. That's why we also stain those cells with the apoptosis marker. As you can see, the Cas3, which is the cell death marker, they were not elevated in the treated micropattern. However, if you look at the P53 markers, which is the cell damage, DNA damage marker, you can see the reversing treated aneuploidy cell, they expressed higher level of the P53. So overall, this indicates those converted aneuploidy ES cells, they seem under a certain amount of stress. However, those stress are not significant enough to cause the cell death and apoptosis in those cells. And they still show the pluripotent markers, which means they still keep the pluripotent characteristics, which make them a perfect cell population to study for this study. So then we want to see how these cells behave if we're trying to use them to form the micropattern, to form the gastroloid model. So basically, as you can see on the left side of in the left panel, those are the control untreated cells. So after the 48 hours of BMP4 induction, they form this beautiful pattern of all the lineage marker, as you can see the upper panel of this left side. And you can see the GATA3 TE markers on, and the brachyury markers is on, and also the ectoderm markers on. And the lower panel are the DABI staining. However, if you look at this reversing treated micropattern, if we see exactly the same amount of cells before the BMP treatment and after 48 hours of the treatment, they seems like they cannot form the ectoderm and brachyury layer in the middle, which are the embryonic fate. However, the trifactoderm cell fate, the extra-embryonic cell fate, doesn't seem to be affected. So first of all, we thought this might be just a density issue, because the aneuploidy cells don't grow as well as euploidy cells. Maybe the low cell density caused the disruption of tight junction, which can cause the similar phenotype. So in order to eliminate this possibility, we see double amount of the cell number for the micropattern, and we still see the same phenotype as the original experiments. And at this point, we are more confirmed that the aneuploidy cells are preferentially differentiated into the trifactoderm cell lineage, and they lost the ability to form the embryonic tissue fate in this gastroloid model. So, and then we want to see how the aneuploidy behave after or if they took on certain lineage. So in order to do that, we treat the micropattern with BMP4 in the meantime with reversing. So the rationale behind this experiment is the BMP4 will instantly trigger the differentiation of this micropattern. However, reversing will take the whole cell cycle to convert the cell to aneuploidy state. Therefore, we can now use this model to see how the aneuploidy cell behave after they adopt certain cell lineage fate. So what happened is, after 48 hours, as you can see in this micropattern, the pattern still form. You can still see the three lineage, the trifactoderm, mesoderm, and ectoderm. However, as you can see in the center part, the size of the ectoderm SOX2 area is smaller than the control one. However, the trifactoderm-like cells doesn't seem to be affected. And if you look at the Debye staining on the lower panel, you can see there are a lot of debris and fragmentation going on in the middle part of the gastruloid model. So this basically telling us there are a lot of cell death or apoptosis going on in those middle part of the gastruloid where the embryonic tissue is supposed to lay. So to confirm the apoptosis, we use the apoptosis marker to stain the gastruloid. As you can see here, the cell death marker Cas3 seems very condensed in the middle part of the gastruloid where the embryonic tissue is supposed to lay. However, the P53 is universally on the gastruloid model. This basically telling us the no matter the aneuploidy cell took on different lineage fate, they all seems very under certain kind of stress. However, only the embryonic tissue cell fate goes through active apoptosis in our model. So to confirm the aneuploidy cell death is caused by apoptosis in our model, we use this drug ZVAD, which is the inhibitor for apoptosis, to treat the gastruloid in the meantime of the BMP treatment and reversing treatment. As you can see, by inhibiting the apoptosis can rescue the pattern of our gastruloid, which means the cell was eliminated through apoptosis in the early differentiation of human embryo. And now we are confirmed that apoptosis is happening in those aneuploidy cells, and we want to see if this apoptosis is differentiation dependent. So in order to do that, we study we use these experiments. Basically, we see the aneuploidy cell on the micropattern, and then we either treat them with BMP4 or without BMP4. So with BMP4, this will start the differentiation. As you can see at the end of the 48 hours, all those cells turn into the trifactoderm-like cells. However, for the patterns without BMP4 treatment, they're still staying pluripotent. And we counted the cells after 48 hours of treatment, and then we found after 48 hours, the one treated with BMP4 has significantly lower cell numbers than the one without treating with BMP4. And as you can see, the Cas3 yellow marker is higher in the lower panel with BMP4 treatment. So this all indicates that this apoptosis of aneuploidy cells is in a differentiate dependent manner. And we also did this experiment where we put so we use two reporter lines. So green line is the euploid cells, and the pink line is the aneuploid reporter cell. And as you can see, we see the cells in both together in the micropattern, and we start the 48 hours of treatment with BMP4 and without BMP4. And so at the end of the experiment, there are still a huge chunk of cell left in the micropattern without the BMP treatment. However, in the micropattern with BMP4 treatment, almost all the pink cells, which are the aneuploidy cells, are gone after 48 hours. So this also indicates this apoptosis of aneuploidy is BMP4 or differentiation dependent. And then we want to see if our model can be used to model the mosaicism of those cells in early development. In order to do that, we mix two populations of the cell. In order to differentiate the two populations of cell, we use the regular human ES cells and then a reporter human ES cells with some fluorescent tag. And as you can see, the control panel, which are the first two panels, those are we mixed two populations of cells, but both of those populations were not treated with riversine. So those are all euploid mycopattern, even with the mixture of two populations. As you can see, all the pattern looks perfectly the same, no matter what the ratio of two populations of the cells are. However, for our mixture study for aneuploidy mosaic gastruloid, we treat the pink reporter cells with riversine. So those pink cells are actually aneuploidy cells. And by mixing them together, we can see if we only have 25% of aneuploidy cells in the mixture gastruloid, the mycopatterns show exactly the same phenotype as the control one. And as you can see, the lower panel at the end of the study, the pink cells are only a small portion of the gastruloid. A lot of them has been eliminated during the 48 hours of differentiation. And when the aneuploidy took up to 50%, it still show a perfectly fine mycopattern gastruloid with all the three lineage markers. However, if you can see, if the aneuploidy cell took up to 75% of the cells, the pattern still has all the different lineage. However, the center part of SOX2 area shrink from the patterns has higher normal cells. So, but you can still see the formation of the pattern, which means even we have very low percentage of the normal cells, this can rescue the phenotype caused by the abnormal aneuploidy cells. And we quantified the cells of the leftover aneuploidy after the 48 hours of treatment, and we found the cells, most of those, the aneuploidy cells took on the trifactoderm lineage, and much less of them took on the SOX2 positive octoderm lineage. So to us, so this study, this mosaicism study just tell us the aneuploidy cells, as long as they have some euploidy cells in it, it can rescue the formation of gastruloid. And also we want to know what's really going on in human embryos. And we use those data from published several papers in where published the single-cell RNA-seq of the human embryo. So the first data we use is from this paper where they analyzed the single-cell RNA sequencing from embryos from day 3 to day 7. And the second set of data we use is from the single-cell RNA-seq data from human embryo from day 6 to day 14. So we use this method, basically the principle is we use the transcriptome to predict the aneuploidy status of the single cells. So basically, if the chromosome has more copy number in it, the transcriptome will show higher copy number of the transcripts in those chromosomes. So by analyzing the copy number, we can reflect the aneuploidy status, the chromosome status of those cells. So what we found by analyzing those two sets of data is we found the aneuploidy rates reduced significantly from day 3 to day 14 embryos from those real human embryo data. So taking this together, our data showed aneuploidy cells were preferentially eliminated in embryonic lineage, and we also showed the depletion of aneuploidy in mosaic gastruloids. And the human RNA-seq data show the prevalence of aneuploidy gradually declined during the early development. And then questions raised to if we should use the aneuploidy status of the trifactoderm lineage to predict the embryo quality the human the quality of the human embryo. So that's it for our study. And I would like to thank my mentor Ali Boivalu and also Dr. Norbert Glasher and all my colleagues in Center for Human Reproduction and Rockefeller University. And I'm happy to take any questions. Thank you.
Okay, thank you very much for allowing me to chair this session on luteal phase support on the various progesterone formulations. This is the Ovarian Club meeting. My name is Claus Yding Andersen from Copenhagen, and I'm very happy to introduce the different speakers we have 4 speakers on the panel today, and the first one will be Daniel Shapiro, and he will discuss the importance of IM progesterone. And as the second panelist, we do have David Frankfurter, also from the US. He is talking about vaginal progesterone. And Nikos Poulousas from Spain is talking about subcutaneous administration of progesterone. And then Shari Markens from Belgium, she will be talking about oral preparations of progesterone as a luteal phase support.
Good afternoon. My name is Daniel Shapiro. I am practicing in Atlanta, Georgia. I'm the medical director of RBA, and with Peter Naja and others, one of the co-founders of My Egg Bank North America, which is a frozen donor egg bank. I have agreed to present the case for intramuscular progesterone, and we'll talk a little bit about its origins and the clinical application in ART. So a few background observations first. Intramuscular and vaginal progesterone were the first clinically available formulations, but they didn't really have uptake until the 1940s and 50s, and quite honestly, nobody really knew what to do with them. So most of the early studies with the original progesterone formulations looked at what we now know to be irrelevant endpoints like serum level or a clearance rate or whether a biopsy is in phase or not. Part of the reason there were no clinical comparisons until the late 80s were because there was no obvious need for progesterone in reproductive medicine until we started using agonists and antagonists later in IVF stimulations. And we learned through that process that luteal support was necessary. Once we learned that, it became important to know which route was superior. And there was assumption at the beginning that intramuscular progesterone would be better because it provided higher serum levels, which I'll show you in a minute. I think most of you know what a Cochrane review is, and the data on the comparative data on progesterone is not very good. There are a handful of RCTs, they're the best of the bunch, but the Cochrane review basically says you can't clearly define anything regarding timing, route, or dose, because the studies, again, are so poor. So a quick timeline. 1672, let's go way back. Lorraine de Graaf described the corpus luteum in an autopsy specimen after a woman had died of a ruptured ectopic pregnancy, and that's how we get the name Graafian follicle as well. He didn't know what it made, but he found it curious that this was on the same side as the ruptured ectopic. It took another 200 years until we started understanding corpus luteal function, and most of the work on that was in Europe, actually. Progesterone was identified and isolated by George Corner and his partner William Allen, and then 5 years later the chemical structure was identified also in Germany. Pituitary function regulation of the progesterone secretion wasn't really understood until Ryan at Harvard Medical School started doing all of that work in the 1940s and 50s. And then it really wasn't until the age of IVF, and specifically IVF with agonist stimulation, that it was clear we needed progesterone supplementation in the luteal phase of those cycles. It took quite a while, even though vaginal progesterone had been around for some time, it took quite a while for it to be established as equivalent IM. And then a few other interesting things there. We now know there are membrane progesterone receptors, not just nuclear receptors. And there's now a paper that does seem to show a benefit with regard to first trimester miscarriage, just published, though the data is still quite questionable. So the very first comparison of IMP and vaginal, again, the endpoint was, we now know is irrelevant. It was serum level only, and the IM and the oral, I'm sorry, the vaginal and the rectal gave similar levels, but the IM was much higher, 4 times higher than either. Paul DeVroy has published several papers on progesterone replacement, both in overectomized, I can't say that word, and ovariectomized, there we go, as well as in ART. His endpoints were whether a biopsy was in phase or not, and he showed that oral was not acceptable using that endpoint. It's still not an endpoint looking at pregnancy rates. A student, or I think a fellow of DeVroy's, published on this and was able, on the endometrium, and was able to show that vaginal actually mimicked histology better than IMP, and might therefore be a better choice. The Bourgain paper also showed the differences in mean serum concentrations between the oral, the vaginal, and the injectable, and you can see the IMP is much higher. Here a pregnancy rate is reported IMP versus a vaginal, and it actually appears that the vaginal, those very small series, a bit better. His conclusions basically are what we're talking about now. Serum levels do not correlate with clinical outcome, and endometrial histology probably doesn't correlate either, but there are differences in the histology between the formulations. So why might it be that you get so much lower serum levels with the oral and the vaginal? And it has to do with first pass kinetics, basically. When you inject, you absorb directly into venous circulation, and you bypass the liver on the first round, and so the levels are going to be higher than if you have conjugated steroids in the mix. Nevertheless, even though the levels in serum vary, what happens in the uterus is actually a little bit different. There are ways to measure the progesterone content of the tissue itself, and sure enough, this is a list of references that show this, that endometrial tissue concentrations are actually higher with vaginal, despite the fact that IMP provides the higher serum level. Natural cycles were controls in this paper, and the conclusion was that you get higher endometrial P4 with the non-injectable, the vaginal method. And this shows the difference in tissue level in nanograms per milligram of protein. You see, natural cycle, the tissue level progesterone is really not that high. And with IMP, it's about 5 times as much. Vaginal is much, much higher, much higher. In each of these cases in the Miles paper, the endometrium was quote unquote in phase. This is a paper from a gentleman named Ciccinelli. It was only 7 patients in each arm. It was a comparison of one of the commercial forms of vaginal progesterone against IMP. And then these women underwent hysterectomy after administration. And he basically confirms what the Miles paper shows. The solid dots are vaginal administration, and the open circles are IM. And you can see that the endometrium, the nanograms per milligram of protein tissue concentration, is higher with the vaginal, even though the serum is higher with the IM. And this is the graphic demonstration of that from the Ciccinelli paper. Sam Chantillis showed the benefit of vaginal progesterone versus IMP. Again, this was not a superior finding. It was not. It was non. If I could speak English, it wasn't different. There was no statistical difference in the two, and this was an argument for the less uncomfortable formulation, being the vaginal. And then this is our paper from 2014. This was a consecutive series of blast transfers, elective single embryo blast transfers. It was retrospective. It was a mixture of donor recipients using frozen embryos and autologous patients using frozen embryos. One of the flaws in the paper, actually. But it was actually a very clean comparison, and we had effectively identical live birth rates with the IM and the vaginal. And so I've got to make the case for progesterone IM. If vaginal and IM progesterone yield similar outcomes, why would anyone pick the painful injection? And the answer is, at least in the US, which is the world's largest market for this, it may not be pain in the tuchus, as we like to say, but it's a pain in the wallet to use the vaginal in the US. It's also either BID or TID dosing with a cost that ranges between about $36 per day compared to IMP, which is just once a day dosing and is far less expensive. And so unfortunately is the only clear benefit to IM progesterone, but in a cost-conscious medical system, a lot of patients will pick IMP specifically for these two reasons. And so in conclusion, IMP gives you a higher serum progesterone level, but that's clinically irrelevant when you compare it to oral or vaginal. And the levels do not correlate to pregnancy outcome or endometrial histology directly. Vaginal and IM are not equivalent with regard to the amount of progesterone that reaches the target site in the endometrium, but most of the RCTs, in fact all of them, show no difference in pregnancy rate. And so without a clear clinical benefit to intramuscular progesterone, the reasons to use it are simply cost and less frequent dosing. And so that's the case for IMP. Thank you very much.
Hello, everybody. I'm David Frankfurter, the Reproductive Endocrinology and Infertility Division Head at the George Washington University in Washington, D.C. I wanted to thank Dr. Shaham for the opportunity to participate in today's luteal phase support event for the Ovarian Club. This is truly an honor. I'll be presenting on the benefits of vaginal progesterone for luteal support in assisted reproduction. So my objectives for this session are to describe the benefits of vaginal progesterone and to define the limits of luteal phase support using vaginal progesterone. I wanted to start by presenting the basis, the physiologic basis for the use of vaginal progesterone in ART. It's not simply a serum absorption and transport process, as many believe. Investigators have demonstrated that there is actually selective uptake of vaginal progesterone by the uterus. Letty et al. In a very elegant in vitro with a perfusion model, within roughly 4 hours of vaginally applied progesterone, tissue uptake can be seen in a cervical to fundal direction, and uptake is actually more pronounced during the luteal or secretory phase of the cycle. This process has actually been referred to as a first pass effect or a first pass uterine effect. This begs the question as to why such a capability exists, in that it's unlikely that 7 million years of evolution intended for the vaginal delivery of exogenous progesterone, that we have come to be with this process solely so that a tablet or a gel or something can be placed in the vagina and be absorbed. Keeping in mind that Homo sapiens has been on the planet for about 1 million years, well predating the discovery of progesterone by Willard Allen in the 1930s, and the application of the marker degradation process for mass production of progesterone in the following decade, and ultimately with the marketing of oral contraceptives and micronized progesterone in the decades to come, there must be some physiologic reason for this first pass phenomenon. So we have fixated over time in terms of what happens from the perspective of serum levels of hormones during the menstrual cycle. When you look at intraperitoneal concentrations of progesterone relative to either peripheral vasculature or what you can see in the circulatory system of the contralateral ovary, you see several orders of magnitude higher progesterone levels in the peritoneal fluid than what's observed in the serum. And this actually can be better visualized if you superimpose concentrations in the peritoneal cavity relative to the serum with the histogram representing the peritoneum and the line curve representing the serum. You can see that there's an astronomically high level of progesterone in the peritoneal cavity. Now, we need to keep in mind that vaginal progesterone has to relate to ART in some manner. We know that controlled ovarian hyperstimulation affects the luteal phase. We know that there's an enhancement in the negative feedback that's observed during the IVF process. And the end result is the potential for an implantation defect and inadequate endometrial support during the course of IVF. When you look at how the stimulated cycle looks from the perspective of the luteal phase, you can see that it's notably shorter than the natural luteal phase, and there's a more dramatic peak and decline in progesterone levels following COH. Therefore, supporting the luteal phase is intended to increase the potential of both pregnancy and to reduce the chance of abortion. And with these in mind, there are several options for manners in which you can support the luteal phase, from using injectable HCG or GnRH support versus progesterone. And I'm going to focus specifically on the latter, primarily vaginal progesterone. And so the question then becomes whether progesterone is necessary at all. And in brief, there are numerous reports, including a meta-analysis, that support the need for luteal support in IVF, in assisted reproduction, when compared to placebo. You can see that there's clearly a benefit, and historically we've observed that there's a benefit when it comes to providing progesterone for luteal support during IVF. And in the case of progesterone, we know that it can be supplied either orally, vaginally, or intramuscularly, and it appears rather clear that PO support for the luteal phase is inadequate. And so the focus here is going to be on IM versus vaginal, with the benefits and pitfalls of vaginal progesterone being the focus. So as far as what to give, does it matter whether we're looking at a fresh IVF cycle or a frozen embryo transfer? Again, the intention is to maximize pregnancy rates and minimize abortion rates. At the same time, we need to pay attention to patient tolerance and convenience. And this is where the conundrum comes from. So going back to this representation of progesterone levels, both intraperitoneally and and within the serum, one can observe that we have very, very high levels of intraperitoneal progesterone levels during the course of a natural cycle. And vaginal progesterone is intended to take care of or take advantage of this first pass effect. And it, in some ways, actually mimics what physiologically the uterus should be seeing if the intention of the system was to allow this high concentrated intraperitoneal progesterone to directly be absorbed within the uterus, ultimately influencing the endometrium, pregnancy, implantation, and ongoing pregnancy likelihood, or sustenance, so to speak. In the mid-1990s, Miles et al. Described what was seen as very high tissue levels of progesterone when supplied vaginally. Conversely, it's been shown that serum levels after vaginal application isn't very high, and that it stands to reason that the counterpoint is true when it comes to intramuscular progesterone, that you see relatively high serum levels, but nowhere near as high tissue levels. And so when you look at meta-analysis, what you see is in fresh IVF cycles, there doesn't appear to be a preferential route, that given that there's still some corpus lutea activity, that no matter what you do, it appears to be very, very similar, whether it's intramuscular or per vagina. Shapiro et al. Showed that it doesn't matter as well what type of vaginal preparation is used, whether it's a gel or a tablet, the outcomes appear favorable, and the outcomes are comparable to what's seen with IM progesterone. Now, when you look from the patient's perspective, it's not surprising that the vaginal route is preferred over the intramuscular route. The former is far more convenient. It is clearly less painful, albeit that it has possibly an annoying discharge. This pales in comparison to the anxiety that's produced and the discomfort that's seen with intramuscular progesterone administration. And so from the standpoint of fresh IVF cycles with embryo transfers, it appears that there's a patient preference benefit to intravaginal progesterone application. Question also should involve cost, and there's no question that IM progesterone is the cheapest form of progesterone supplementation. That being said, on a relative basis to what IVF costs, at least in the United States, the cost for luteal support is far less than the IVF cycle in general. And so when it comes to fresh IVF cycles, it can be said that IVF alters the luteal phase, that we can say that there appear to be no differences in outcomes based on the route of administration. And while more costly, vaginal application appears to be preferred by patients. So let's shift gears a little bit and look at this from the perspective of the frozen embryo transfer cycle. And I just want to start and very briefly mention that if we're talking about natural cycle FETs, it really doesn't seem to matter. The data appear to be very consistent with what's seen in fresh IVF transfers. So whether you use IM progesterone to supplement in the luteal phase versus PV versus any progesterone at all, depending on the type of natural cycle that's undertaken, it probably doesn't matter. So what we're going to focus on really are the program cycles. And does the mode or route of administration of progesterone for luteal support make a difference, and is luteal support needed? Well, I think that it's pretty intuitive that if you're programming the cycle and there's no corpus luteum, that we need to give progesterone. The question then becomes by what manner? We're left with a rather mixed bag of studies, despite the fact that there's a meta-analysis that says that there really isn't much difference between one mode and the other. The data are very, very limited, relegated to a handful of studies, many of which revolve around natural cycles. So just to provide the two different arguments from the multiple observation studies that have been reported, Berg et al. In 2013 found a significant difference in ongoing pregnancy rates when one was using vaginal progesterone as opposed to vaginal and intramuscular combination. Conversely, Shapiro et al. Saw no differences in outcomes whether vaginal or IM was used in vitrified thawed embryo transfer cycles at the blastocyst stage. What's interesting is we have one randomized controlled trial that looked at this very question, the SUSTAIN trial, which was published in 2018. This was a randomized clinical trial involving 3 arms: vaginal progesterone, intramuscular progesterone, and combined vaginal progesterone with intramuscular progesterone every 3 days. Enrollment in this study was stopped when it was noted that one arm was inferior to the other 2 with regards to ongoing pregnancy rates. When the blinding was removed, it was noted that it was the vaginal arm, the vaginal without intramuscular progesterone arm, that had lower ongoing pregnancy rates. And so the conclusions of the authors was that vaginal progesterone plus IM every 3rd day provides a viable, effective alternative to IM progesterone, meaning that vaginal progesterone by itself was inadequate to support the luteal phase. Now, despite being the only randomized clinical trial looking at this question, it's been criticized because of the dosing and the frequency of progesterone use, that maybe this in a relative sense led to a diminished estrogen effect or progesterone effect. And what we know from the pharmacodynamics of intravaginal progesterone is that BID dosing isn't actually 2/3 of TID dosing, in that when you look, especially early in the luteal phase, you see that TID dosing actually more than doubles the concentration of progesterone. So it is possible that the findings of the SUSTAIN trial weren't simply a function of the route of administration, but also were confounded by the dosing. An additional question that came from the trial was related to the fact that the day of embryo transfer was different in the IM only group, making it unclear as to whether or not variability given dosing and day of transfer also influenced the outcomes. That being said, whether we're doing frozen embryo transfers or fresh IVF, patients still find the vaginal route less painful, less anxiety provoking, and more convenient. And so it is important to take the patient desires into consideration. And obviously patients are most interested in being pregnant, but with the paucity of data, it's still not clear what the cost benefit is in frozen embryo transfers using IM progesterone versus vaginal. In conclusion, when it comes to frozen embryo transfer cycles, the luteal phase clearly needs to be simulated and done so pharmacologically. Clearly, the use of progesterone is mandatory, and while there may be some conflicting data on the outcomes as far as vaginal versus IM, at the very most, if we're going to use an IM form, every 3 days appears to be sufficient, and it's still unclear whether or not IM is truly superior, though the RCTs to date seem to support that. Finally, patient convenience and pain is important to consider, as is cost. Again, I would like to thank the Ovarian Club for giving me the opportunity to present today.
So good morning, good afternoon, good evening, ladies and gentlemen. My name is Nicholas Polizos, and I'm actually the head of the Reproductive Medicine Department at Excelsior University Hospital. I would like to thank you all for taking in this webinar, and I would like, of course, to thank the Ovarian Club for inviting me and Zev Soham for the kind invitation. And I will talk about a subject which is controversial, which is something that we don't know, or we know a lot, or we might think we know a lot, and it's about progesterone. progesterone supplementation in our patients that are undergoing IVF fixing. And we will talk about various progesterone formulations, and I will try to talk about the subcutaneous preparation. And it's really crazy to me to say that we have a whole session about progesterone in ovarian club. But maybe it's very important. And why is it important? Because we use it, because we need it. And when do we need it? Almost every time that we start the cycle, either if it's a fresh IVF or ICSI cycle, or of course, if it's a frozen embryo transfer cycle. Progesterone always is there, and we like to use it. Why? Because we have a luteal phase defect. So this is where we are, a whole session on progesterone. The need of progesterone is clear in the majority of our cycles, but we have different options. And what are the options? We can use vaginal capsules or pills. We can use vaginal gel. We can use intramuscular injections, which we don't care sometimes, but the patients feel pain. We can use new subcutaneous injections. Why? Because our patients are used to subcutaneous injections during stimulation, or came recently the oral preparation, which you will hear also this time. But the question is, which is the best and why do you use one of them? But before going to which is the best, if there is something which is the best, I would like to talk to you about the differences. Because all these different formulations and different routes of administration have distinct profile. What do we have to take into account? Daily doses. We have multiple, single, triple. We have different blood concentration. We have some blood concentration with the vaginal preparations, high blood concentration with the intramuscular, high with the subcutaneous, and zero with the oral. We cannot measure it in the blood. We have different absorption, conditional formulation with the gel and the caps, individual variability, and unpredictable with discharge, unconditioned with intramuscular and subcutaneous, unknown with the oral. We cannot measure it in the blood. Side effects. The vast majority seems to be well accepted by our population, but we have the intramuscular that has pain, and the patients do not want it at all. And of course, we're talking about comfort and preferences. We are used to using vaginal preparation and seems to dominate the market at this point, but we have less comfort with intramuscular injections in patients' preference. We seem to have very good comfort with subcutaneous, and of course oral because you're using oral. But finally, you have approval. Yes, no. For example, the oral preparation, despite the huge literature that is coming, it's not approved everywhere. We know very well that not all the competent authorities give approval. And of course, we have some voices coming about safety. So in any case, we have all this group of medication preparations. What difference does it make? Because for me, to use it in my patients, I need to see the difference. The difference in terms of efficacy, the difference in terms of preference and side effects, because I want less side effects. And of course, if we can modernize our treatment to go to a personalized approach, an approach which is tailored to our patients. And we'll go one by one to this aspect, starting from efficacy. Why do I need progesterone in a ovarian stimulation cycle? Because there is a difference. We're talking about a hyperstimulated cycle and a normal cycle here, that they have a luteal phase gap. Significantly lower progesterone concentrations. Why is this? Because of the supraphysiological estradiol levels, because of the aspiration of the granulosa cells from the follicles during oocyte retrieval, but also because of the suppression that we do to prevent the late surge. We result in premature luteolysis and we don't have so much progesterone. So, does it matter which of them I use? Well, if we see in the literature, we will see that almost in all routes, intramuscular, oral, subcutaneous, and vaginal, it's not clear with the rectal, when we use progesterone, we have significantly higher pregnancy rates compared to control group. Progesterone is needed. But which progesterone is needed? Because if we see in this meta-analysis published back in 2015, we will see that intramuscular, vaginal, rectal, there is not such a big difference. It seems to be more or less similar, maybe slightly higher, but huge heterogeneity on the trials. When we compare vaginal versus rectal, no difference in pregnancy rates. And when we compare subcutaneous versus vaginal, gel or vaginal pills, again, we're talking about exactly the same pregnancy rates. Oral came in the market, and you will hear from the next speaker that there have been studies showing non-inferiority compared to vaginal gel or compared to vaginal capsules. But again, I would highlight, although there have been safety regarding the safety of this progesterone that has been used, and probably you will hear it from the next speaker. But when we're talking about frozen embryo transfer cycle, this is different. In fresh embryo transfer cycles, everything appears to be the same. But in frozen embryo transfer cycle, we have a completely different reason of luteal phase defect. And what is this? We don't have corporal luteum. And this beautiful corpus luteum is important. Why is it important? Because it's a transit ovarian gland during luteal phase and early pregnancy. And what does it do? It produces hormones. And mainly, it produces progesterone at high levels, which appear to be important for the pregnancy. And we try to realize how important is this progesterone for maintaining pregnancy, especially in frozen embryo transfer cycles, where we don't have corporal luteum. We have to see this experiment back in 1973, where after laparoscopy, corporal luteum had been cut out, luteectomy. And what we have seen is that when the progesterone levels drop after luteectomy, what is the result? Abortion. When the progesterone levels start to drop, but increase and maintain high, we maintain the pregnancy and we have a revolutive pregnancy. And there appears to be a critical moment at 7 weeks, since luteectomy before 7 weeks can lead to miscarriage, whereas later it's not a problem. But if we supplement with progesterone when we do a luteectomy before 7 weeks, then the pregnancies continue. So is it the same if we use all these different preparations or not? And I will go to you in a beautiful study, randomized controlled trial published from the United States in 2018, in which compared vaginal preparation only, intramuscular preparation only daily, and a combination of intramuscular and vaginal every day and intramuscular every 3 days. What they have seen is that when you use only vaginal, you have a higher percentage of abortions. You have a lower pregnancy rate and a lower live birth rate. Has there been criticism in this study? Yes, it has been. Why is the reason? Because of the lower dose of vaginal capsules that have been used, which apparently might not represent the market. But in the end, what we need to realize is that maybe in this frozen embryo transfer cycle, it's not only the progesterone itself with the way that we give it that plays a role, but possibly the serum progesterone levels, which can be a way to individualize the treatment in the future. And this is what we will try to see in the last part of the presentation. So, having said this, I will go to the second part, which is the preference and the side effects. And because I'm talking about the subcutaneous preparation, we'll try to see if this is future, a present, something that we can use it in the end for everyday clinical practice, and if the patient like it. And the reason I'm telling you is that we're used to using vaginal progesterone, and this is true. Intramuscular hurts, we know that. We're not going to argue about the value of intramuscular, but we will argue about the pain that it creates. And then you have oral that apparently the pill seems to be good, although we are missing data regarding safety, although we need further studies, and we need to see if it works in the frozen embryo transfer cycles. This is important because we don't have data. But when we compare vaginal progesterone with subcutaneous, what we will see is that it seems that it works well. Although we have higher injection site reactions, we have less vaginal reactions, less breast pain and fatigue, and of course, on the other side, when we compare to vaginal pills, vaginal gel, we will see that, again, we're talking about a higher skin subcutaneous disorders, but less diarrhea, less reproductive system and breast disorders, and of course, less vaginal discharge, which can be important for many patients because they don't like the discharge, or at least many of them they don't like. Secondly, genital tract infections from the 2 randomized trials that have been published, you will see that although there is not a significant difference, you will see that the total number of events, infections and manifestations from the genital tract is double, 6-14, 7-15, when you're using the vaginal preparation compared to the subcutaneous. So yes, there is an advantage there. But what we take into account most is what our patients say to us. And what do the patients say to us regarding comfort? We will see that from one of the studies, it appeared that the percentage of patients that were feeling comfortable or very comfortable with the vaginal compared to the subcutaneous preparation was equivalent or even higher in the comfortable group, suggesting that this can be an option for the future, especially if we're talking about patients that are used to giving subcutaneous injection during their stimulation cycle. In terms of comfort, we have further evidence in which we have seen that in women that they have used subcutaneous and vaginal preparations, it seems that there is a very high comfort level and preference levels when we're talking about administrations per day, interference in daily work activity, loss of medicine, and of course about feeling dirty or interference in the relationships, the sexual relations with the patients. On the other hand, when a randomized trial has been presented in ASRM back in 2017, in which women have used both treatment, surprisingly 74% of them have supported the subcutaneous form, which is really promising and important. And for me, what is even more important is this study published back in 2018, in which it has shown that when you use vaginal progesterone, you have a rather high, which is the B, satisfaction rate, which is 44.9% with the vaginal form. And you see that the variant, the rather convenient part of the patient that they're using subcutaneous after vaginal, 49, 53%, and it seems to increase by the days. The expectations that they had were lower, and it seems that the subcutaneous form is really well accepted and is bringing satisfaction to all our patients. So we have seen that efficacy works in fresh cycles or preparations. In artificial cycles, maybe it would be different, but what difference does this make? And is this the opportunity and not a problem for us? And what could be the opportunity to build up, to try to do a personalized treatment? Because this is the future of medicine, and this is the future of reproductive medicine, and this can be the future of luteal phase support. And why am I telling you this? Because an individualized luteal phase support based on progesterone levels before frozen embryo transfer could be the future. Why could it be the future? Because we have evidence. And what does the evidence say? That progesterone plays a role. If we see all of these trials that have been published over the years, we will see that, excluding one in 2015, that's telling us that the high progesterone levels result in lower live birth rates, the vast majority of them, all the others, clearly demonstrate that when you have high progesterone levels, you have higher live birth rates or pregnancy rates in your patient. What is the problem of this literature? The differences. It's a mosaic, it's a babel of different doses, different levels, and different days of measurement of progesterone. 20 nanograms fifth day, less than 20 nanograms second day, 22 to 31 sixth day, 11 nanograms 9 to 11 days. So all this babel, all this mosaic of different measurements and timings needs to be clarified, although there is a clear trend that progesterone levels before frozen embryo transfer play a role. And why and how much do we need? It depends on when we measure. Day of embryo transfer, after embryo transfer, or before embryo transfer. If you ask me, I would vote for before. Why? Because I had the option to intervene. I had the option to intervene and do an individualized approach. But the evidence is there. The evidence is there about the day of embryo transfer. Elena Labarda has published in 2017 a beautiful study saying to us that when you have low progesterone levels in your blood sampling the day of embryo transfer, you have 32 as compared to 52% chances of of ongoing pregnancy, and this is highly statistically significant. Other studies came and tried to evaluate 9 to 11 days post-embryo transfer. And what they have seen by Birgit Alsberg, that again the same. Ongoing pregnancy rates are significantly lower when you have low progesterone levels the day after embryo transfer, 9 to 11 days, a day of HCG measurement in the blood in the patients. So again, showing that progesterone plays a role. And this was again highly significant after adjusting for confounding factor. And finally, our group in Dexeus, we published 2 studies, one in 2018, measuring 1 day before embryo transfer, time that we could intervene, the progesterone levels, and we have seen that when the progesterone is low, less than 10.64 compared to more than 10.64, although you have identical pregnancy rates, what is the problem? Pregnancy losses. Miscarriage rates from 9.5 in the normal group goes to 26.6, and we're talking about euploid embryos that are genetically normal, and a significantly lower percentage of live birth rates in women that they had low progesterone levels in their blood levels. And this has been also verified, validated by a second study that we have done, in which we have seen the same linear association between progesterone levels and pregnancy rates. Either when you use PGT-A cycles or no PGT-A cycles, you see that the live birth rates increases with the level of progesterone in the blood. So where are we? When to measure and how much is the threshold? I would say it's the same. 1 day before day of embryo transfer or even after, we have similar patterns, which is around the level of 10. It can be 10.6, 9.2, 11, but I think 10 is where you have to, and this is in line with the pharmacokinetics. But if we're talking about pharmacokinetics, we need to realize that if we want to individualize, and if we're thinking about the future, we need to think of pharmacokinetics. We cannot forget it. And what pharmacokinetics says is that when I administer vaginal preparations, capsules or gel, my maximum levels in the blood seems to be around 10. They're not exceeding. Vaginas cannot absorb all the progesterone, and if you go to very high doses, you will not so high. So while you supplement during your patients, some of them might not reach so high. On the other hand, you have the oral, which we say again that we still don't have approval in every side of the world. But again, what about the blood? Maximum levels, undetectable. This is a study published back in 1980, shows that the progesterone levels in women in the luteal phase, that they are controlled, nothing, taking nothing, or the progesterone are exactly the same. So you cannot measure your testosterone in the blood, and how can you individualize if you don't measure? Maybe not. Maybe you can't. But when we think of pharmacokinetics, we have to think and see what's happening with the injectables. Intramuscular, the bad guy, which hurts, and the subcutaneous, which appears to be a better guy. Why? Because it doesn't hurt so much and it brings comfort. Where the maximum levels reach 100 nanograms per ml. So you shoot one dose and it seems that your progesterone increases. And then we have to think about this beautiful corpus luteum, where it doesn't exist in our frozen embryo transfer cycles. And this beautiful study by example, which if you don't have high progesterone levels, you will lead to an abortion. So thinking of this, individualize the luteal phase support, the luteal phase of our patients. And this is a study that we completed. This is a prospective study in which we included almost 600 patients that they were going a frozen embryo transfer cycle under hormonal replacement treatment of embryos that they had been generated from PGT-A cycles, and they were embryos that they were genetically normal. Among these patients, a good proportion, the vast majority, or the majority of them, around 60% had normal values. So progesterone was good. With vaginal preparation, you had very good results. But 41%, and this is not negligible, they had low progesterone levels. What we did is we supplemented. We started subcutaneous administration of 25 milligrams per day. We gave subcutaneous injections of progesterone, and we tried to see how many they will maintain high levels. And we have seen that the vast majority, more than 95%, 222 patients, had very high levels. And we tried to see what are the results from the frozen embryo transfer in this population. While we have seen before that our study in the past has demonstrated that these women with low levels have very high miscarriage rates. So here are the results. Surprisingly good. What it shows is that your pregnancy rates, either when you supplement in the low-level patients or in the patients that they have good levels, your pregnancy rates are very high. Ongoing pregnancy rates, equally high, even slightly better, not significantly, but equally high, and miscarriage rates low. What does it say to me? That if you supplement with your injectable subcutaneous injections in these women that they have low levels, yes, you can save your pregnancy, yes, you can reduce your miscarriage rates, and yes, you can have an individualized luteal phase support, which is the future of luteal phase support from my point of view. To conclude, and sorry for taking more time, I think we have so many drugs, so many different preparations in our arsenal of drugs. Different routes of administration are good, but we have to realize that in terms of efficacy in the first IVF cycles, they are all the same, whatever you use. Yes, indeed, this has been proven. On the other hand, we have a new subcutaneous progesterone regimen, which appears to be well tolerated. It demonstrates comfort for patient administration, and it can be a good alternative. Why? Because in frozen embryo transfer cycles, it seems that progesterone levels are associated with treatment success. Low progesterone, low pregnancy rates. Low progesterone is not uncommon. We have seen it in 40% of our cycles after vaginal supplementation. So what does it say to me? You can use your vaginal form or you can use a subcutaneous form, but many of the cycles, they will need an addition of subcutaneous progesterone in the frozen embryo transfer cycles because this appears to demonstrate excellent pregnancy rates. And for me, this is a window to the future. What is the future? Individualize our luteal phase support according to the level of progesterone, which may indeed be the future for managing the luteal phase defect, which apparently is greater, is much profound in the women that they are undergoing frozen embryo transfer cycles. Thank you so much for your attention, and thank you for the invitation to give this lecture.
I'm Shari Mackens from Brussels, and I will be the one going with you through the oral administration route for luteal phase support. These are my conflicts of interest, and this is an overview of the items that we have to discuss together. So a short intro on the luteal phase support in general, but I guess that the speakers that came just before me already introduced you to the general concepts, so we can do this very quickly. Then we have to go a little bit more into detail into the differences between the natural and the synthetic progesterone, the dydrogesterone, which is the form that we can use as an oral compound. Then we have to go and have a look at the efficacy of the product. So when we use an oral luteal phase support for fresh embryo transfer, what are the results in the studies that have been performed? And the same goes for the frozen embryo transfer. As a last item, of course, very important, the safety profile, and then I will go to some final remarks. This is what we all know, that when we stimulate the ovaries, that afterwards the luteal phase is hampered. When you look at the progesterone levels, you see that they rise very quickly, but that then at the end of the luteal phase, there seems to be a deficiency. And also from a clinical point of view, we know from the meta-analysis of van der Linden in 2015 that the luteal phase support is needed after ovarian stimulation. So although there is a consensus on to use luteal phase support, we do not have a consensus on which product to use and when to start and for how long to administer the product. So in this meta-analysis, we had 45 randomized controlled trials, many women, many patients included, but there were no different odds ratios between the different formulations of progesterone to administer. This is a worldwide web-based questionnaire from 2014 where you see how it actually goes in clinic. And you see that the vaginal forms are used a lot. And then the oral route was in 2014 only used in 2% of the cases. And this is quite odd, definitely when you look at it from a patient point of view, because if you are the patient standing on this crossroad, and if you have to choose between vaginal administration, injections, or a simple oral compound, a pill to take, from a patient's point of view, this seems like a very logic choice, because the oral compound, of course, is not painful. There's no injection. It is easy to administer. You do not have the vaginal side effects from the vaginal formulations, maybe culturally better accepted. And this is very important because, of course, the better we can offer the patient comfort, the better the compliance will be. And the cost efficiency of the oral luteal phase support is also very important. So in the next slides, I will try to convince you on the advantages, and of course, therefore, we need to dive a little bit deeper into the differences between the progesterone formulations. So let's look at the natural progesterones versus the synthetic progesterones. However, I immediately want to mention that maybe the use of the word natural progesterone is not that adequate in this context. Better to use is the bioidentical progesterone, because whether it is the natural form or the dydrogesterone, both are processed and coming from the yam root via the chemical process of the marker degradation. So both of them have the same starting point. And then on the next slide, you see where the difference starts. So for the bioidentical progesterones, there is a micronization to increase the bioavailability. However, when these bioidentical progesterones are used via the oral route, there is the first hepatic pause effect, which really decreases the bioavailability of the product and which increases the more general systemic side effects. When you look at the synthetic progesterone, by using light processing, we arrive to this additional double bond between the carbon 6 and 7, which gives the molecule a little bit of a curved form. And this is the dydrogesterone molecule, which by doing this process and by the curved form increases the bioavailability of the product, which then, of course, leads to much lower doses that can be used in clinic when you compare them to the other forms. So better bioavailability, lower dose, less side effects. Now we have to go and have a look at the efficiency of the product. We have to dive into the studies that have proven that they work as good as since a long time at a high prevalence. So we have two very nice and very large randomized controlled trials. The first one published by Herman Tourné in Human Reproduction in 2017. The second one published by George Griesinger, also Human Reproduction 2018. So both of them were multi-center, randomized, controlled phase 3 trials. Both of them including a very high patient number, more than 1,000 patients in each study. This was the Lotus study program. So in the Lotus 1 study, 30 milligrams of oral dydrogesterone was compared with the micronized vaginal capsules at a dosage of 600 milligrams. And in the Lotus 2 study, the comparison was made with the vaginal gel at 90 milligrams once daily. These are the results of both studies. So you see the main outcomes of the cycle, of the study cycles. You see the pregnancy rate at 4 weeks, 8 weeks, 12 weeks for both studies. And then, of course, most important, the live birth rates. And what you see in this figure, when you look at the figure, or when you look at the confidence intervals, is that both studies robustly demonstrated a non-inferiority of dihydrogesterone compared to the two other forms of luteal phase support. This is an upcoming paper. It will be published very, very soon online and in PLOS ONE. And in this study, the team of George Griesinger combines the individual participant data from the LOTUS studies together with previous studies. So it's a combination of an IPD and an aggregate data meta-analysis. And very interestingly, when you take all of the available evidence of today together, it seems to favor the use of dihydrogesterone for luteal phase support after fresh embryo transfer. Now let's go to the frozen embryo transfer, because we see a shift in daily clinical practice from fresh to frozen. Definitely for the future, we also have to know whether the dihydrogesterone molecule works as good in frozen embryo transfer cycles. And then what is most important to have a look at are, of course, the hormonal replacement therapy cycles, because there we have no corpus luteum. So the only progesterone available to install the pregnancy and to support the pregnancy is the exogenous administration. This is an overview of what is available today. You see that there is one limited sample size, RCT from 2017, in which dihydrogesterone alone gave a less performant outcome. However, only 20 milligrams of dihydrogesterone was used. All of the other studies, which is one pilot RCT and then two retrospective data sets in which a higher dose was used, 30 milligrams, 40 milligrams in these two. In that case, no significant difference was seen in between the groups. This week, just very recently, also this paper came out, another retrospective data set showing no difference between the oral dihydrogesterone administration and the micronized vaginal progesterone in frozen embryo transfer cycles, whether they were natural cycles or artificially prepared cycles. So we have some evidence available which seems to be very reassuring. But of course, what we need are nice RCTs in the future. So let's keep calm and randomize also for the frozen embryo transfer cycles. Very interesting, in these frozen embryo transfer cycles for HRT are the growing concerns on the higher prevalence of pregnancy complications, more specifically hypertension and preeclampsia. So this is an overview of all studies expressing these concerns. As point of view, we have to mention that in an artificial cycle, there is no corpus luteum, so there is no endogenous progesterone, but there is also all of these other molecules secreted by the corpus luteum are also lacking. And one of the hypotheses is that the absence of the corpus luteum and the absence of these molecules, that this really has an important role on the invasion of the spiral arteries and on the progression and the development of preeclampsia. And in this context, dihydrogesterone might be a very interesting molecule to look at because of the immunomodulatory effects of the progesterone. So in animal models, it has been shown that the molecule of dihydrogesterone has these additional immune functions. And so we have to look in the future whether this could maybe help to decrease the prevalence and the incidence of the obstetrical complications after frozen embryo transfer cycles. This gives me a chance to introduce to you a future prospect of the dihydrogesterone molecule. This is the DIDRA study. It's a study that we are performing at this moment in Brussels, in which we would like to learn more on the immunomodulation effects of the molecule and on the molecular effects on the endometrium. So here you see the study design. Actually, we have asked 30 oocyte donors to donate, to stimulate 2 times, and to, after the oocyte retrieval, continue with a luteal phase support in 1 cycle with a micronized vaginal progesterone, and then in the counter cycle with the oral dihydrogesterone. So this is a randomized, double-blind, double-dummy crossover study in which we would like to learn more on the immune cells in the blood, the immune cells in the endometrium, the pharmacokinetic profile of both molecules, the impacts on the vaginal microbiome, and the impacts on the molecular functions of the endometrium. So these are upcoming data which we are really looking forward to, which should become available in 2021. Last important item to discuss is the safety profile of dihydrogesterone, but we can really be sure of the fact that the large data sets that we have available, that they have robustly shown the safety of the molecule. Dihydrogesterone has been used for a very long time in other settings than the ART setting for progesterone deficiency. There are large data sets confirming the safety. And so also the LOTUS program and the IPD, they have shown exactly the same. So no significant impact of this treatment on the incidence of congenital and genetic disorders. In the LOTUS program, where about 800 babies were born, there was no difference between the progesterone formulations. So we can definitely state that it is safe to prescribe dihydrogesterone to your patient, and the long-term follow-up of the molecule is, of course, assured and awaited. Final remarks on the oral luteal phase support route with dihydrogesterone. We can state that it is safe and as efficient for fresh embryo transfer. The molecule is approved now for luteal phase support in the Netherlands since 2017, and following the Netherlands in more than 60 countries today. It is at low cost, it is well tolerated, and it gives the patient a high comfort. Future research is needed to determine the optimal dose and the efficiency in frozen embryo transfer cycles, and it will be very nice to see whether there would be an additional advantage of the potential immunomodulatory effects of dihydrogesterone. What is also important to state today is that the current serum progesterone assays do not pick up dihydrogesterone or its active metabolites. So in the context of a personalized luteal phase support, which is gaining more and more ground in our daily clinical practice, it will require the development of an accurate assay to also measure dihydrogesterone if you want to individualize the treatment for our patients. I thank you for your attention.
So hello, my name is Klaus Yding Andersen, and I'm going to give you a very short presentation on some of the effects of the mid-cycle surge of gonadotrophins when we administer 6,500 units of recombinant HCG for final maturation of oracles. we have now, for the first time, gathered very detailed information from a larger group of women undergoing ovarian stimulation. And we have now worked together with Lan from Vietnam, and she has collected 160 women who followed a standard antagonist protocol, and all women underwent a freeze-all for various reasons. This meant that none of these women received any kind of exogenous progesterone or luteal phase support at all, but they were followed after the HCG. They were followed 0, 12, 24, and 36 hours ovulation trigger, and then daily during the next 6 days. So this is now a large number of women and a relatively detailed evaluation of how their luteal phase came out. So what you see here is the HCG concentrations compared to the natural cycle. So the natural cycle is the average of 3 independent studies on LH during the natural menstrual cycle, and the HCG depicts the concentrations which occur after 6,500 units of HCG. And what you do see here, then of course on the x-axis you see times after injection. So you can see that the HCG concentration then shoots up very, very rapidly after injection. We actually have a peak at around 24 weeks, hours, and this now is substantially higher. And what you do see is that the area under the curve for the LH activity is tremendously high. So we have a factor of at least 5 between HCG and what you see natural menstrual cycle. This, of course, has an enormous effect on progesterone. And what you do see here is the natural menstrual cycle. So this is what we get to around 40 nanomolar or 35, 40 nanomolar after OPU plus 6. This is where it peaks. The interesting thing here is now to follow what happens after the HCG trigger. You have a small peak at 24 hours, then a little dip, and then it just continues up. And here we see a maximum. And this is now 4 days, OPU plus 4. This is where maximum occurs. And then we start to have a steady decline. What we hope is always to obtain a concentration of progesterone at the peak, which is more than 40 nanomolar, because this is what we normally see in a natural menstrual cycle. But actually, there is a few under. And this is probably the reason why we provide such a hefty stimulus with HCG. That is because there is some women down here, and in order for one dose to fit all, you actually have to provide such a huge number of so much HCG. But it peaks at day 4. If we look at the next slide, this is very busy. This is HCG concentration and the progesterone concentration mean, the median here, mean and median. And as you can see, we actually have concentrations over here of progesterone, which if you look at the median, then it do not reach quite the levels that we want it to reach. And you can see that here we have very high levels of progesterone, of HCG. The interesting part, of course, is to see what happens here at the end. So you have this dual effect that we have super physiological, super high levels of HCG in the first part, and then it declines and falls off 9 units, 5 units, 2.8 units, OPU plus 6. And obviously we expect implantation to occur around mid-luteal phase on OPU plus 6, but here there is hardly any push for progesterone. Still high levels of progesterone, but this is what is hanging in the system. And if we look at these two graphs combined, we can actually see here's the HCG, here's the progesterone coming up, and this is the 95% confidence interval. But it's interesting to notice that here on day 4, where progesterone peaks, we actually have an average concentration of HCG of just 9. So there is a huge overshooting with the HCG, and therefore it starts to decline here. if we look at what happens at the end of the effect of the HCG surge, and then assume that a physiological concentration of LA-HCG is around 5 units per liter, then it actually do come out that on average the median level of HCG at OPU plus 4 is 8.2, day 5 4.6, day 6 2.4. This means that 17, 59, and 89% are actually experiencing sub-physiological concentrations of LH-like activity on these different days. So we have a massive effect of HCG early on, and then too little as we approach the time of implantation. And if you also start to look at when the patients actually have their peak concentration, this is also very interesting. You see here that it do turn out that a little less than 20% of the women do appear to have a progesterone concentration that peaks either on OPU plus 2 or OPU plus 3. And then it starts to decline towards day 6. And then you can see OPU plus 4, 39%. 20 plus 39, that is almost 60%, already have had a peak before OPU plus 5. So it's conceivable that we advance the endometrium a lot, since it's decreasing from here on. And you can see that it actually decreases by 58% in this group, 55 here, and 48. So this is on day 5 to day 6, half of the progesterone disappears, which of course is a very different picture of what we envision for the progesterone concentration as it's supposed to peak on day 6. What does this massive fall in progesterone mean to the endometrium? We don't know that yet. In my optic, it actually opens up the luteal phase once again. There's a lot of information that we don't know. What is the pregnancy potential of women, of those 20% which peak already on day 2? What is the potential from these? Are the pregnancy rates here declining because the endometrium is simply too advanced? Or how does it come out? Is it the maximal concentration of progesterone that has an effect? If this occurs already on day 4, what impact does the concentration of day 6 then have? We don't know that. So there's a lot of open questions coming up. And I think the conclusion from our studies is that the HCG actually on 3 or 4 different levels is causing unphysiological circumstances for implantation and reproductive outcome. The progesterone arises very fast after the injection, a lot faster than the natural menstrual mid-cycle surge. What impact does this have on the endometrium? The peak concentration of progesterone is advanced at least 2 days. Almost 20% of the patients experience a max concentration 2 or 3 days after OP, which is very fast and may not provide optimal chance for implantation. And it do turn out that the peak concentration is 10 times higher after brain stimulation as compared to the normal cycle, but with an enormous range. So as some women, for whatever reason, they all receive 6,500 units, but some of them don't respond very well. And some of them are very high responders. Obviously, this is also related to the number of follicles which are sitting in there, but it is providing a very, very large range of responses, and we don't know the effect of this. And it do turn out that when the peak of progesterone is happening either on day 2, 3, 4, 5, then there is a massive reduction in progesterone circulating until day 6. Around 50% of the progesterone disappears. If it disappears fast from day 5 to 6, is this worse than if progesterone disappears from day 3 to day 6? Completely unknown. So this huge, extensive variation between patients, I think that this very much calls for individualized approaches. And I think that we, during this session, have seen that we can provide exogenous progesterone to eliminate some of the effects that the HCG, some of the variability seen with the HCG administration, and this may then be one way of compensating these women to secure a sufficiently good progesterone concentration. But which preparation and which individualized approach is, in my opinion, still open for interpretation. Thank you.
I would like to welcome all of you to this session of the Ovarian Club, and it is my pleasure to introduce the next speaker, Professor Michael Greenberg. Professor Greenberg is an obstetrician gynecologist specializing in reproductive medicine and is currently the head of the Department for Reproductive Medicine and Fertility Preservation at the University Hospital Antoine Becler, Clamart, France. His research interests include the assessment of ovarian follicular status and the regulation of anti-Mullerian hormone, which were the topics of his PhD. Over the past years, he has expanded his research into the field of oncofertility and recently became president of the French Society of Oncofertility. He's also a member of the Reproductive Endocrinology Special Interest Group of the ESHRE. And Professor Greenberg, along with his colleagues, have published over 150 peer-reviewed articles. The topic of his lecture will be IVM, present and future indications for medically assisted reproduction and fertility preservation. This topic has been studied in depth by Professor Greenberg and his team, who have also published extensively in this field their original and very innovative findings. So, Professor Greenberg, you are welcome to present.
Thank you, Ariel. This is a great pleasure for me to be with you today. And as previously said, so my topic will be to discuss with you the role of IVM in reproductive medicine and in fertility preservation, the current status, and the future. So first of all, I would like to share with you some data on IVM, and just to tell you that IVM is not a new technique. Indeed, it has been studied initially during the 30s, especially in mammalian, and it has been studied by Gregory Pincus in 1935. And then we had to wait for a long time until the first pregnancy reported in 1983 by Lucinda Vick in New York City. But it has been, the pregnancy has been obtained from IVM of oocytes rescued from IVF cycle, namely oocytes that had failed to mature following ovarian stimulation. And between these immature oocytes, some of them have been matured in vitro and led to live birth. Then, with the first pregnancy of IVM following IVM in an oocyte recipient in 1991, and in 1994, the first pregnancy following IVM in PCOS patients, which has been probably one of the most reported indication for IVM during the following years. So what could be the indication of IVM? So first of all, probably the PCOS are the best patient, or the most studied patient having been studied with IVM. And then it has been also proposed to patients with history of OHSS, to patients having contraindication to ovarian stimulation, for egg donation as well, to try to limit the administration of exogenous gonadotropins, and also in pro-responders to ovarian stimulation. Today, we can consider that we have more than 6,000 babies born following IVM worldwide. So this is not bad, but probably not that much according to, if we consider that this technique has been developed during the 90s. What about the babies born following IVM? As you can see on this slide, you can see that there is no increase in congenital abnormalities in babies born following IVM when compared to babies born following IVF or ICSI. So we have large amount of data having shown that these babies are definitely normal at birth and during their development. But you all know, and probably all of you have heard, that IVM led to very poor results. This is probably true if we consider that IVM has mostly been developed and offered in patients not having that good indication, and probably this suboptimal indication led to these poor results. As an example, we have many reports came from teams having tried IVM in patients with deficient oocyte maturation following ovarian stimulation. So when nothing works for enabling good ovarian oocyte maturation, then they've tried to move to IVM. But this is probably not a good indication due to the poor oocyte capacity to mature naturally or following ovarian stimulation and even following IVM. And this bad oocyte quality and bad oocyte competence is not possible to increase by any technique. So, and IVM as well. So IVM to success in this indication. So probably the best indication for IVM is presented by patients suffering from PCOS. Initially, it has been proposed in this group of patients. We have to remember that initially, when it has been offered in these patients with plenty of follicles, antral follicles within their ovaries, and therefore at high risk of ovarian hyperstimulation syndrome, we have to keep in mind that these patients didn't have the possibility to be initially triggered with GnRH agonist due to the only existence of agonist protocol. And then, due to the probably lower oocyte competence of oocyte coming from IVM, and the development of antagonist protocol with the possibility of avoiding ovarian hyperstimulation syndrome with the possibility of triggering with GnRH agonist, then most of us go to ovarian stimulation and leave IVM for only a small groups who are still interested in the technique. As you can see in this on this slide, this is the first paper published by Qian in the end of the 90s in PCOS patients and the results of with IVM. And you can see that this the success rates were not that bad in this group of patients, with 40% of clinical pregnancy rates, but only in 25 cycles, and as you can see, with more or less 3 embryo transferred within the uterus. And in the end, 40% of clinical pregnancy. This was the first report. And then, following a couple of years and couple of papers published in this field in IVF in PCOS patients, we can see that in this study reported by Gremo et al. From Oxford Group, you can see when they compared IVF and IVM in PCOS patients, you can see that the implantation rates were definitely lower in IVM, in patient having undergone IVM, probably due to the poor oocyte, the lower oocyte competence of this oocyte matured in vitro. Then the Belgian group from Michel de Vos reported better success rate with IVM, they still offered in PCOS patient IVM with a different technique when compared to the basic IVM. The basic IVM consists in the retrieval of small antral follicle without any priming before, no FSH administration, no estradiol administration, and for some groups, following just a trigger shot with HCG. And then the maturation occurred within the lab in specific media during 24 to 48 hours, and oocyte having reached maturity can be fertilized, and then if we have embryo could be transferred within the uterus. For the Belgian team, in PCOS patients, they prime their cycle with FSH, with relatively high doses of FSH, 225 IUs of FSH during 5 days, and then without any trigger shot, they retrieve immature eggs and then mature them in vitro. In this group of patients, they were able to observe that probably the low success rates following IVM were due to impaired endometrium. Indeed, the serum estradiol amount following this protocol remain probably insufficient to prime the endometrium, leading to not only a problem of oocyte competence, but the poor results probably came also from an impaired endometrium. And they observed that when they were able to perform a freeze-all strategy in these IVM patients, so following IVM, embryos obtained were frozen and then transferred on the subsequent cycle following an hormonal substitutive treatment. And they were able to observe that the success rate following IVM in this freeze-all strategy was definitely better. And they concluded that probably the problem not only came from the oocyte competence, which should not be that bad, but probably the main problem came from the endometrium. The same groups recently observed that the results were not the same according to the PCOS phenotype. And probably the best group of patients suffering from PCOS, the best candidate for IVM, could be those with hyperandrogenia, dysovulation, and an important number of small antral follicle within the uterus. Indeed, when they focused on patients with only hyperandrogenia or only an over follicular excess, then the success rate following IVM were not that good, and probably in these two subgroup of patients, ovarian stimulation could be better. But you can see in the patient with the full PCOS phenotype, hyperandrogenia, ovarian follicular excess, and ovarian dysovulation, they were able to have accumulated live birth rates per started cycle of 40%, which is not that bad. Another interesting group of patients who could be good candidate, who could be probably the best candidate for IVM, are patients suffering from ovarian resistance to FSH. Indeed, in this group of patients, ovarian stimulation is not possible. These patients fail to respond to even very, very high amounts of exogenous FSH. And we had the case, and we reported the first pregnancy in this subtype of patient. The patient was referred to my center for egg donation with very high serum level of FSH and LH, but we were very when we had a look at the antral follicle count and the serum AMH level, unexpectedly they were within the normal range, despite very high FSH and LH serum level. So we tried in this patient to perform a stimulation trial, which failed as probably expected. And then we discussed the possibility of performing a retrieval of immature oocyte from these small enterals, these 23 small enterals which were visible within the ovaries. And unexpectedly, the maturation rate was extremely good, and leading to many embryos. And this patient has now 3 kids, three healthy kids. She delivered 3 times following only IVM. So it probably, and following this report, we and other groups reported different relatively good success rate in these patients with ovarian resistance to FSH. Another important field of development of IVM is probably fertility preservation. Indeed, probably the best indication for IVM now is ovarian resistance to FSH. It is also possible in some PCOS patients. And then, as I told you before, with the development of antagonists and the possibility of frisol following GnRH agonist trigger, most of teams decided to stop their IVM program to continue to manage PCOS patients with ovarian stimulation. The success rates are better. And then with the development of fertility preservation and especially oncofertility, we decided to think about a new life for IVM. And indeed, if we consider IVM do not require any ovarian stimulation, do not lead to an increase in serum estradiol level, and require no time for having the possibility to recover some eggs. And then we thought that in some oncologic patients, when stimulation is not feasible, when estradiol level should remain within normal ranges, and when the situation is extremely urgent, then IVM could be an option for this patient. IVM in this indication is probably a bit different when compared to PCOS patients. Indeed, as you can see here on the slide, the ovarian of these patients are not endowed with many antral follicles. These are normal patients, not PCOS, without any follicular excess. And then the retrieval is probably not as easy as in PCOS patients. And this is a follicle here, which measure between 1 and 3 millimeters in diameter. And just behind the ovary, you can see the vessels just behind. And these black images are not follicle, but vessels. And so in this indication, probably the learning curve is a little bit higher when compared to retrieval performed in PCOS patients because of the risk of vascular lesions. You can see this here. So the images is the size of this follicle is more or less 5 millimeter in diameter, and you can see the retrieval here of these small antral follicles. So the zoom is relatively important, and you can see between these 2 points it's only 1 centimeter. So these follicles are measuring between 2 and 4 millimeters in diameter. So what could be the indication for fertility preservation? Breast cancer, especially when the patient should require neoadjuvant chemotherapy. We have some data in this patient following ovarian stimulation, but safety data in these patients having to undergo stimulation with a tumor which is still in place are very scarce, and and we do not know exactly if we're safe when we stimulate this patient with a tumor which is still present within the breast. We know that following before adjuvant chemotherapy, when the tumor has been removed, no problem for ovarian stimulation. But in neoadjuvant chemotherapy, we do not have any safety data. We do not have enough safety data to make sure that we are safe in this indication. Another indication could be endometrial cancer, granular cell tumor, which are a very specific tumor, which are responsive to FSH. And this is a problem because conversely to breast cancer and endometrial cancer, the problem is not serum level of estradiol, but the problem is FSH. So it's not possible most of the time to stimulate the patient with granular cell tumor because these tumoral cells are responsive to FSH. So in this indication, IVF could be a good option because we never use FSH before ovarian retrieval. Other indication could be urgent chemotherapy when we do not have time for ovarian stimulation. You know that stimulation lasts more or less 12 to 15 days, and in some oncologic situation, we do not have time for this. And the last indication for fertility preservation could be patient with ovarian resistance to FSH, which is more or less the same as the patient I presented you before, but we reported recently a patient with autoimmune premature ovarian insufficiency, and we know that in these autoimmune diseases, the first step before the follicular exhaustion, before this, it's, when we do not have any more follicle, nothing could be offered in this patient except egg donation, but the first step of this autoimmune disease is remarkable because there are still follicles within the ovaries with very high serum levels of FSH and LH. So some kind of ovarian resistance. So this could be a good indication as well for IVF. So we published and we demonstrated that IVM could be an option for urgent fertility preservation, which could be performed whatever the phase of the cycle. You can see the two groups here, follicular phase and luteal phase for immature oocyte retrieval. Patients were comparable in terms of age, BMI, and markers of the follicular ovarian status. And finally, with exactly similar number of oocytes recovered, same maturation rates, we were able to freeze between 6 and 7 mature oocytes following IVF. We did a study as well in BRCA patients, and we failed to see any difference in the number of oocytes recovered in patients mutated or not mutated. Because you know that we had there are some reports showing that this BRCA patient had and lower levels of serum AMH and number of antral follicle. So we decided to study the possible difference in the maturation rates between patients mutated or not, and we failed to see any difference. And same. No difference between patients with BRCA1 mutation or BRCA2 mutation. IVM is probably interesting also in hematologic diseases. In these patients, most often the treatment is relatively urgent. In Hodgkin lymphoma patients or non-Hodgkin lymphoma patients, we had some patients with impossibility to be stimulated due to an important mass within the thorax, and in these patients, it's not usually the chemotherapy is relatively urgent, and in this situation, IVM could be an option as well, and and you can see that in this group of patients, the number of immature oocytes recovered with the mean was 12, with a final number of IVM eggs frozen, which was 5. This is the patient I discussed with you before. The first pregnancy reported in a patient with having preserved fertility following IVM in case of immature autoimmune premature ovarian insufficiency. And you can see in this patient that the levels of FSH and LH were relatively important, with still antral follicle present within the ovary. This patient had was in amenorrhea, and we were able to recover eggs. And 2 months later, following the fertility preservation, there were no antral follicle visible within the ovary anymore. So the patient was definitely menopause. So what about the probably other option and the future scope of IVM? This is a Chinese paper published in Human Reproduction this year, and they proposed the possibility of performing IVM in patients having to undergo hysteroscopy or laparoscopy for benign gynecologic diseases. And different indication for surgery, which was for most of patients laparoscopy for hydrocyplinges, but also patients with ovarian cysts, and in this or for some uterine pathologies, and they performed IVM just in the same time as the surgery. So 158 cycle with more or less 2,000 immature oocytes recovered, a mean number of oocytes recovered of 14, and finally, following 47% of maturation rate, more or less 6 eggs matured in vitro, which could be frozen. So we did a study to have an idea about, because we know that the number of eggs frozen is probably the main indicator of a success rate. We know this very well from patients having undergone ovarian stimulation. We know that probably this patient need between 10 and 15 eggs to have relatively good chances of having a live birth. So we did a study in our oncologic patients to have an idea of what could be the threshold level of antral follicle count and AMH to be able to freeze 8, 10, or 15 IVM mature oocytes following IVM. And you can see that to have 10 eggs frozen following IVM, we need more or less 20 follicles visible within the ovary and 3.8 nanograms per ml of AMH. So relatively important values for these patients to have probably good chances with IVM, because we know that with 10 eggs, this patient probably have relatively good chances of having a live birth. So we're increasing the number of oocytes following IVM, but probably by doubling IVM. So you've heard about the dual stim, and we did the dual IVM as well. So in patients with no possibility of ovarian stimulation, we did a first cycle of IVM, and during and following a couple of days, which could be even 3 days later, we can perform another IVM cycle and even a third IVM cycle before the chemotherapy. If ovarian stimulation is still contraindicated, we have the possibility to accumulate the IVM cycle to try to enhance the number of IVM oocytes frozen. We did this study, which is now published, and you can see that following just one cycle of IVM, we were able to cryopreserve more or less 7 eggs, and when we double the cycle, we had in this group of patients 11 IVM oocyte cryopreserved. But probably the best way to increase the number of eggs is to combine 2 techniques of fertility preservation, IVM, either with following with transvaginal oocyte retrieval or during retrieval in the lab on the ovary which has been removed. Indeed, the combination of IVM plus ovarian tissue cryopreservation is probably a good option for all patients. I would say that ovarian tissue cryopreservation should not be done by itself. Why not additioning the possibility of performing IVM to try to be able to get some more eggs? Indeed, we know that in some patients in whom the ovary has been removed, in some patients the graft will not be feasible due to the risk of reintroduction of malignant cells. And probably in these patients, a good option could be the possibility of having immature eggs recovered and then frozen following IVM, because we know that when we have an egg, there is no risk of having any reintroduction of malignant cells. So I would say that when you do ovarian tissue cryopreservation, combine IVM either with transvaginal retrieval or retrieval in the lab. This strategy has been recently published by the Belgian group of Michel de Vos, and you can see that in 77 patients having been offered the combination of ovarian tissue cryopreservation plus IVM. So oocyte vitrification was performed in 64 patients with a mean of 7 eggs frozen following IVM. And some patients also have embryo vitrification, so only 13 patients. And in these patients, we had 2 embryos following IVM. And the Belgian group reports some pregnancies following this strategy. So the competence of this oocyte recovered in the lab at the time of ovarian tissue dissection before ovarian tissue cryopreservation is probably another option and may lead to pregnancies and live birth in these oncologic patients. At what age could we obtain immature oocyte? Actually, even in very young patients, you can see the age of this patient is 5. We are able to get eggs in the lab, whatever the age of the patient and whatever the disease, within the ovary at the time of the dissection. We can get some eggs, whatever the disease and whatever the age of the patient. But a recent paper showed that when these oocytes are recovered from girls before puberty, there were lower chances of reaching maturity for these oocytes. So in young girls or in adults, the maturation rates are probably better when compared to young girls before puberty. So the first pregnancy in oncofertility has been reported in 2014 following ex vivo IVM and embryo cryopreservation. And we reported the first live birth following IVM this year in an oncologic patient having undergone oocyte vitrification following IVM before breast cancer. The patient delivered a healthy baby in the beginning of the year. And it's always very strange for me, and even in this paper published in the New England Journal of Medicine about overall fertility preservation technique, there was no reference to IVM. It was a bit strange for me because IVM definitely could be an additional option for this patient, and probably an interesting option. We know that probably the competence of these eggs is not as good as that of eggs recovered following ovarian stimulation. We know that ovarian tissue could be an option, but with ovarian tissue, we only have yet at present 150 babies born. And please remember that the first pregnancy has been reported in 2004. So only 16 years later, only 150 babies. So this is probably not an optimal option of fertility preservation. So why not considering additional technique, and IVM could be interesting in this patient. So just before the end of this presentation, what could be the advantages of IVM for fertility preservation? It enables an oocyte and embryo preservation. It's available in emergency. There is no increase in serum estradiol level. There's a possibility of double IVM cycle, the possibility of combine it with ovarian tissue preservation. What are the drawbacks? No restoration of the endocrine function when compared to ovarian tissue preservation and graft. It's only available if we want to perform transvaginal retrieval. It could be performed only following the patients. Number of cells recovered is unpredictable, and the number of eggs following recovered and mature following IVM is probably reduced, and you had the possibility to see it was only between 6 and 7 in mean in this patient. What could be the future and how to improve this technique? There are still discussions on whether or not we should prime or cycle before the egg retrieval. Some are performing FSH priming, other FSH plus HCG priming, some others only HCG priming. And when I discuss with Michel DeVos say we do not have to prime the cycle with HCG because by this HCG priming, the different oocytes are at different stage of maturation, because some of these oocytes have the possibility to mature a little bit due to this HCG this HCG trigger shot, and then they prefer to have an overall indication about the true potential of IVM. They prefer working with only eggs in the same maturation stage. So I do not have the response about what could be the best protocol yet. I don't know. Some are working as well on culture media, which is extremely important, because we know that we have a lot huge job to try to improve the culture media for IVM. And there are some data coming from some groups, especially from Robert Gilchrist in Australia, who's studying a lot about how to improve the maturation rates, and they work a lot on biphasic IVM, which consists in a first impregnation of this oocyte within a specific media before the conventional media of IVM. And the last thing is is probably not the future, but is the present. With a freeze-hold strategy, we know that in this situation, the failure of IVM due to impaired endometrium could be avoided by freeze-hold strategy in this patient. So thank you for your attention, and Ariel, I can answer to your question now.
Well, thank you very much, Michael, for this excellent and very clear presentation. We're running out of time, so I will just ask you one question, but it is very important to my opinion. You have, regarding the safety of this technique, you have shown a slide in the beginning of the talk showing no increased risk for congenital malformation. But there have been concerns raised about epigenetic modifications such as DNA methylation or acetylation introduced by IVM. So where are we now regarding the risks of epigenetic modifications in IVM?
This is a good question, but actually we're still at the same point. Nothing has been demonstrated, and we do not have information regarding a possible risk. This is only at present theoretical, but in clinical practice, kids are fine without any problem, and we now have more than 6,000 babies born, and nothing has been reported yet in terms of epigenetic.
Okay, so I guess we will have to wait and see.
Yeah.
So thank you once again, and thank to all of you who have attended this session. Thank you.
You're welcome. Thank you.
So we'll move to the next presentation by Professor Carlos Simon. Professor Carlos Simon is a board certified and full professor of setting gynecology at the University of Valencia in Spain. He is a senior lecturer at the Harvard University, Boston, USA, adjunct professor at the Department of Obstetric Gynecology, Baylor College of Medicine in the United States, and head of the Scientific Advisory Board of iGenomics. He is author of more publications in international peer-reviewed journals. He will discuss with us today the genetics of the human endometrium. So Carlos, please go ahead.
Thank you. Thank you, Seth. For me, it's a pleasure to be here. And I would like to discuss with you this topic, which is my favorite topic, because I think that the endometrial factor, the maternal factor, is gaining now the attention of the scientific community, and it's very important to understand properly the genetics of the human endometrium to really understand reproduction and improve the way that we are doing things. So this is the spirit of this presentation, from the bench to the bedside. But before starting, I would like to send you my disclosure. And in addition of many duties that I have, what is relevant for this presentation is that I am the founder and head of the Scientific Advisory Board of iGenomics, which is a biotech company that is trying to work on this topic, which is the maternal factor, as well as others, from the bench to the translational part of it. So there will be some contents that it's also involving iGenomics. I just want you to know about that. And the main questions that I would like to raise prior to starting with that, there are basically two concepts. The first is that regardless of our big effort in the last 40 years, since the pioneers started the whole field of reproductive medicine, IRT remains inefficient, and we are all aware of that. The immense majority of IVF cycles fail, and the best metrics that we have, which is live birth, remains poorly still. 30-35% per initiated cycle, worldwide, and I'm referring to really big statistics from the big scientific societies in Europe and United States. And we know that the most fundamental reason because it fails is the gap that we have here between the transferring of the embryos and the implantation and pregnancy. And the gap here is being done by the poor knowledge of the endometrial factor and the poor personalized medicine that we are doing in this part of the whole reproductive process. Because I think that we all know that we are treating every patient in their way according to different metrics for stimulation, ovarian stimulation. We are just treating the embryos in a different ways as they manage. But once we are just arriving to transfer the embryo, every patient is the same. We transfer the embryo whenever the embryo is ready. So this is one of the concepts that is the basis, is the clinical basis of what we are doing on the endometrium. And the other big concept is that personalized medicine has been now penetrate every field in medicine. We know that variability is the law of life. We know that there are not two faces alike, not two bodies, and we are just, we know that oncology has been improved very much by learning this lesson. And the big challenge for us in reproductive medicine will be the transition from our world of generalized medicine based on population average towards precision medicine based on each person's individual biology. And that's the concept here. Just by acknowledging the fact that the greatest enemy of scientific practice of medicine is the practice of the routine. We should take advantage of the moment that we are living in science to be able to apply this knowledge to the clinical practice. And this is the main thing that we are doing on the endometrial factor today. And this is the black box. This is the black box where this step that I showed you in the first slide happened. And the reason why when we transfer the embryo, the live birth rate will be very poor. And the main reason is because this embryo has to go through a series of processes that composed by the position in which the endometrial microbiome is present, and the endometrium should deal with that. Then there is a maternal embryonic crosstalk. Then the embryo has to really attach to the endometrial epithelium, the luminal epithelium, in order to move forward in a specific window of implantation. And then the decidualization is critical in the invasion phase, and also some pregnancies will fail at this moment. All of this assuming that the embryo is chromosomally normal, of course. So this is the black box that we have been for a long time trying to understand, and this is the science that I would like to add on this black box. But prior to that, let's see what is the clinical question. The clinical question is that there is a window of opportunity for the embryo to implant. This window of opportunity is known for a long time and was demonstrated since the 90s by David Nabot in New York, in which using just natural cycle and embryos coming from ovum donation, he demonstrates that the transfer of embryos at specific days will just produce pregnancies. However, those embryos at different timing will never reach a baby here. And we know that once the patient just forget progesterone, or if we transfer the best embryo out of this window, it will never, it will not happen. So the point, and this is why menstruating species as the human exists, because the whole point of the menstrual cycle is to prepare this window of opportunity in order to get implantation. And we have tried to understand this window of opportunity first from the anatomical point of view and now the molecular point of view. This is the biological plausibility. We know that there is a specific transformation of this luminal epithelium, that it changes morphologically, the cytoskeleton changes, microvilli disappear, pilopods appear, and this epithelium remains that the possibility that the prophylactoderm cells will adhere to that. And we have been, again, trying to understand from the Noyes criteria that it didn't work to the ultrasound, that is the only thing that we are using now as anatomical medicine or phenotypic, trying to go for an objective molecular tool that allow us to understand the whole menstrual cycle now without possibility of subjective interpretation. And this is basically the point of what I'm going to mention. This is the only thing that we are using nowadays as anatomical medicine. It's nice to have a 7-8 millimeters triple layer endometrium, but this doesn't mean that this endometrium is receptive. You can have receptive endometrium with a 5 millimeter, and you can fail with this type of endometrium. So we are aware of that, and there are plenty of meta-analysis that has been demonstrating that. So let's try to figure it out another way to understand the whole menstrual cycle, which is the endometrial transcriptome, is to analyze the RNA that is transcribed at different moments of the menstrual cycle. We, as well as other colleagues, started the field 20 years ago. This is the group of Peter Rogers. This is our own publication. This is the work of Linda Judis. And with that, we try to put these Google glasses of transcriptomic regulation. Those are the genes that are transcribed up or down regulated at different moments of the menstrual cycle. And because of that, we just came out 9 years ago with the transcriptomic signature of endometrial receptivity, by which we try to understand the moment in which a specific patient, the window will be there and will be the personalized window of this patient. And we did that at that moment, analyzing the whole tissue, which means just from an endometrial biopsy, taking the whole tissue and being able to get a sample of genes, in this case 230 genes, that with a specific algorithm will let us know that at this moment the window will be open and will be ready. Since then, we have been trying to move forward to analyze this data, but now at the single cell transcriptomic levels. Single cell is changing now the way that the biology and the genetics is written. And there is an initiative, which is the Human Cell Atlas, that is transferring this information at the single cell level in any organ of the body. If you go to the Human Cell Atlas, you will see the amount of work worldwide. This is a huge consortium that is trying to get this information. And we have been also in charge of this from the human uterus, and we are having now a European project taking care of that. And this is just the initial work that we just recently published in collaboration with Steve Quake at the Stanford. The idea here was to take the endometrial biopsy. We just separate into fractions, stromal cells and epithelial cells, and then we just move to the fluidic system, that this is what we start to do from the beginning. And with this system, we are able to isolate cells, single cells here, and do the whole transcriptomics, which is basically the analysis of the 24,000 genes in a cell in a way that a cell is being treated like a patient. So in this case, we were able to analyze these 71,000 cells from 29 healthy ovum donors. And we did it with two different technologies. First, we start with fluidigm, analyzing the whole menstrual cycle, and then we did with 10x, which is another new technology that analyzing at the secretory endometrium. So with this data, what we learned is that we were able to identify the 6 different cell types present in the human endometrium, different cell types that they are just identified because they have a different transcriptomic expression here. And we are able to understand even the epithelium. We just identified epithelium and ciliated and unciliated epithelium. And within the epithelium, we are able to identify luminal and glandular epithelium. And this is just throughout the menstrual cycle. If we just concentrate on the secretory phase, you can see here how we can determine the existence. Each of these colors is composed by one dot. One dot is just one cell. So we are talking about here thousands of cells. We can differentiate between luminal and epithelial, luminal and glandular epithelium. We can identify endothelium, lymphocyte, macrophages, stromal fibroblasts. Here you can see the main genes that differentiate the different cell types. You can see here the numbers of cells, and even we analyze where in the cell cycle those cells are. Altogether, give us the knowledge of the different endometrial cell types first, and second, what is the pseudo time across the menstrual cycle? And we calculate that by trying to understand what is the proximity in terms of RNA at the different time, at the different moments of the menstrual cycle. For example, please see this panel with the stromal fibroblasts according to how close the transcriptomic signature evolved. You can see that there is from phase 1, 2, 3, 4, and the big discontinuity occurs here. 1 is the menstruation regenerative phase, 2 is proliferative, this is early and this is late, so this is quite logical. There is a very different transcriptomic signature from the stroma in the late luteal phase and now from the follicular phase. However, look at the epithelium. We call them unciliated to differentiate from ciliated. In the epithelium, the big discontinuity occurs between the early secretory and the late secretory. This is more different, those cells here, that the epithelium from the late secretory and the menstruation. So you can see that there is a big gap here which identify a different pattern of mRNA just from at the moment of the window of implantation. We separate the early versus the late. Altogether, this data demonstrate, you can see in this panel, that this is just the transcriptomic dynamics of the epithelium, just taking cell by cell in the endometrial epithelium. So you can see where is this discontinuity, indicating that those genes, they are getting turned on, whereas all of these are getting turned off. Here, turn off, turn on here, and the other and the opposite here. So there is the point of activation of the window of implantation is just right here in the epithelium, unlike in the stroma, that there is no such a big gap, and the decidualization process is more subtle in terms of starting RNAs or just disappear those RNAs. So in summary, from this data, what I can just bring you here is that in this Nature Medicine, we have demonstrated that there is 6 major endometrial cell types that can be identified by their specific RNA signature, that we have 4 major phases of endometrial transformation, and we can really describe the signature from the luminal and the glandular epithelium, and there is an abrupt transcriptomic opening of the window of implantation at the single cell level, whereas decidualization is initiated before the opening of the window, and is widespread in the stromal fibroblasts, preferentially starting in the endothelial cells of the spiral arteriole. So, and also, of course, in the luteal phase, we have provided evidence of direct interplay between stromal fibroblasts and lymphocytes during decidualization. All of these, they were ovum donors in natural cycles. So this paves the way just for the physiology of the genetics of the human endometrium. So this is basically the confirmation at the single cell level of the transcriptomic signature of endometrial receptivity that we described in the whole tissue. And what we have learned in the last 10 years by analyzing thousands of endometrial samples worldwide is that the window of implantation is about 30 hours long, and 70% of patients, this window is open after 5 days of progesterone administration, either endogenous or exogenous. However, in 30% of all your patients, the window will take longer to be open, 6 or 7 days, or will take less days, 4 or 3 days. And some patients with uterine malformations, the window will be narrow than we expected. We have seen windows of 20 hours or even 12 hours. And this is all about the progesterone receptor, the existence of polymorphism, of the existence of changes or different phenotypes like the progene phenotype that makes that this receptor, even with the same dosage of progesterone, will take longer to be activated. So because of that, we try to move the personalized medicine concept to the endometrial factor in the knowledge of the personalized window of receptivity. And that's why we came with the concept of personalized embryo transfer by knowing this in the patient that is going to be transferred the embryo. And we start the whole thing with the treatment of the most difficult patients, those with recurrent implantation failure of endometrial origin. The concept is quite straightforward. Instead of transferring the embryo only when the embryo is ready, do the transfer whenever the endometrium of this patient indicates that it's time to do it and the personalized window is there. So this was the main concept that we have tried to put forward. And to understand what is the clinical value of this, we have been trying to build up this pyramid of evidence-based medicine from case report, retrospective, prospective, and even randomized clinical trials. There is more than 25 publications done on this concept at different levels of this evidence-based medicine pyramid. And also there are independent retrospective studies that has been proved the same concept. And also there are some independent retrospective studies that they have not found a clinical improvement of personalized embryo transfer guided by ERA. And that's why we have been trying to do this study. This is a randomized clinical study, but now in patients at the first appointment, regardless of there is any endometrial, recurrent implantation failure. By doing this now in patients at the first appointment, trying to compare the three arms of the study will be the three different embryo transfer categories that we are having nowadays, which is the frozen, the fresh, and the introduction of the personalized embryo transfer. So this is the RCT protocol study. That includes IVF patients at their first appointment undergoing blastocyst transfer, either day 5 or day 6. They were randomized to any of these three arms. Personalized embryo transfer, in which all embryos are cryopreserved, the ERA is being done, and later on, the personalized embryo transfer is executed according to the timing indicated, according to the personalized window of the patient. The second arm is the frozen embryo transfer, in which all the embryos are cryopreserved, and then we let any center to transfer the embryos as they routinely do. And as you will see, frozen embryo transfer is not a single procedure. Different clinics in different parts of the world, they transfer the embryo either at day 4 of progesterone, day 5, day 6, or day even 7. So, because probably we are not paying attention to the endometrium, rather we just pay attention to the embryo. And they are doing this for different reasons, but again, if we consider the time that the embryo is transferred, frozen embryo transfer is not a single procedure, as it is the fresh embryo transfer, in which the embryo is just obtained and transferring back to the patient in the same cycle. But as you know, there will be patients with high estradiol, others with low estradiol. So again, it's a single procedure, but the patients, if we think this, it will be in a different situation. Primary objectives, live birth, cumulative live birth, secondary implantation and pregnancy rate, biochemical pregnancies, miscarriage, cost effectiveness, and neonatal outcomes. And this is just the pedigree of the registration of the study. This was the 16 active sites worldwide, and these were the selection criteria that we already mentioned, and also the paper is published, so you can go for that. This is the consort flow diagram, in which basically we have these 458 patients randomized. At the end, after these follow-up losses, we include this number of patients by intention to treat, and from this moment onwards, we lose those patients because different reasons, because non-compliance, because in some centers the embryo was transferred at different moment, or because there was a high progesterone at the moment of the ACT administration, or because the patients changed their mind and they changed from one arm of the study to the other. At the end of the day, we include this number of patients per protocol that they fully comply with the complete protocol. This is one of the weaknesses of our study, in which we plan for a 30% dropout of patients because of these reasons, and we end up with a 50% dropout. But at the end, we have those patients, and we give the results by intention to treat and also by per protocol, so everybody can make their own assumptions. This is the demographic and clinical characteristics of the patients at the baseline, with no differences among the different arms of the study. And this is the cycle characteristics and embryological data by ITT, in which there was no difference in terms of all the considerations that we made, except by the fact that in the group of personalized embryo transfer, it was diminished, the number of day 5 embryos, 69% versus 75 and 82 in the others. This was accounting just for an inferiority in the embryonic part of the personalized embryo transfer group. This is the reproductive outcomes by intention to treat, in which we found that there was a significant increase in cumulative pregnancy rate in personalized embryo transfer versus frozen and fresh, 93 versus 80% in both arms of the study. And these are the reproductive outcomes at the first embryo transfer and cumulative during 1 year follow-up per protocol analysis, in which we found that it was a significant increase in pregnancy rate, in implantation rate, live birth rate, cumulative pregnancy rate, and cumulative live birth rate in personalized embryo transfer versus frozen and fresh embryo transfer. Here you have the numbers in each of these different categories. Also, we investigate the obstetrical, delivery, and neonatal outcomes per protocol analysis. It was no difference in any arms of the study, considering all of these parameters that you have here. And finally, we did a cost effectiveness estimation per baby at home, considering the different cost figures that you are going through in each of the 3 different transfers systems that we are comparing in European Union currency, or USA, as you know, is more expensive than in Europe. At the end, the take-home message is that the most economic embryo transfer is the fresh embryo transfer. The most expensive is the frozen and personalized embryo transfer per baby at home at the first attempt. The cost is something in the middle between fresh and frozen. So the take-home message from this randomized clinical study from patients at the first appointment is that, and referring now per protocol, is that there is an increase in implantation rate in personalized embryo transfer versus frozen and fresh. There is an increase in pregnancy rate, and there is an increase in significant increase in cumulative pregnancy rate and the live birth rate was 13.8 percentual points versus frozen and 10 versus fresh. Since the study was powered to detect 15, we did not reach significance in this specific parameter here. And cumulative live birth rate was also significant in personalized, 15 and 22 versus frozen and fresh. And the point here that I want to make is that since we start this, there has been many other groups and companies that they have been creating the genetic test for endometrial receptivity. And for us, it's an honor to have been able to open this field by which now the scientific and clinical community is just considering also, is taking in consideration the endometrial factor to improve the results in assisted reproduction. And finally, I just would like to leave you with the concept, which is my particular view about the field, which is that IVF 1.0 is what our pioneers give it to us, which is the fact that we transfer embryos in the uterus. And the big challenge was to obtain oocytes to create the best embryos and to transfer them to the uterus. But I think that now, with the use of the scientific advances, we can transfer the embryos, first embryos without chromosomal issues, euploid embryos, and we know that by doing this, we improve live birth rates in about 15%, and this has been shown in several randomized clinical trials. And also, if we add to that the basic knowledge about the endometrial factor, we can also increase this another 14 points and being better off by increasing live birth rates from 30 to approximately double of that. The point here is that we can improve the actual practice if we consider the new scientific advances that we can really apply to human reproduction. And with that, I just want to leave with the faces of my team that is working on that for a long time, which is leading by Maria Ruiz, the ERA group, and also our clinical studies that is leading by Diana and Carlos Gomez and David Blesa, that is trying to get us always the new technologies that we can apply, together with a very special collaboration with Steve Quake at Stanford, that he has been the one that opened our eyes to single-cell transcriptomics, and we are now having a European project working with different colleagues at the Sanger Institute, just to move forward the team in the interest of the organ that we are very familiar and very interested, which is the human uterus. And of course, our colleagues from iGenomics worldwide trying to move this from the bench to the bedside. Thank you very much for your attention, and I will be happy to entertain any questions that you might have.
Carlos, thank you very much for a very, very interesting presentation, which elaborates a lot on the endometrial receptivity. And I have a few questions for you. First of all, is endometrial receptivity is hormone dependent? If we increase progesterone level, should we change the endometrial receptivity? Will it be changed? Is it dependent also on estrogen?
Yeah, it's a very good question, and makes a lot of sense. The thing is, of course, is hormonal dependent, but the hormones, as you know, they're very dependent on the hormonal receptor rather than the hormonal ligand. Obviously, you have to have progesterone in the system, and that's why progesterone is crucial after proper estradiol priming. But the dosage that we are using worldwide, we have analyzed endometrium coming from different parts of the world in which the dosage are different. The route is different, vaginal, subcutaneous, intramuscular, and at the end of the day, it relies on the progesterone receptor, and that's why the timing for the personalized window of implantation it's different among patients depending on the progesterone receptor, and this is something that it is something new that we will be we will be happy to share as soon as this is confirmed. So it is more than it has been published, the progene phenotype of the progesterone receptor. It is known that the progesterone receptor in the Neanderthal is different than the Homo sapiens. So the progesterone receptor has been evolved through the evolution, and it is the basic. This is the basis to really open the window. More than of course, the ligand is crucial, but what I mean is that we are not going to change this by adding more progesterone. If we have less progesterone than the system, the progesterone receptor will not be activated. But once it is activated, it's not a matter to the root, or it is not an issue of the dosage.
Is this also dependent on age? Is there any difference between the younger patients and older patients, or it's genetics and there is no difference on the age? And why I'm asking you, because if we'll take a patient who need an IVF from the beginning, is it possible that they will have implantation failure only on the second cycle after having one child? Or is it, through the whole life? If they cannot have a child, if they'll not adjust the time of implantation according to the endometrial receptivity?
This is a very interesting question. What we have learned is that unlike the ovary, the endometrium is not age dependent. And we can see the same reactions regardless of the age of the patient. And the best example is the ovum donation program, that you can get implantation at any moment of the life, including after 70. Now, the situation of whether one patient has a pregnancy and then something failed, keep in mind that when you have a natural pregnancy, you have the two elements, which is the embryo and the endometrium, that they can have different speeds. We are talking about, at the end of the day, we are talking about whether this is a slow or just a slow or faster endometrium, let's put it in this way, but we know that there is also a slow or fast embryo. So if you have in a patient the situation which is similar, you can have a natural pregnancy without any problem. But then when this patient, for whatever reason, maybe the age or whatever other factor, goes to IRT, at this moment you just fix one of them. You just fix, in this case, you fix the embryo. So if this patient has the window of implantation requires 7 days, for instance, to be open, if you just fix the embryo and you transfer at day 5, you are going to do it in a displaced window of implantation. So because of that, sometimes, at the beginning, we thought that it was not reason to check that in a patient with a prior natural pregnancy. But we learned from different clinics and from different studies that we have done that this could be the case. In some patients with natural pregnancies, they can have a displaced window, and this will be the reason why it will work within assisted reproductive technology. The other thing is, once a patient just implant in IVF and you do an ERA test, you don't need to repeat that, because if you repeat the cycle and you do it in the same timing as you have done at the beginning, it will work. And we have already data, and we have experience in the second generation of children after the ERA test, and you don't need to repeat that. So it will be fixed. The window is there for the patient. The transcriptomic regulation of any organ is always there. The difference in the uterus is this is hormonally regulated, but keep in mind that there are two factors here, and synchrony is what we are looking forward.
What do you think about the different supplementation put into the uterus with the embryo, like the embryo glue? And, there are some other papers about adding HCG and other supplements, but mainly the embryo glue, because I'm aware of several publications and the Cochrane study that showed that embryo glue increased implantation rates. So how this can combine to endometrioreceptivity can be added to?
I'm really not aware of these studies, and I don't see. I cannot comment on that because I really don't have data to say yes or not. But typically you always want to understand things, and I don't know what embryo glue is, and I don't know what is the molecule and how it will be acting, and what could be the path and the biological plausibility. So I cannot comment on that.
And the last question I want to ask you, if I have the ability to put into the uterus a microscope, will I see the changes between day 16 to day 17 and 18 that I can identify the implantation window?
Sure. It has been done, not a microscope, an electron microscope has been shown that clearly. This is the concept of plasma membrane transformation, how the cytoskeleton changes. It changes completely. I mean, this is the luminal epithelium that the microvilli disappear, the cytoskeleton changes. We have some publications and other groups how the complete cytoskeleton is different, and it is the reason why now the trophectoderm can attach to the luminal, the apical part of the epithelium. Otherwise, it will never be able to adhere, and this is what happens when the window is not there. So there is a specific opportunity, timing opportunity, for the embryo to attach, and you can see it morphologically, but the best thing is to be able to analyze. I mean, the most practical way is to be able to see that at the molecular level, so it's a yes or not. And we are just, the next thing that we are trying to do is to do this in a DNA analysis of the progesterone receptor that can really demonstrate, because of this phenotype, this genotype of the progesterone receptor can be correlated with where the window should be. I mean, the optimal thing will be to translate this test to blood and at the same moment in the patient. With this study that I present you, we can transfer this to non-invasive, doing in endometrial fluid, because we can recognize the different cell types with this transcriptomic signature. But at the end of the day, what we really want is to make things easier, and at the very same moment that the embryo transfer will be there.
Carlo, thank you very much. It was excellent. I'm sure we learned a lot from your presentation, and thank you for your time and efforts to be with us today. So thank you.
My pleasure.
Okay, thank you very much. Thank you for this opportunity to present some of our data on this year's Ovarian Club meeting, which indeed is one of the unusual meetings of this, which is usually a highlight during the year. Unfortunately, we are unable to meet face-to-face this year, but we will be happy to do an online presentation, and we are happy to present some of the work we have been doing during this last year. And I think that this is now a topic which do attract a lot of interest around the world, and this is interesting to clinicians and basic scientists as well. And we have been looking more into AMH. We have been looking into how AMH is actually made, how it's built up, what is it composed of in nature. What we have been looking at so far is mainly recombinant AMH, which has been produced by a Chinese hamster ovary cell line, but not a lot of people have actually had an opportunity to study native unmanipulated AMH in females. And we have now been doing that and been characterizing AMH in many different ways. And this is the subject of today's presentation, which will be done by Lynn Salzu-Mamsen, who's sitting next to me and who has been one of my postdocs for the last 10 years and is a very scattered and valued member of our laboratory. And I'm more than happy to leave the floor for her. Lynn, please take over.
Thank you very much, Klaus, for the nice introduction. And I would go through what Klaus briefly introduced here, the different isoforms of AMH and how they appear in humans. And as you see at the first picture behind me, this is a human ovary where you can see a beautiful oocyte surrounded by intense staining of AMH in the oocyte complex. And this is what we're going to take a closer look into the next half hour. I have no conflict of interest. And what we would go through would be what AMH is, and then the possible functions of AMH, and the clinical relevance of AMH, and the different AMH isoforms in human follic fluid and granulosa cells. And then in the end, we would have a look at how AMH can be measured by different ELISA measurements and how difficult it actually may be. And to start out with, just to make sure that we are all on the same page, then AMH is produced as a 70 kilodalton homodimer, and it's produced in a non-active form, as you can see here, and it has to be cleaved to become active. And the consensus cleavage site is here, as the arrow indicates, between the N and the C terminal, but also additional cleavage sites do exist, that is known. And it has to be cleaved in order to become active. After cleavage, the C terminal can bind to the AMH2 receptor and induce intracellular signaling. Upon binding to the receptor, the C terminal of AMH and the N terminal dissociate, leaving us with an active C terminal and an inactive N terminal. So we have been working a lot with different antibodies from Anne's laboratory, which are highly specific to the different isoforms of AMH. So we do have antibody that detects specifically the N terminal, and some over here detecting specifically the active C terminal. So that gives us some new additional options to look at the processing of AMH that we have not been able to do before. And as I just showed you before, we have the full-length non-active AMH. It has to be proteolytically processed to bind to the AMH2 receptor. When it does that, we have a conformational changing of the receptor, which leads to an inactivation of the receptor 1 and induce SMAD phosphorylation and intracellular signaling. And as you can see in this image, then the C terminal binds to the receptor. After binding, the N terminal dissociates. It can induce signal though while bound to the N terminal, but it also induces a signal when the N terminal is dissociated. And this very nice study by Di Clemente have looked into which form of AMH has the most potent effect to induce intracellular signaling. And this shows that that the C terminal of AMH actually is the most potent isoform of AMH. It induces the highest SMAD signaling. Also, the cleaved form of AMH induces signal, but the full length before cleavage hardly induces any signal of AMH. So it's produced in this latent form and may highly have no biological effects. Possible function of AMH in the ovary. As there's a pretty good agreement about how AMH works in mice. And most of the study we have on AMH is in mice studies. And here's well established that AMH inhibits the initial recruitment, and AMH inhibits the stimulatory effect of FSH on the growth of the pre-antral and small antral follicles. So it's two effects. It's an inhibition of growth and an inhibition of the FSH that this way also inhibit growth of the small follicles. But when it comes to humans and other monoovulatory species, it may not be the same. And this is a very important difference that can easily be confused. But it appears that in humans and monoovulatory species, for example, monkeys and sheep, AMH have the opposite effect. AMH may enhance follicle recruitment and survival and growth. And AMH may inhibit the aromatase and thereby have an impact on the early steroidogenesis in the ovary. And I would show you some of the studies we and others have done that lead us to these conclusions. And these images here is from our laboratory. We have a human adult ovary. You can see an antral ovary and antral follicle here expressing high levels of AMH. It's produced in the female ovary, from late gestation until the end of the reproductive life. And you can see already from the primary follicles, we do have AMH present, but in the primordial there's no expressions because we need the granulosa cells to produce the AMH. And this study we done some years ago at our laboratory, and here we have been looking into the concentrations of AMH in human fetuses during second trimester. And you can see here that in the female there is not any detectable level of AMH, which is very nice because AMH is an anti-Mullerian hormone, which makes sure that the Mullerian ducts, which give rise to the female reproductive system, regenerates. So that is, of course, not what we want to take place in the ovary. But when we look at the lower samples, which is the males, we have sky-high levels of AMH because this is exactly what we want to do in a male fetus. We want to close down the Mullerian duct system. Looking at maternal serum from pregnant women, to see if these high levels of AMH in the male fetus is also present, can be detected in the mother. It seems not to be the case. You can see pregnancies here from women carrying a male pregnancy and AMH levels from women carrying a female pregnancy, and there's no significant difference. So this suggests that AMH is a very potent hormone and it's regulated very local within the fetus during early fetal development, and it does not impact the concentration within the pregnant mother. If we go a little further, we have these very beautiful studies by Bruce Campbell and colleagues. He have been looking into the AMH in sheep models, and he found that AMH is inversely correlated with aromatase. And what you can see here on the x-axis, there is it's very convincing that you have the follicle size, and you can see in the smallest follicles we have the most AMH, and when the AMH is decreasing with follicle size, then aromatase is coming up. This he also shows here in this nice immunohistochemical study, where he have at the left side of the panel we have AMH, where you can see a clear brown staining around in the cumulus complex around the oocyte. And when you look at the right hand, you see that in all the cells that is not AMH positive, they are aromatase positive. So they do not overlap. So this again suggests that AMH may be an inhibitor of the aromatase enzyme. We have tried to mimic this study in humans at our laboratory. Here, as you saw in the first picture, we have stained an oocyte cumulus complex with the active form of AMH. And we do see the same picture that the AMH, the active form of AMH, is highly up-concentrated around the oocyte, but we do see an expression of AMH in the entire cumulus complex. Also, when we stain for the cleaved form of AMH, we can also see that it's present around, this is a section close to the oocyte, but we can still see the same gradient that AMH is present in highest concentration in the middle of the cumulus oocyte complex. And we have also looked at AMH in our group, where we have tried to culture human ovarian cortex for 4 weeks. And during culture, treated as the culture with both testosterone and AMH. And what I want you to notice from this figure is that there is a significant increase in the number of primary follicles after treatment with AMH. And this is purine cleaved AMH, which means that the AMH is active. So here, this is in contrast to what we know from my studies, that here AMH actually, it looks like AMH actually promotes recruitment and survival, and maybe also growth in the small human follicles. This has also been shown in rhesus macaque monkeys in some very new and very nice recent studies, where primary follicles has also been cultured and treated with AMH, and these form in this study they form these organoids, and this study also found that AMH is significantly increasing the organoid diameter in the small follicles. So, and also suggesting that AMH promote the follicle growth. The same study also looked at survival and the diameter of the follicles, and in all cases, these studies, as you can see in this table, that after 3 to 5 weeks of culture, we do see that AMH increase both survival and follicle growth and the diameter of the growing follicles. If we come back to humans, we have made this study where we have pulled a lot of follicles from our cryopreservation, or included follicles from our cryopreservation program. So this is AMA contents in follicles from women who have not undergone IVF treatment. So this is what we expect to see in real life in unmanipulated follicles. And here you can see that AMH is sky high. Look at the level, it's 1,000 nanograms per mil we see here in the follicles. And as you can see, AMH is very high in the small follicles before selection. And we do see it reflects that the estradiol is very low. So there is an inverse correlation between AMH and estradiol, again suggesting that AMH affect the steroidogenesis. And this has also been seen, the same picture in the macaque monkey study, where we also do see that AMH has reduced both the SUB19, which is the aromatase, which is the same as aromatase that is converting testosterone to estradiol, and also the estradiol concentration. So it seems like the pattern is similar between monoovulatory species. So to put this together, so we have the testosterone that has to be aromatized by aromatase SUB19 and to convert testosterone to estradiol. But if we have AMH, then we have a break on the aromatase and a reduced estradiol concentration in humans. And why will that be? And one idea or one explanation could be that that we want AMH to ensure that the immature follicles are quiet and do not interfere with the pituitary-ovarian dialogue regulating the development of the selected follicle. And if we go a little closer into the AMH factory, which is granulosa cells, we have been staining small antral follicles with the different antibodies detecting the specific forms of AMH. And as you can see from these pictures, here we have a clear detection within the cytoplasm, which is also what we expect it to be. But the interesting thing is when we look at the C-terminal, the antibody that detects the C-terminal, which is the active one, specifically, then in some cases we do see that the AMH is located to the nucleus, which suggests that maybe AMH have another function, that we have different functions, and it may also act as a transcription factor. We have tried to culture the human granulosa cells for 20 hours. And as you can see in this one, this is the cleaved form of AMH. We do see here it's clearly expressed in the cytoplasm. You can see the round holes where the nucleus are located and where we have no AMH staining, and all the staining of the green is AMH is outside the nucleus. But when we stain with the mature antibody detecting the mature C-terminal, the picture is different. Then it's combined. In some cells, we do have an extremely intense expression within the nucleus, like here, and in other cells, it's expressed in the cytoplasm. So it's, again, just suggests that AMH is very variating, and it can be difficult to imagine what precise function it may have. It may be several. And if we look at the AMH isoforms in human follicles and granulosa cells, we have been using a setup with 4 different ELISA assays from Anne's laboratory, and which are all calibrated according to the same AMH standard, but they detect different isotopes or different epitopes on the AMH molecule. So you can see the first one detects at the N terminal and the C terminal, giving rise. So with this assay we can be able to pin out these two isoforms. The other two detects detects and capture on the N terminal, giving rise to all these forms that includes the N terminal of the molecule, and the last one both capture and detect specifically on the C terminal, and we will only see the fragments of AMH that contains the C terminal. And from this, we found the first thing we could see that with 3 of the assays, we found a significant correlation between follicle diameter and AMH, which is not a new finding that we have seen before. But the interesting thing is that using these different assays, which are all calibrated according to the same AMH standard and are running the exact same follicle fluid samples, we do get very different levels of AMH. You can see it's very different how the content of AMH the different assays do measure. And we also saw here that this specific assay that detects only the C terminal, here there was no significant association between follicle diameter and AMH content, which may suggest that when we come to the active form, the concentration of AMH is more stable and is not so affected by follicle diameter as when we look at all the other isoforms of AMH. And we also explored the AMH in follicle fluid and granulosa cells with the use of Western blot technique. Here we have included follicular fluid from follicles with increasing diameter from 3 to 12 millimeters in diameter. And you can see this, the picture is pretty similar between the different follicles. We do see kind of the same bands. We do have a few bands that is coming up more intense in the small follicles, but what I want you to notice here is that all these in vivo forms are not similar to the ones coming up here in the recombinant standard, suggesting that what we usually use as reference, the recombinant AMH, may not be the same as we find in vivo. And we also looked at granulosa cells alone. Here we have been obtaining granulosa cells from follicle with increasing diameter, and we have used the specific antibody for the N terminal and for the C terminal separate. And what you see here is again that the pattern is very different. We do find low molecular weight band in the granulosa cells in some of the follicles, not in all, and some different bands are coming up. So, and it's not the same as in the follicle fluid. So here we can see that it's absolutely different. We have some forms are coming up in the granulosa cells, and already when we come to the follicular fluid, it's different. And it's not even the same between follicles of different sizes. And here we have looked at follicles of the same size and compared those. We have obtained follicle fluid with the corresponding granulosa cells. This is the two first is from the same patient, and the follicles is of the same size. And here you can still see that even between follicles from the same woman of the same size, the AMH isoforms are different. They are not the same. And you can see it again here when we go to the next follicle and to the third. And we have done pretty many different Western blot, and the pattern is the same. We do see very different forms of AMH in follicle fluid and granulosa cells. So this just suggests that it may be very difficult to imagine what kind of, to make a standard for a antibody or an ELISA that used under the use of antibodies that can detect all the different forms, because there is very many different forms, even within follicles from the same size, from the same women. The last plot I would show you here is a plot where we have used the same samples as in the previous slide, but here we have the samples have been treated with a reducing agent on this part of the over here and not over here. And what we get out of this is that the AMH recombinant, the standard going here, after we use the reducing agent that cleaves the SS bridges, we find that it changed conformation, which is also what we expect. But in the native forms from in vivo, it doesn't change at all. So this indicates that even though we do have a low molecular weight band in the recombinant standard, it's probably not the same as the low molecular weight band we have within the follicle or within the granulosa cells. So it's a little tricky. And the final thing I would like to show you today is coming back to the ELISA measurements and how now we know that within the follicle we have a lot of different isoforms of AMH, but usually what we use in the clinic would be, of course, serum samples, which we use to, in combination with IVF treatment, we use it to have an idea of how the ovarian reserve is in the women coming to the clinic. And in this study, 16 women below the age of 30 and 10 women above the age of 35 has been included, and blood sample has been taken on cycle day 5, 10, 15, 20, 25, and in some cases 30, in 3 consecutive cycles. And then the samples have been run with the most common used AMH assays from Roche and ANS and the Beckman. And when we look at, this is just example from different, each panel represent one woman, and you can see in most cases the assays run in parallel. They do not detect exactly the same concentration of AMH, and this is probably because they elaborate different epitopes, or they bind to different epitopes with different specificity. So we may not want to compare AMH measurement used where we have used different assays. So if we want to measure AMH, we would like to use the same at least. But in some cases, they don't even run in parallel using the different assays. As you can see from these 2 patients up here who both have a pretty low AMH level, the Beckman assay were not able to detect any AMH at all, whereas the other 2 detect AMH, and the same was the case over here. I think this is below detection limit of the Beckman study, or the Beckman assay. And if we look at this one case down here, this is a very normal and cycling woman, and with a normal antral follicle count where you would expect to find AMH. 2 of the assays did not detect any AMH at all. And I assume that this is because this woman apparently have some different isoforms of AMH, which were not detectable with the 2 assays, but was detectable with the ANS laboratory assay. So this can suggest that AMH is many different things and may be regulated very differently even within the same woman. And of course, we should be careful when putting all our if we put too much effort into using the AMH as a precise predictor of the ovarian reserve, because it may vary a lot between assays and between the different samples from different women. So in conclusion, from our studies, we have found that AMH is differently processed in individual follicles in both follicular fluid and granulosa cells, even within the same woman. And AMH processing of follicular fluid and granulosa cells is very complex and gives rise to additional cleavage products, and some active and some inactives. And the AMH isoforms present in the circulation are likely to reflect those in the follicular fluid and granulosa cells, since it's a granulosa cell, which produce the AMH. And it's therefore difficult to envision an ELISA assay that will detect the various AMH isoforms with similar efficacy in different serum samples. Thank you for your attention.
Okay, thank you very much, Lynn, for this these new data on AMH in humans. I think that there's a lot of new information that we do not know about on AMH, and just measuring this in the clinic is probably not providing all the information which AMH is able to give us. And I do think that there is indeed a need for further studies on this. I would like to ask you a few questions before we finish this session, and I think that I would like to start out by saying to you, so now you're showing a lot of Western blots and a lot of information on different ELISAs and so on, and why do you think that we haven't seen these data before? I mean, it's we have been knowing about AMH now for basically 5 decades, and still there's not a lot on the different forms of AMH in vivo.
Yes, I think that's most likely because mostly AMH is measured in serum, and we do see that the concentration of AMH is 1,000 times lower in serum than it is within the follicle, because the follicle, the granulosa cells, is the factory. So this, when we need to look into where it's actually produced to see what the factory produces. If we look at it already, when we look at it in follicle fluids, it's not the same as within the granulosa cells. So it's likely to be processed even more when it reaches the circulation. So measuring AMH in the circulation would likely not give us a lot of information, at least about the active form of AMH. The active form is the C-terminal, is unglycosylated, it's a very small molecule, and it's not present, will not be present in serum for very long. It would be degraded very rapidly. So that is also why measuring AMH in serum, often you would have a readout of no active forms at all, because it's simply not there for so long. So it doesn't stick around.
Okay, very good. I think that there is studies which previously tried to detect the different forms of AMH in circulation or in other biological fluids, not follicular fluid, but they actually did an immunopurification of the AMH. And then, funny enough, they get a picture of what this specific antibody then catches of different AMH isoforms. And I think that you have very nicely demonstrated that if you use AMH antibodies detecting different epitopes and different isoforms, the picture is completely different.
Yeah.
So what is the implications of this?
Well, it's difficult. It was not an easy question.
No, it is not.
Because, of course, if we use assay where we purify the AMH, we will, of course, only detect what these antibodies that was used for the purification detects, was able to capture. So all the other isoforms may slip away through our fingers, even though we try to catch them. So we can, and you could imagine we could design an assay where we used several antibodies that detects and captures both at the N-terminal and C-terminal. But then again, I think we will be in trouble because many of the isoforms, then we would depict them twice. So the end-up concentration will also not be correct, because it can be full-length, cleaved and associated, and elaborating more, depicting antibodies at the same time will give, of course, capture more, but it would not give us a more clear picture of the actual AMH concentration or the different forms. We would probably get and measure too much if we did it that way.
Yeah, and then of course on top of that comes the standard. So if we now take a pair of antibodies which detect some forms of AMH, then in relation to the standard, this will then depend on how many of the different isoforms are then present in the standard. So it's just a difficult, and on top of that, I think I would also like to add to or explain to us that when you do have AMH intact, the full length 70 kilodalton peptide, and you have the first cleavage so that you take off the C-terminal and it do become active, then the AMH is specifically interesting because the three-dimensional changes that happens, they expose new isoform, new epitopes. So can you explain what is the importance of that?
Well, the importance is that these antibodies specific for the C-terminal, maybe I forgot to mention that, they are specific for the cleavage form. So we know that we actually depict on the active form of it because before the proteolytic cleavage, the epitopes will be hidden. So it wouldn't. So if we do see it with the C-terminal specific antibodies, it is active. And that's, of course, gives us some information that we, at least in this case, know exactly that if it's depicted by the C-terminal specific antibody, it's the active, or maybe the active associated form. But at least it has been cleaved before them to be unmasked.
So the consensus based on the information we have from the recombinant AMH is that you have this dimer of the two 70 kilodalton peptides which are held together by SS bridges. And when you make the proteolytic cleavage, you sort of cut off a 25 kilodalton fragment, which then comes out as a 25 kilodalton fragment. This is the active form. And once you reduce it, you cut off the SS bridges. This goes down to 12.5.
Yeah.
So this is one chain, and then it's cut off halfway or at the C-terminal. So now we are looking into the granulosa cells, and you're depicting new small molecular weight bands of AMH. They have a molecular weight more than 12.5. They're 14, 16. What is the implication of that?
It's difficult. It's simply not. We have the theoretical cleavage site, the theoretical processing, but it looks like in vivo there is more to it than that. There is different isoforms, there are different forms that and cleavage. There must be different cleavage sites that we simply are not aware of, because that would give rise to the smaller fragments that not. So maybe the small fragments of the 25, it can be cut into even smaller, in smaller parts. That is not 12.5. That is something else.
So and when we reduce the 14 and 60 kilodalton and small fragments, they don't go down in molecular weight. So they're single chains. They're not sitting with CC terminals, CC bridges between them. So they would be cut upstream towards the N-terminal, because they're larger than 12.5. So they must be longer than that. So there's a processing, not on the consensus cleavage sites of AMH in vivo, and certainly not in the granulosa cells, which of course is extremely difficult to understand and interesting at this point in time. But I do think that I would like you to speculate that only in the granulosa cells we see these fragments. And only in the granulosa cells you see, if you use the similar antibody, which detects these 14 and 60 kilodalton bands, you, in some of the nuclei of granulosa cells, see an intense staining. Do you think that this is the bands we're looking at inside the nucleus now?
Yeah, it may be. It's difficult because it could be. We have the entire granulosa cells, so we don't both have nucleus and cytoplasm. We have everything, but we cannot from a Western blot see where the fragment is, if it is where it's located in the cells. Yeah.
And then, of course, we really don't know in detail how expression of AMH is regulated, but the last picture you show us here is very convincing. So this is now confirmed in sheep and also confirmed in humans, that you have this intense AMH expression around the oocyte. So somehow AMH maintained to be upregulated. So what are we talking about here? Why is that?
Yeah, it is likely to hypothesize that there is an communication between the oocyte and the cumulus cell surrounding, and the AMH may have an impact, or either way, maybe the oocyte is talking to the granulosa cells, or the other way around about something about AMH.
Yeah, so I think that there's a lot more information here also, which is interesting to study. So the Western blot you showed us, you have very nicely follicular fluid samples and granulosa cells, which originated in the same follicle.
Yeah.
So the granulosa cells corresponds to the follicular fluid. But the AMH isoforms present are completely different. How would we envision this happens? I mean, why wouldn't we see what's inside the granulosa cells reflected in the follicular fluid? But we don't. So what can we hypothesize on the secretion of AMH from the granulosa cells?
Yeah, it appears that something happened within the follicle fluid, and we know that the protein concentration within the follicle is extremely high. There's a lot of things in there, and there may be some proteolytics enzymes that already before it reaches the circulation just within the follicle process the AMH. It would be my best.
Yeah, no, but that's all good. So I just want to ask you one final technical question, because we are now sitting and looking at your beautiful oocyte cumulus complex from a human follicle, and indeed the AMH is highly concentrated around the oocyte. But tell me, why do I see green spots in the theca cells?
You don't see the green spots in the theca cells. You see them in the vessels, in the theca cells. AMH also stained in the vessels.
All right.
Yeah.
All right.
Yeah.
Okay. I think I want to thank you, Lynn, for a very nice and interesting presentation. And I'll finish this session and thanking the audience for their attention. Thank you.
Thank you.
I would like to welcome all of you who joined us for this session entitled Luteinizing Hormone-Independent Progesterone Rise as a Physiological Trigger of Ovulatory Gonadotrophin Surge in the Human. The exact sequence of events leading to the LH surge has not been fully elucidated. For many years, the most prevalent theory has been that a sustained elevation of serum estradiol is the trigger for the GnRH and the subsequent gonadotrophin surge. This theory, however, is not free of weaknesses, and confounding evidence do exist. Progesterone has also been mentioned as a putative candidate.
we wanted to see if we can reproduce LH surge with a very low circulating level of progesterone. This patient was consulted and chosen because she had previous failures of implantation, and it was an IUI patient. You can see that patient had classical after injection of progesterone. It was 5 milligrams in oil injected. So she had classical signs of ovulation. Her progesterone 17 hours later after injection was around 8, and her LH was 37, which would be expected for typical ovulation. And what is very important is that 7 days later, without any additional support, her progesterone level is within the range which we would want to see in physiological luteal phase. To conclude this presentation, the ovulatory sorting of gonadotropins is triggered, as we believe, by progesterone through generation signaling pathway. As follicle is losing integrity, changes in the intrafollicular milieu causes progesterone to rise and estradiol to drop, which makes LH surge imminent. And P4 level above 0.5 nanogram per ml during follicular phase is clinically significant. There are many ramifications from this new paradigm. One of them is that we may be able to create a natural luteal phase for frozen transfers very, very inexpensively, because progesterone is very inexpensive. Another derivative from this new concept is what we call term oocyte maturation and term ovarian stimulation, and their impact on oocyte competence, which was published in Fertility Sterility in July. And we also put forth the new theory of PCOS origin, and this publication was published online yesterday, by the way, just yesterday. As with any new scientific paradigm, it's never final. It's an approximation. And in science, it always a sequence. You start with paradigm, you have anomaly, you have complication, and new paradigm. In our case, the paradigm was estradiol causing LH surge. Anomaly was observation that progesterone can do it. We had all kind of ideas why it was still estradiol. We ignored for many years progesterone as a possible contender for LH trigger, and we think we have a new paradigm, and new scientific truth is never final. It's never final, even in exact science and not in medicine. And our new ovulation paradigm is no exception, although we hope that it is an exception. And I would like to acknowledge several people who helped us to discuss the discussion of this new paradigm, give a lot of valuable feedback, and also Dr. Iskson and Araj, who donated money to make this publication free and open access for everybody. Thank you very much.
So thank you very much, Dimitri, for this excellent presentation. It's actually an exciting lesson in gynecological endocrinology, which we like so much. And I only have a few questions and comments to both of you, Michael and Dimitri. Regarding the effect of the administration of progesterone in the presence of large follicles and its ability to trigger ovulation. There is an interest study from Turkey. First author is Yildiz, and it's published last year in Fertility Sterility. And in this study about progesterone-primed ovarian stimulation, PPOS, I would call it, it was used in oocyte donor, and it it is interesting because unlike all other papers, like the Quant paper that you have mentioned, in which progesterone is administered from the beginning of the stimulation, in this study, they used a flexible protocol where medroxyprogesterone acetate was administered either from stimulation day 7 or in the presence of a bleeding follicle that was 14 millimeters or larger, whichever came first. So you might expect that if you introduce progesterone in the presence of a large follicle with LH and FSH already accumulated in the hypophysis, it may trigger a surge, which did not happen in any of the study participants. So they actually showed that a flexible PPOS is possible. So maybe it was because it was a medroxyprogesterone acetate and not a natural progesterone, but how would you explain that? What would your elaboration on that?
You want me to answer, Michael, or you want to answer?
Go ahead, Dimitri, and then I can add on after that.
Okay. Well, I have to look at the manuscript. It's always, they always in detail. My first, but without looking at it, and this would be shooting from the hip, so to speak, because I did not see the article, I always like to look into details of the materials and methods, because just the results can be difficult to interpret, as you know, without knowing exactly what kind of patient they were, like what was happening, and it's like, you have to look at specific patients sometimes to understand why in this case it didn't happen. But if it's on donors, so it's more or less uniformed group of patients, so this probably not an issue. I would think that on day 6 or on day 6, I wouldn't expect in most patients hypothalamus to be primed to progesterone. So this would be my first guess. It could still be desensitized. Second, I would look at what was happening, what protocol it was. Was it long protocol, short protocol? Was he measuring LH day after he started progesterone? I doubt it, because I would not expect him to measure it. And maybe if he would see LH surge. In this case, LH surge would be inconsequential. It would not do anything, because follicles are too small to respond to LH. And he would because he's using stimulation, external FSH, his follicles will continue to grow. And he triggers, not with LH, he triggers with probably, I would imagine, HCG, and then this is how he would avoid this trap of inducing what would be cysts. But I will tell you something, that if you look at our last publication, which was just published about origin of PCOS, we believe that this premature LH surge, which can be caused in these patients by prematurely sensitized hypothalamus, could be used to explain those cysts. So we think in some cases, when you have a lot of follicles, very high MH, you may get very high estradiol, you may get this effect. But if you only have, even if it's a very large follicle, it's only one follicle, estradiol will not be high enough to induce on day 6 enough receptors in hypothalamus to allow progesterone to cause the effect. Michael, what do you think?
Yeah, so I would agree with several things you said. First of all, obviously, I agree with to read the article and be more familiar with what was done would be very important to be able to specifically answer the question. The factors that would come to my mind, as you were alluding to at the very end, is progesterone receptors, whether there are sufficient presence of them to be able to respond. But I also wonder whether maybe a difference is that it was not progesterone, but the medroxyprogesterone acetate that was used, and the relatively high potency compared to natural progesterone, and whether that in some way was influencing the response at the hypothalamic level.
Okay, thank you. Another question. It is now well documented that the late follicular phase progesterone elevation, not only during controlled ovarian stimulation, but also in natural cycles with frozen embryo transfer, adversely affect the implantation rates, most likely through introducing embryo endometrial asynchrony. So wouldn't there be a risk from introducing the ovulatory trigger by the administration of progesterone? You have to be very careful in selecting and titrating the dose. Wouldn't there be a risk of advancing the endometrium and causing a kind of asynchrony with this approach?
It's a great question. It's a good question. And I would expect you to ask some difficult questions because this is what you are. You ask difficult questions. Well, and again, Michael, can I jump in first?
Please do.
Okay. So progesterone begins to rise at the peak of the, progesterone causes LH surge at the end of the needle. So the timing, whether you inject HCG or you inject progesterone or progesterone rises and triggers LH, is almost exactly the same. So it's not. I don't think that this a couple hours would make it would spoil endometrium, would desynchronize endometrium and in an embryo.
Michael, would you like to add something?
The only thing I guess I would add is it is our expectation that a natural physiologic LH surge, as might be induced by progesterone, may actually help the luteal phase environment and the development of the endometrium, as opposed to what may occur in situations where there are super physiologic levels of hormones that are being used as part of the stimulation cycle and the induction of ovulation.
But it's a great question, Ariel. It's a great question. You know, we've worked on this article for a while, so we thought we ask ourselves all questions, and like in the last 2 months, nobody could ask me a question which I did not already answer to somebody else. But this question nobody asked, and it's a great question.
You know that if you start luteal support 1 day earlier than the oocyte retrieval, then it will already reduce the implantation and the pregnancy rate. So you have to be very careful. Maybe you mentioned that it's a very subtle rise of progesterone. So you just have to be, if it works, that you have to be very careful with the dose to prevent this ill effect on the endometrium.
Absolutely. Yes.
Yes. I have a question to Michael. Just because Michael has been more years in the field, I guess, and I've been attracted and fascinated by the gonadotrophin surge attenuating or inhibitory factor, GUNSAF or GUNSIF. And you're familiar with that. And according to the new paradigm, is there still a missing link for such a substance like the gonadotrophin surge in attenuating factor to reduce pituitary responsiveness to GnRH during stimulation? Or should we still looking for this factor? Gonsa.
Again, I think that's a great question. Potentially, it may suggest that there is additional factors within the regulatory process, and it would not surprise me. But I'm not sure that it would be required to be present in order to be able to for induction of ovulation and to see the subsequent hormonal changes that we see. So potentially, great question.
It's a tough question. This is tough. This is not your average interviewer. This is a real tough question.
Last question is for both of you. You are probably you have plans for the future, and which experiment or set of series of experiments do you have in mind, or you suggest to enhance and establish further the role of progesterone in triggering the gonadotrophin surge?
Michael?
Well, I think those studies could take two different pathways. One would be trying to define the sort of questions you were just asking and to better understand the physiology of what is happening, which I think would require setups with for frequently sampled collection of specimens in order to be, better define the specific sequence of hormonal events that are occurring and when they occur, and then identify the consequences throughout the luteal phase. A second pathway would be to define and demonstrate that what we are hypothesizing here actually happens, and then to look at the influence of a relatively small, or would be considered a small clinical elevation of progesterone, but which we are hypothesizing is clinically significant because it leads to the LH surge, and to demonstrate what happens then to luteal phase characteristics, both hormonally as well as endometrial, and ultimately looking at pregnancy outcome.
Yeah, and since the question was to me as well, I would like to go and recruit, patients and trigger with progesterone. I have no doubts that whatever we showed as a case report is very reproducible. And the reason I'm saying this because before it was when this manuscript was published, it's a very big statement, very big claim, and to go into the masses without feeling confident that we are on a solid ground is very risky, and neither Michael nor me would not be doing that. So we ask people, we just share this with people from other clinics, and we had at least 2 more different clinics where people tried to induce LH surge with the same way as we did, and got exactly the same result. I do not know anything practically which would be as reproducible as what we are talking about here. It could be not complete, could be, but it's very unlikely to be completely wrong, because we have the pudding, we got it. We just don't have many cookies or puddings, but we're confident that it may not be a complete picture. I don't believe we will ever have a complete picture because we're dealing with a system which is so complex and so fluid, where we can move from male to female with a tiny, tiny changes in the pathways. We have redundancies, we have duplications and everything. Human brain is not designed to handle this complexity, but at least at the basic level, we know that even without regarding to underlying mechanism details, this phenomenon is reproducible.
Okay, so I think we can end the session again by thanking you and congratulating you for this publication and your achievement, and have a good day. Bye.
Thank you very much.
Thank you
very much for inviting us. Bye-bye.
Thank you.
I have the pleasure to introduce Dr. Richard Scott. Richard is a board-certificated reproductive endocrinologist, obstetrician and gynecologist, and is CEO of IVI Rama Global. Dr. Scott serves as professor and fellowship director at the Division of Reproductive Endocrinology at Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia, Pennsylvania. Dr. Scott received his medical degree from the University of Virginia Medical School, Charlottesville, Virginia, performed his obstetric and gynecology residency at Wilford Harf USAF Medical Center in San Antonio, Texas, and completed his fellowship in reproductive endocrinology at the Jones Institute of Reproductive Medicine in Norfolk, Virginia. Richard's research interests include embryology, pre-implantation genetic screening, and non-invasive screening of embryonic reproductive competence. Richard has published over 500 scientific papers and abstracts. He also received numerous international and national awards. The topic of his presentation today is metrics for AIT outcomes. So Richard, the stage is yours.
Well, thank you so much. And thank you for the invitation to be here. This series of topics and lectures and webinars has been really extraordinary, and it's a privilege to be part of it. And quite frankly, I'm excited to be here. I think that in spite of it being a question that has been asked from the very earliest days of clinical ART, we continue to struggle at times with what really defines a positive outcome. How well does ART work? In the end, everyone says, of course, it's deliveries, it's healthy babies that come into the world. I don't think anyone would deny that. But representing that and creating rates and how we report that both to each other as professionals, to insurance companies and governments that provide access to care and resources, and of course the patients themselves, has become a complicated question that's had an ever-evolving answer and is to this day still not something which is consistent across all countries and all platforms. In its simplest form, a positive outcome would be defined by a pregnancy and delivery of a healthy infant. I mean, what else could it be? Well, there are other things to be considered. How do we address the issues around multiple gestations? How do we address reporting requirements that in the U.S. come from the Wyden bill? I'm not going to go through those requirements. It's obviously a very international audience, and there will be different mandates and different requirements in each regulatory environment. How do we attain consistency across those and fairness and accuracy? And I think it boils down to when we're reporting, if we're reporting to a government for the benefit of the government or a benefits management system for the benefit of them, they'll have their own criteria, they'll look at data their own way. But when we're reporting to patients, I think we need to know that we have to think about what they want to know. And that's always subjective, changes with time. I'm somewhat speculative in these opinions, but they come from speaking with many patient advocacy groups, many patients themselves, and of course, many colleagues. First and foremost, number one, is delivery rates. If I do this cycle, if I attempt IVF, for instance, at this time, will I have a baby 9 months from now? And in doing that, they care about an overall assessment of quality and efficiency for sure. That number arrives almost as a percentage, but they do care about safety, and they care more. They're recognizing the need to care about neonatal outcomes more and more, and our reporting needs to reflect all of that. I think it's generally less important to assess the efficiency outcome of any individual step. We know it comes to us, particularly if they've never had care and never been through IVF, and says, you know, I really only care about my fertilization rate. I really don't care about whether I may form high-quality embryos or blastocysts. I really don't care if my endometrium is appropriately prepared or supported. Of course, they care about all those things. And so a reporting system which is heavily intensive on the outcomes from each individual step is something that patients typically become lost in and is probably counterproductive in the long run. Certainly, people with specific problems may focus on specific issues. If you know you have ultra severe male factor, then that's something you're going to want to know about ICSI and efficiency. But that's the substantial minority of patients, and those are, of course, data that are provided by individual clinics in the context of that individual patient, and not necessarily overall reporting. What would an ideal report look like? Well, I think it'd be simple. It has to be absolutely unequivocal. There should be no vagueness or difficulty in interpreting the data. Everyone who looks at that data point should walk away with the same interpretation of its meaning. It has to be spin-free. This is something that the U.S. has not always done well with. Depending on who's deciding what gets reported, people with diminished reserve don't get reported, or low responders get reported differently. Or if you say it's a minimal stimulation, even though there's no definition given, it gets reported differently. And now there are other devices that people would like to report differently. The reality is, don't spin any of that. Report the outcome. If patients are asking for more detailed information about some specific circumstance they're in, then provide that to them in the best context you can. But for generalized reporting, that's inefficient, and it really leads to things which can be quite misleading. It should not support less responsible clinical practice. I mean, if you can put six-pack and get almost everyone pregnant, are you practicing good medicine? And of course, the answer is no. And people put a lot of embryos back because it raises delivery rates. And even though they report multiples and singletons, patients are not always, particularly early in their care, sufficiently informed to understand the risks which are associated with those things. Furthermore, it's a way to handle hiding lower quality outcomes from your laboratory and from your clinical care. If you get the same pregnancy rate putting 4 back that someone else gets putting 1 back, that's not an equivalent program. And the safety is not the same, quality is not the same, and patients should not be reassured that they're the same. So these things should expose practice patterns which result in higher neonatal risk. I'm not talking about commercial or competitive advantage. I'm talking about genuine neonatal risk, because that brings less healthy children. In the end, we have to gear things to the reality of a coming universal acceptance of single embryo transfer. Now, reports over the years have evolved and become quite complex. They're time-consuming to go through, and they're frequently unclear. They are a genuine, sincere effort to be as comprehensive and as clear as possible. But it's confusing. Multiple screens are required to find the core data. I went to look up some data on one of the programs that we're affiliated with the other day, and to be honest with you, I gave up. I couldn't get to the core answers that I wanted to try to understand what was going on in that program. If I can't do it, I really doubt patients can do it. Many of these things are not easily interpretable, and they may at times even be misleading. Certainly, the most common response we have from our patients who are proud of our data, we send them to these places to review the data. They say it's not very helpful. This type of analysis paralysis, too much data, uncertainty about how to interpret it, how to weight things, is bad, and it's made worse when things constantly change. And so the report looks one way one year, then a different way the next year, a different way the next year. That tells you that there's recognition that we may not be reporting or segregating data in an ideal way, and we need to back up and be simple. In today's world, governments and insurance companies, benefit managers use these data to make decisions about who they work with and about how they fund them. And at times, that could be very dangerous if anything is in fact misinterpreted. Individual probabilities, great goal. It's totally noble. Patient plugs in who they are and out comes their exact specific outcome, except that things are always grouped. And so, like it or not, people use these to compare programs. And so then the sample size in the individual groups becomes very important. So let's think about how we might group things in an ideal world. We have 5 different age groups used by SART, plus donor eggs. That's at least 6 groups. We have at least 6 different major diagnostic categories, although there are many more, but limited to 6. There are 2 different rare and reserve status groups. You have diminished reserve or you don't. That's sometimes difficult to define. Whether you've had a prior attempt or not, because that knowledge would certainly influence your prognosis. Whether you're using PGT-A or not, fresh versus cryo or not, number of embryos transferred. It's at least 1, 2, or 3 or more. Could be more groups than that. when you just put those limited things together, and I would tell you that there's many more groups than that, that's 3,888 different combinations. No one's going to have very many in every box. So they're going to be further grouped and further consolidated, and you really get away from this individualized probability concept. Misspelled that. So the reality is that it's far from perfect. So let's go back to the basics. What do patients want to know, and what do they really know, need to know? And I think the first thing is, do I have anything to transfer? If I go through IVF, am I going to get an embryo that gives me a chance of getting pregnant? It's still not about delivery. It's an intermediate waypoint for sure, but it integrates it integrates everything that goes along through stimulation, retrieval, fertilization, embryo development in vitro. It puts all those together and says, hey, if you come here, the things that we do, that's all of those things, will lead to you having an opportunity for a transfer or not. If no transferable embryos result in a given cycle, it certainly can alter future management, but in that cycle, in that outcome, it's final. And so that's got to be considered a failure, and certainly needs to be considered. If people bring up the possibility that with PGT-A, it creates a problem. Look, people with PGT-A are going to have higher implantation rates, but it will come at least partially at the cost of having fewer embryos to transfer, and for some patients not having embryos to transfer. And so that has to be reflected somewhere. This is a superb place to reflect that. If you have two blasts that appear usable, but they're both aneuploid, you're not going to transfer them. That's a failure and needs to be reported as such. And so, do you get to transfer? Do you have one or more embryos available to transfer? Is a simple, critical, easily defined endpoint that nobody can monkey with, no one can alter, and you would just define it. Total number of cycles where there's one or more embryo available for actual transfer, or long-term cryopreservation if you're doing that, divided by the total number of cycle starts. Patient begins treatment, begins meds. Simple, absolutely and easily understood universal calculation, and answers a fundamental question that the patient have. Are you going to get me something to transfer? Their almost immediate follow-on question is, will this embryo become my baby? And of course, we all in the industry, all of us who are professionals, would call that the sustained implantation rate. What's the probability that a given embryo, which we have selected and said is sufficient quality to be transferred, will actually lead to delivery of a live-born infant? The key here, because transfer decisions are about embryos, and transfer and the quality of the lab and the quality of the outcomes really are based on the performance of the embryos, is to report something about delivery rates based on the embryo, not just on the patient, but on the embryo. So sustained implantation rate, we'll talk about delivery rate in a moment, is very, very important. They're really, with this type of reporting, there's no benefit to multiple embryo transfer. You can't hide a deficient laboratory or some other problematic aspect of a program behind putting multiple embryos back. It will tell you and allow patients to evaluate right up front what their outcomes are, because everything is per embryo transfer. It also, remember, is the same as the delivery rate if we're doing single embryo transfer, which should be our goal. Should be everybody's goal for every transfer. In our program, we don't do multiple embryo transfers to anybody at any time. This also is very easily calculated. Take the total number of embryos you transferred, look at the total number of babies born, that's it. Sustained implantation rate. It's not getting to a heartbeat or seeing a sac, highly influenced by when you do the ultrasound. It's not who got the discharge through their obstetrician. It's who delivered, how many babies were born, is the denominator, the numerator being how many embryos are transferred. You'll come up with a number. Again, really not susceptible to people playing games with their data. Very easily interpreted by professionals and lay people like the patients alike, and gives us an excellent assessment of the quality of a program. And in patients' information, patients need to know, decide this is worthwhile for them. And then finally, of the three big ones, how many embryos will there be if I need to try again? Today's world, we're mostly putting back one embryo. If a patient has a second usable embryo, that means they could have another try if it failed, or another baby someday if it didn't, by using the embryos that have already been created in that cycle. This number is typically made on usable embryos or biopsyable blasts if you're, you have some that haven't been transferred yet. Usable being if you're doing PGT. Obviously, important differences exist when patients should expect. And it's important in interpreting their probability of ultimately having a baby or building a family, and for assessing quality within a program. Because obviously, if you take 100 patients of a given age group and similar background, and one clinic averages 4 supernumerary blasts and the other one only 1, that's a big difference in the quality of those programs. And it's something patients should appreciate. Math, again, very simple. Total number of embryos remaining after the first transfer, supernumerary, after the first transfer, divided by total number of cycle starts. Am I likely not only to have embryos, but enough that I can try again or have another baby should I be successful after the first transfer? Very simple, no fudge factor, and something that can help patients make decisions about whether this is something they want to do, whether the outcome justifies them making the decision to go through the process. So that's 3 simple things. Very, very effective. What's the probability of having no embryo for transfer? Captures all the failures. Sustained implantation rates, probability of delivering an embryo if you transfer it. Urges single embryo transfer, which is the most reasonable course of action in today's world. And number of supernumerary embryos per treatment cycle. Are you going to have more opportunities in the future? Is the culture system, the stimulation, the retrieval, the insemination, is that efficient? And this can help, of course, people understand all of those things. There is a 4th metric that is perhaps somewhat less critical for patients in making these decisions, but I personally believe is very important, which is patients often frequently ask, what can we do to reduce or eliminate, can never eliminate, any health risks associated with this pregnancy and birth? How do we reduce the health risk to the baby? And here again, this has been known for a very long time. Vicki Baker and David Anderson summarized it beautifully in their 2004 Fertility and Sterility article. But and while things are better, in the end, the principles have not changed. Prematurity is the single greatest complication from ART. The single most important risk that our patients take is preterm delivery, which relates not completely, but almost exclusively to multiple gestation. And of course, that all comes from multiple, not all, but most all comes from multiple embryo transfer. I know there are models zygotics out there and they're slightly higher in our world, but the reality is that's not the genesis of our problem. If our goal is healthy children, and what else could it be, then it's important that we have a metric that reflects the impact of all the clinical and laboratory management decisions on outcomes. Our goal is healthy children. We need to do something that furthers patient safety. I want to jump ahead, apologize for switching slide order there. This is the prevalence of low birth weight in our clinic. And the orange line is the prevalence of low birth weight in the United States according to the CDC, the Center for Disease Control, who collects and reports that data each and every year. And I think what you'll see is that our program, like so many, certainly no better than anybody else, maybe worse than some, had a very high prevalence of low birth weight, less than 2,500 grams. The graph looked just the same for very low birth weight, less than 1,500 grams. They're lower prevalence for very low birth weight, but the principles the same, were much higher than the general population risk. As we have reduced transfer order, as the quality of care has improved, as laboratory science has improved, in 2018, we were just slightly higher. In 2019, not included in this summary because not every single patient has reported their delivery date, but it looks like our prevalence of preterm birth will be lower than the general population risk. Your chance of having twins is, polyzygotic twins in particular, is lower if you conceive through IVF than if you conceive spontaneously at home. The health advantages to children, the societal costs in terms of the impacts on their lives, their marriages, their other children's lives, the costs on the burdens on the healthcare system are all just massive and undeniable. This represents an enormous improvement in the standard of care in our own program, and one we all should be striving towards. So these data need to also be reported. What's the prevalence of low birth weight or very low birth weight relative to the CDC risk, the general population risk? Because it is now possible that we can return our patients' risk to the general population risk, which is just a massive improvement in the standard of care. I'll point out that this can also help us scientifically. The way we've defined pregnancy, clinical pregnancy in particular, because it depends on ultrasound, and ultrasounds have improved, and the time in which people do them has changed. Creates great confusion in the literature. We had simple definitions. Do you get an embryo? Does it deliver? and how many embryos, supernumerary embryos do you have, as well as the outcomes in terms of the health of the children. Simple definitions in straightforward form. It should make the literature more interpretable, and it should become consistent over time. And I believe there's great benefits there. I want to point out in closing, with only a slide or two left, that delivery of weight alone is a very inadequate indicator. Why? Because as Jamie Grippo began pointing out 20 years ago, it encourages multiple embryo transfer. He used to call the Wyden bill the Multiple Gestation Inducement Act because it drove everyone to be competitive. Patients look at those rates, and we're never going to change that. Even SART says, start here and look at them first. We know why that is. And those multiple embryo transfers ultimately lead to multiple gestations, 6 times the risk of cerebral palsy, twice the risk of perinatal death, massively increased congenital blindness and deafness. The overall outcomes here are quite impaired, and there's no reason for us to have them. So reporting delivery rate is no longer really enough. If you're doing single embryo transfer, guess what? It's the same. But it doesn't reflect quality. Now, there may be professional publications, there may be literature where reporting ultimate delivery rate is essential. Of course there is. But in the end, it should always be accompanied by sustained implantation rate. And when we're looking at the impact of a technology, part of how we are going to assess that going forward in the future inevitably will be, does it empower effective single embryo transfer while retaining good outcomes for our patients? So very important. So with that, I would like to thank you for the opportunity to be here again. And I appreciate very much all the outstanding work being done by this group to bring these incredible webinars during this very difficult time. And I would be glad to answer any questions or listen to any comments that Zeb or anyone else has.
Richard, thank you very much for a very informative and interesting talk. I have a few questions that I want to understand your thoughts, to listen to your thoughts. And I'm sure that people are listening to this webinar would ask themselves, well, it's very interesting, but how do I apply this into my practice? I want to start just, with a very simple question. How do you measure or set up the standard of the success in your clinic?
Well, we measure the success in our clinic by the ability to go to effective single embryo transfer, which then reflects good outcomes in the sustained implantation rate, which is pretty high. Of course, everyone will have their own goals, and I know there are many outstanding clinics out there. I think that as people get more confident, as they work to improve outcomes, which comes through many different things that people do, they'll raise their implantation rates and they'll get to single effective transfer. At the same time, we can't afford to not have transfers. So it's a combination of how many people had no transfer and how many outcomes. And this is a very simple thing to incorporate, is how we counsel our patients. You just make the decision and do it.
So how do you respond to your patients if they come and say to you, IVF costs money. We have money only for one trial, and we want more than one baby. So please transfer at least two babies because we cannot afford it to do it again. And I know that this is against normal practice, but this is the wish of the couple. So how do you respond to them?
So, of course, everyone will have a different way of counseling their patients, and I want to be very respectful of that. But I can tell you, however, that when you tell patients, look, if your child was here today, would you ever make a decision that gives them twice the likelihood of dying, almost 20 times the risk of blindness and deafness, 6 times the risk of cerebral palsy? The list of impairments, I go down the list, I can rattle it off for minutes at a time. And you know what they all say? We would never do that. And then I say, but that's what you're asking me to do. And you know what they do? They don't want that. What they really want is a very high delivery rate the first time. So we have to be able to deliver a high sustained implantation rate. And when you can do that, now typically in the 60s to low 70s in many programs, including ours, patients are satisfied with that. Also remind them that if you have 2 transferable embryos, second transfer is not very expensive compared to the cycle. That you get more live babies born and more healthy babies born from 2 1-embryo transfers than you do from 1 2-embryo transfer. More babies born. not just more pregnancies and deliveries, more live births. And so when they hear that, quite frankly, it's not that hard to compel them. Patients, we've not found it difficult to compel people.
When there is a new couple coming into your office and you need to give them a program for stimulation, are you base your stimulation on personal experience, or you have a database that you compare their parameters with your database experience instead of just personal experience in giving them the program, the drugs, the dose?
Such an important question. So we have a very large database, both here in New Jersey where my clinical practice is, but also through the EVRMA system, which has many hundreds of thousands of cycles of data in it. And what we find is that refines stimulation decisions down really into a modest number of groups, just a handful of different stimulation protocols that we can define and then we put patients in. So it's evidence-based and it's data-driven, but we don't find that the difference between 200 and 225 units of FSH is meaningful. So we don't refine things that far. We've not been able to show clinical benefit in our own very substantial data set. But it is all data driven, and I think these decisions are important to be made in a data driven way.
There is a lot of controversies about the luteal phase, whether to freeze our embryos and to replace in the natural cycle, or to transfer fresh embryo to the stimulated cycle. What is your preference in your clinics? What are you doing in your clinics?
So in our clinic, we are a believer in Bruce Shapiro's data, and we redid, and I mention it because all we did was redo his experiments, but we redid many of his studies and found the same thing. In our clinic, we get 7 or 8% higher delivery rates when we do frozen embryo transfers. So we packaged our IVF all together. It's not a substantial burden for our patients. And we now do retrievals one cycle and we do frozen embryo transfers the next cycle. I recognize that people look at that in terms of progesterones and obviously taking out hyperstim risk. But progesterones are trying to think of it in the endometrium, but it's also impacted by how fast the embryo grows. And so it's not just who had a progesterone elevation or who did not. And it's not just whether they're low, mid, or high responders, even though all of those are legitimate factors to consider. You also have to know the speed of the embryo. And our group is also a believer in Daniel Bryson and he releases sort of quiet embryo hypothesis. We're happy for our embryos to go a little slower, but that now frequently pushes them out of the window. We can't make those decisions to the last minute. Patients have started progesterone. And so the reality is it's very difficult to decide who's safe to transfer fresh. And it's very easy to do cryocycles. And our outcomes in our clinic have unequivocally improved, particularly in older patients. It's much more beneficial in older patients than younger patients. And so we do cryo all cycles.
And when you do cryo and replace it in a subsequent cycle, do you do it totally natural cycle, or do you support the luteal phase in this natural cycle?
We always support the luteal phase. And I understand in the natural cycle that there's some debate in that literature, but I will say that we have enough paranoia that some people have a luteal insufficiency at some level, and we believe Ernesto Bosch's data on progesterone and outcomes, and the group from Valencia, and so we always give them some progesterone.
And the last question, the whole world is dealing now with the coronavirus pandemic. Everyone is trying to do things that might improve patients' communication, patients' treatment. So can you tell us, I know that in the United States, it's a huge problem, the coronavirus today. So did you change anything in your practice? Is consultation done through the internet? Is monitoring done through the internet? How do you deal and how do you cope with this pandemic that probably will stay with us for a long time?
So obviously coronavirus is very impactful and we have to be very careful. But we never close. Even in the early days of the crisis. We have very strict and very strictly enforced social distancing with our patients as well. We don't hesitate to be bossy and make them stay apart. We don't let the husbands come in unless they're dropping off a specimen, only the wives. We spread it out monitoring hours so that you walk in our waiting room, it's huge, and there's never more than 1 or 2 people there. We keep everybody spread out. We initially did a lot of telehealth consults. and patients like that, but they definitely prefer in-person consults. So we bring them in, we keep everybody separated. The doctor and the patients are physically separated by a good distance. Everyone wears masks. We clean surfaces incessantly, and we have the space in our clinic to keep everyone separate. We do throughout our system. Interestingly, if someone brought an infection into our clinic, or one of our employees brought an infection to our clinic, it is likely that other people around them would become infected because there's a high degree of exposure even with a mask, even with caution. And now through more than 200,000 patient visits and thousands of employees working tens of thousands of workdays, we have 0 nodes of infection. We have 0 clusters of infection. And in fact, in New Jersey, where that number is tens of thousands, we've had exactly 4 people acquire COVID, and they all got it from someone at home. They all got it from someone who brought it to them at home, and there's been no transmission to their colleagues or anyone in the clinic. Obviously, when they get symptomatic, we don't let them come in. We screen everyone at the door. We're very, very careful. So I think this can be managed. No one should be afraid of this. You should keep taking care of your patients. Time is still the enemy for our patients, and this can be managed responsibly, successfully.
Do you do any corona test to the patients?
We do. We test the patients at the beginning of their treatment cycle. The first day they begin anything, and for regulatory reasons, depending on the treatment cycle, sometimes we screen them near the end as well. We test our staff at least once a month, and anyone who has any symptoms gets tested. Many negatives is what we find, but we're very cautious, and we're very, very liberal with our screening. We've had a handful of patients, not many, but a handful of patients turn up positive. They were in the asymptomatic phase of the infection. We send them home, but we've had no transmissions. Obviously, we don't begin treatment until they're resolved.
Richard, thank you very much. It was really interesting presentation. I like very much the discussion. We learned a lot from your experience, and hopefully we will meet sometime in person. I'm not sure when, but I hope that it will happen.
I'll be very disappointed if that doesn't happen. Hopefully this will be better soon. Who knows?
Okay. Thank you very much again for your time.
Thanks for doing this, Seth. This is wonderful. Thank you.
To conclude the short program of the Ovarian Club meeting today, we hope that you enjoyed the lectures. They will be available on demand on the meeting website. We would like to thank again the speakers for their excellent presentations. We would like to thank the audience for being with us today, and we will be able to collect soon the certificate of attendance, and we hope to receive the CME accreditation points very soon. We will inform you all about this.
And the next Ovarian Club meeting, Asian edition, will take place on December. And we will inform you in regard to this. So with this, we would like to end this evening, this meeting, and see you in December.
Thank you.
I'd like to welcome everyone to the CoGen course on pre-implantation genetic testing. This is a pre-Congress course that we've been holding every year, usually in Paris, but this year it's going to be virtual. I would like to thank Cooper Genomics, part of Cooper Surgical, for their generous support of this Congress like they have done for the previous years in the Congress in Paris. We have gathered a great faculty for this course, and this is the itinerary, as you can see. My background is I'm a reproductive endocrinologist in the United States, in New York, and a professor of obstetrics, gynecology, and reproductive medicine. I'm also the chief medical officer of Modern Fertility. Our esteemed faculty includes Professor Yuval Yaron, who is board certified in both OBGYN and clinical genetics, and is the director of prenatal genetic diagnosis unit at the Tel Aviv University at the Sourasky Medical Center. He is also the chairman and organizer of the Cogen World Congress. Dr. Santiago Mané, known as Santi, is from Catalonia and got his PhD at the University of Pittsburgh and became the director of PGT at St. Barnabas in 1995 and developed the first test to detect chromosomal translocations. He is also the co-founder of Reprogenetics until it became part of Cooper, and also co-founded several other companies. He is the adjunct professor at Yale and has published multiple publications, some of them landmark papers in the understanding and advancement of preimplantation genetic testing. Dr. Tony Gordon is a PhD in molecular cytogenetics and has a huge experience of over 20 years in molecular diagnostic. And he started the 24-Sure product line within Blue Genome, aiming to bring the Blue Genome's copy number microarray expertise to preimplantation genetic screening. At the time it was called PGS and now it's PGT-A. He is currently the director of clinical operations at Cooper Genomics and is leading the Cooper Genomics global business development outside of the United States. It is a great pleasure to welcome Professor Dagan Wells, who has been actively involved in PGD, then PGT, and the study of human gametes and embryos for the last 25 years. Believe it or not, he is actually not that old. He spent several years at the University College of London, where he accomplished the first comprehensive chromosome analysis of cells from human embryos. And later he joined the faculty of Yale and served as the director of Reprogenetics, one of the largest providers of PGD, PGT services. And now he's associate professor at Oxford and has published extensively in our field. So with this esteemed faculty, I would like to turn to our first speaker, Professor Yuval Yaron, who will give us the introduction of Genetics 101, the very basis for what we're going to discuss in the following talks. At the end of the specific presentations, we're going to have a panel discussion, very exciting, on CRISPR as it applies to embryos, since it has gotten such huge exposure in recent days. And I encourage all of you to stay tuned. Thank you.
Hi, everyone. Welcome to this course, Genetics 101, Basic Genetic Principles for the Practitioners. My name is Yuval Yaron. I'm Director of Prenatal Genetic Diagnosis Unit at Tel Aviv Sourasky Medical Center. And these are my disclosures. I'm a member of a clinical expert panel for Illumina. I'm chairman for the Cogen World Congress, and I'm consultant for Genox Company. And this is the Tel Aviv Medical Center where I work. So let's begin. Genetics began as an observational discipline with Gregor Mendel working his way with peas and other species. Basically, we observe a phenomenon, for instance, parents and offspring, and we look at different traits or conditions and try to resolve the patterns of inheritance. But in the past, there was very little that we could do. But with the discovery of DNA and the molecular basis of inherited diseases, we now see genetics as an interventional discipline. To understand the structure and the hierarchy of the genome, it's best to use this example. We look at the genome as an encyclopedia with 23 pairs of chromosome, just like having 23 pairs of volumes of an encyclopedia, where each chromosome is one volume, and just like a volume has many pages, so does a chromosome have many genes. And the gene is basically a recipe which provides the body with information for making a product, usually a protein. There are a total of about 3 billion base pairs in the genome, and the exome is only a part of it. The exome, which encodes the proteins, comprises only 1 to 2% of the genome. It's about 60 million base pairs. The gene undergoes transcription with RNA polymerase to produce a messenger RNA, and the messenger RNA is translated into protein by the ribosomes. Genetic diseases and genetic aberrations are therefore caused by various levels of disruption, either at the whole chromosome level, at the submicroscopic level, or the actual sequence variants. So let's begin with the chromosomal aberrations. These can be discovered using standard cytogenetics techniques. These are virtually unchanged over the last 40, 50 decades. It's time consuming. It usually requires cell culture. It's labor intensive, and the problem is it has a limited resolution. It can only detect changes that are 5 to 10 megabase and above. A megabase is a million base pair. However, even with this technology, one can detect numeric and structural abnormality. Numeric abnormalities include the common aneuploidies, such as Down syndrome, trisomy 21, trisomy 18 and 13, and obviously the sex chromosome anomalies like Klinefelter and Turner syndrome. But we can also detect a mosaic state. A mosaic state is a condition where there are at least 2 cell lines with different chromosome constitution, such as a mosaic Turner syndrome or a mosaic trisomy 21. The consequences of mosaicism depend on what chromosome is involved. Some are more harmful than others, on the percentage of abnormal cells, but there's no direct correlation, on the tissue distribution. For instance, is the mosaic only in the placenta? Is it in the fetus, or both? And other ramifications such as uniparental disomy, etc. However, it's important to recognize that majority of mosaicism that is identified does not presage an abnormal baby, and that's true. So mosaicism can be viewed as something almost physiological if it's in a low rate. How does mosaicism occur? There are 2 major pathways. One is what we call mitotic or post-zygotic non-disjunction. We start on the left with normal male and female gametes and normal zygote. However, during a later stage of mitosis, one cell has non-disjunction, producing a trisomic and a corresponding nullisomic cell line. Usually those nullisomic cell lines are don't develop, and therefore in this individual we'll have a combination of normal and trisomic cell line. This is one mechanism. The other mechanism is meiotic non-disjunction and trisomic rescue. In this case, there is non-disjunction during meiosis, producing a diploid gamete. And after fertilization, we have a trisomic zygote. The trisomic zygote will develop into a trisomic fetus, usually will result in a miscarriage unless it's a tolerant chromosome like chromosome 21. However, sometimes the extra chromosome goes missing. And therefore, we remain with a trisomy and a disomy, and this is called partial trisomic rescue. This sometimes results in uniparental disomy if both of the remaining chromosomes are from the same parent. So we talked about the chromosomal aberrations that are numeric. Now let's view the structural chromosomal aberrations. The most common and well-recognized are reciprocal translocations. They occur in about 1 in 500 individuals. A reciprocal translocation, a balanced one, is the result of breakage and transfer of part of the chromosome arms to create this situation. This is balanced because there's no extra or missing genetic material. However, after fertilization, sometimes we remain with an unbalanced offspring, and this will either result in lack of implantation, early miscarriage, or in some cases, even the birth of affected unbalanced offspring. Moving next and diving deeper down into the genetic composition, we find submicroscopic changes that are less than 5 to 7 megabase. They could either be deletion or duplication. There are also inversions and so on, but let's focus on these two. In the past, and when I studied to be a geneticist, there was only a handful of conditions like the Jor syndrome, Williams, or Prader-Willi. Notice that the size of the microdeletion is quite small, below the resolution of a standard karyotyping. However, now we recognize that there are almost a limitless number of microdeletion and microduplication syndromes, and these can now be detected using techniques such as comparative genomic hybridization or chromosomal microarrays. And I won't go too much into details, but suffice it to say that then when there is an imbalance, it can be viewed as an extra copy or a missing copy. And this is usually presented in using a computer software where a deletion is described as this dip in the reading of the different markers. And you can detect copy number variants throughout the genome. In this case, it's a 22q deletion, which is characteristic of the Jor syndrome or the velocardiofacial syndrome. One can also detect variants of unclear significance like this one, so it does require additional information and annotation by the geneticist who looks at these results. Then diving even deeper, we reach the actual sequence variant. So this is a change in one of the nucleotides or a few of them. In the past, we used to refer to these changes as either a mutation or a benign variant. But according to the new American College of Medical Genetics Standards and Guidelines, one must view these sequence variants as a spectrum, beginning with a pathogenic variant, which we used to call mutation. This is a change which is 100% pathogenic, a likely pathogenic variant, greater than 90%, and then likely benign and benign variants. But most variants that are detected in sequencing are variants of unclear significance. What is a benign variant? It's a change of a nucleotide changing the meaning, but that does not change the meaning. So it's actually like two ways of spelling the same word, doesn't change the meaning. So that is a benign variant. Whereas a pathogenic variant is the same change of one letter, but this being a recipe, it would change the entire meaning of the statement. So a pathogenic variant is something that changes the either the function of the protein or its length or its expression. So just as an example, The protein that is responsible for cystic fibrosis is encoded by the CFTR gene. The CFTR gene encodes for this protein, which is a channel allowing the chloride ions to leave the cell into the lumen of the respiratory tract and gastrointestinal tract. And this causes flux of water into the lumen, producing mucus that it can be expelled. However, if there's a mutation, this channel is blocked, not allowing the chloride ions to leave the cell and not allowing the water to leave the cell, and that produces a viscous, sticky mucus which builds up inside the lumen and produces the phenotype of cystic fibrosis. This is just an example of a pathogenic variant. So how does one detect such a pathogenic variant? Depending on what is the question that is being asked, currently one can check the entire genome or just a slice of it, which is the exome, about 1 to 2%, or limit oneself to a certain gene panel, which includes only genes of interest for a particular condition, or look at one single gene. A lot of it is now achieved using next generation sequencing technology, which now enable us to sequence at one time dozens up to 100 different exomes. We next move to different modes of inheritance. How do different traits and different diseases pass on from the parents to their offspring? Beginning with autosomal dominant conditions. In autosomal dominant conditions, it is enough to have one abnormal copy of the gene to cause the condition. So looking here, the affected gene, and here in beige, the unaffected gene. So the affected father will have one abnormal copy and one normal copy, and this will result in 50% of the offspring being affected regardless of their sex. And this is a characteristic pedigree with a transfer from generation to generation. Some typical example, neurofibromatosis, tuberous sclerosis, achondroplasia, and so on. Codominant conditions are conditions where both alleles are expressed. For instance, the blood types A, B, and O. If the father is A, O, and the mother is B, O, there are different options of offspring, and both A and B can be manifest. This is just like the picture I've shown you, where the vertical and horizontal lines may be expressed separately or expressed together. So this is a codominant trait. Autosomal recessive conditions require that both copies of the gene be mutated or have pathogenic variants. For instance, when both parents each carry an abnormal copy, and they're normal, healthy carriers, they have a 25% chance of having a child affected, inheriting both abnormal copies, 50% of having carrier offspring just like the parents, and 25% of having unaffected children. This is much more common when the parents are relatives are consanguineous. And common example includes cystic fibrosis, spinal muscular atrophy, Tay-Sachs, and so on. Most of the conditions that are attested when one performs carrier screening or expanded carrier screening will be autosomal recessive conditions. X-linked conditions are limited to conditions on the X chromosome. They're usually passed on from a healthy carrier mother who has two X chromosomes to her offspring. In this case, males have only one X and one Y chromosome. So when the mother is a carrier, half of her children will have inherited the normal copy. So half of the children, both boys and girls, will be normal. But if she passes on the abnormal gene, half of the kids will inherit it. Girls will be normal carriers like the mother, and boys will be affected. There are some exceptions, but this is characteristic of Duchenne muscular dystrophy, hemophilia, color blindness, and so on. There are, however, other forms of inheritance. We call them non-Mendelian inheritance. They don't follow any one of these modes of inheritance, and I'll just show you a few examples. Fragile X is an example of a triplet repeat expansion condition. The mutation is actually an expansion of a segment of DNA that contains a tandem repeat of 3 nucleotides. In case of Fragile X syndrome, the triplet is CGG, which is repeated in normal individuals 5 to 55 times. In individuals affected with Fragile X, they have more than 200 repeats of this triplet CGG. A full mutation actually results in the condition. And there's an intermediate state, a pre-mutation, 55 to 200 repeats. And individuals who carry this pre-mutation are at increased risk of transferring the pre-mutation to their offspring, with increase in the number of repeats causing a full mutation. There are other conditions that are triplet repeat expansion disorder, just like Huntington disease and myotonic dystrophy and so on. Mitochondrial inheritance is quite unique. Inside our cells, we have energy-producing organelles. They're called mitochondria. Each mitochondrion has several mitochondrial DNA chromosomes. They're kind of ring chromosome. They're quite small, and we inherit them only through our mother, through the oocyte, and none is transferred from the father. So an example would be if the father is unaffected and the mother is affected, this condition may pass on to all kids, but if the father is affected, none of the kids will be affected. And finally, most of the conditions that we encounter, a lot of the late onset conditions like hypertension, cancer, and certain conditions that we encounter early in life like neural tube defect, cleft palate, congenital heart disease, are caused by multifactorial inheritance. So it's a combination of genetics and environment, and each individual has a certain number of risk alleles, and when the number of risk alleles increases, then the likelihood that threshold is passed, and that individual may be affected. So there's a threshold phenomenon. It's quite difficult to predict exactly who and how they will be affected. And with this, we conclude Genetics 101. I hope this information will be useful for you in understanding the next talks. Thank you very much.
Hello, my name is Santiago Monet, and I will be talking today about the STAR study and the aftermath of that study. First, my affiliations and conflicts of interest. I'm CEO of Overture Life, a company automating IVF, also a professor at Yale, and I've been involved in several companies over the years in which I'm founder, or I was the CEO, for instance, of Reprogenetics and Recombine, companies that have been involved in PGT. As you know, the rationale for PGT is that there's an increase in aneuploidy with maternal age, which translates into a decrease in implantation potential, and most of this decrease is caused by aneuploidy. However, if we transfer a euploid embryo, they tend to implant equally well at any age. Therefore, the maternal age effect, it's basically eliminated by selecting euploid embryos. Obviously, we need to still produce these euploid embryos, so per retrieval, you'll see still a decrease in pregnancy rates, since some patients won't make any euploid embryos. So PGT improves implantation rates, reduces miscarriage rates, increases live birth rates per transfer, reduces time to pregnancy, and enables single embryo transfer. However, it does not create euploid embryos, and it does not improve cumulative pregnancy rates. If we transfer all the embryos that in a cohort, one by one, at the end of the day, you'll get the same pregnancy rate, or a little bit better maybe, if you transfer them all one by one, than if you do PGT, since there may be a slight damage caused by the biopsy, but definitely you'll get to pregnancy much later if you don't do PGT. This, I think it's convincing people to do a lot of PGT, as you could see over the years, since PGT version 2 in 2013 to the latest data that is published by SART 2018. It has increased from single digits to 40% in the US, and there are a lot of clinics that are now 100% PGT. There have been many methods that have been developed for PGT since FISH. Right now, most centers are using either next-gen sequencing in different flavors of next-gen sequencing. The one that is more popular, it can detect 700,000 independent signals per embryo, and has a resolution of about 3 megabases. Very few false positives and false negatives, and it can detect almost any type of chromosome abnormality, with the exception of a few polyploids, which can be now detected with, for instance, next-gen sequencing AI2, which is a combination of next-gen sequencing and SNP arrays. Not a SNP arrays. It detects SNPs in addition of next-gen sequencing. So most of the data that we'll show, it will be with next-gen sequencing, although I have some data with PGT-A too. Basically, PGT-A2, for the ones that are not familiar with it, it combines copy number screening through next-gen sequencing, but also because we get much more information with this platform. We get SNP arrays, which allows us to be able to identify polyploidy, identify where the chromosome abnormality comes from, and so on. Also, it has what's called parent sequencing, which allows us to have to read the same fragment from two sides, and therefore all those repetitive sequences that are around the genome now will be correctly identified, instead of giving us false locations in the genome. And also it uses artificial intelligence to analyze the samples. This is going to be discussed by Tony Gordon in further detail in another talk, so I'm not going to go through this too much. Regarding chromosome abnormalities that have been detected by PGT, as you know, there is a significant increase in aneuploidy with maternal age. However, we have not found differences between the number of embryos produced within every age. So let's say for a patient 35 years of age, the average would be around 47%, irrespective of how many embryos there were produced. However, obviously, the more embryos that are produced, the higher the chance that we will find a euploid embryo. Interestingly, what we've seen is that it's not that euploidy, that aneuploidy increases with maternal age, but that euploidy decreases. The number of euploid, the absolute number of euploid embryos decreases with advancing maternal age. In addition of aneuploidy, we also can detect mosaicism, as I said, and mosaicism does not increase with maternal age. What it increases is aneuploidy and complex abnormalities. And therefore, this is because obviously aneuploidy is mitotic in origin and linked to maternal age, meanwhile mosaicism is caused by errors in postmeiotically. This is the same, but analyzed by karyomapping. Karyomapping, it's only based on SNPs, and again, as you could see, aneuploidy increases with advancing maternal age, but mitotic errors, they don't. Also, interestingly, we had some data on in vivo generated embryos that was using the PreVivo platform, and what we found is that there was basically the same rate of chromosome abnormalities in vivo and in vitro embryos. Regarding mosaicism, and this has been now an issue of big debates in the field, this is not an abnormality that we are detecting now and that it has been invented by next-gen sequencing. Mosaicism has been detected by other platforms for many years when we were doing FISH. It was a common discovery in embryos, especially since we were able to analyze each cell individually. Now, by doing molecular techniques, we put several cells in the same tube, and you get an average. With next-gen sequencing, we can distinguish between 20 to 80% of cells are normal in an embryo. However, it's important to know which technique you are using, because some techniques detect mosaics and others don't. For instance, qPCR was not detecting mosaics, and also what the center that you are using is reporting. So some centers report different rates of mosaicism, and now the tendency seems to be narrowing what is reported as mosaicism. Before it was between 20 and 80%, and now a lot of centers are doing a cutoff at 50%, and below they call it euploid, and above they call it abnormal. As you know, Gray et al. Were the first to consciously transfer mosaic embryos, and they found out that some of them can reach term. I say consciously because we've been transferring mosaic embryos since the start, or when you don't do PGT, you're transferring them. There have been now close to 10 papers showing transfers of mosaic embryos, and here, as you could see, the majority of them have detected that there is a significant difference between the implantation of mosaic embryos and euploid embryos, and also significant differences between embryos that are mosaic with a high percentage of abnormal cells compared to embryos that have a low percentage of abnormal cells. This is a paper that we published this year, and as you could see, we found that mosaic embryos implant less than euploid embryos, miscarry more, and have a lower ongoing pregnancy rate, but still is a significant ongoing pregnancy rate. 37% of them can reach term. And at ISRM, we just recently published this poster, in which we reported 1,000 mosaic transfers. And this is a multi-center study, and all use a very sick Illumina platform, and reported mosaics ranging from 20 to 80%. And what we saw is that depending on the percentage of mosaicism, and here we classify it as low or high, and the threshold is 50%, there is a significant drop in implantation potential the more complex and the higher the level of mosaicism, the lower the potential of implanting and ongoing pregnancy. Compared to, therefore, to previous platforms, let's say RSCGH, the papers so far published or studies published show a trend that shows that next-gen sequencing increases ongoing pregnancy rates because we have a better selection of these mosaics. And recently also the group of NYU using PGT-A2 found a significant improvement of using this platform over the previous next-gen sequencing platforms. So there was a significant ongoing live birth and also a significant decrease in biochemicals. There was one non-selection study also by Capalvo, an interesting paper in which they showed that in low mosaics there was no difference between euploids and low mosaics in terms of ongoing pregnancy rates, which is similar to what other studies have also found. The more complex is the mosaic and the more abnormal cells, the lower the chance that this mosaic embryo will implant. Regarding follow-up of these mosaics, this I think is the only study or one of the few studies that has a sizable amount of amniocentesis published, and basically all of the babies born so far have been normal with exception of one, and the abnormality was not one that could be detected by the platform, and it was not related to the mosaicism. And as far as I know, there is only one paper showing that one mosaic embryo was transferred, and then the baby also had the same mosaicism. This is a paper by Semra Karaman, and actually the baby was normal phenotypically. It had only 2% of mosaic cells. So putting all this data together, basically only 0.2% of these embryos that were classified as mosaic on a blastocyst stage, the mosaicism persisted to the baby, which is very similar to what you find in a normal euploid embryo, 0.2%, 0.1%. Regarding transferring abnormal embryos, and as far as I know, there are 4 studies that have published some transfer of abnormal embryos. As you could see, 94% of the embryos that implanted miscarried. Only 2 reached term, and 1 of them was abnormal. So definitely we don't recommend to transfer abnormal embryos, fully abnormal embryos. We need to distinguish between mosaics and fully aneuploid embryos. There are some peers that are trying to confuse these, and a mosaic embryo is not the same as an aneuploid embryo, as you can see here. Also, there are iatrogenic causes of chromosome abnormalities. This is a study that we did in which we used egg donors to compare different centers. And as you know, egg donors, more or less, they all are young. They have been selected in the same manner, and therefore is a good group to compare different IVF centers for different parameters. And what we found is the aneuploidy rates between these centers range from 18% to 60%, so a huge difference. Also, in other studies, we saw that it's not only aneuploidy that changes between centers, but also mosaicism. And in this study, the McCulloch et al. 2019, we found that this was correlated with the fraction of HMG of the gonadotropins. The more HMG, the lower the aneuploidy rate that we found. There was another paper by Irani et al. Showing no differences in chromosomal abnormalities related to hormonal stimulation, although they didn't report HMG. So, also, there are other factors that impact chromosomal abnormalities that are lab-related, not hormonal-related, such as temperature, changes in pH, percentage of oxygen, osmolarity, and also depending on the type of media used. So even continuous versus sequential media, there have been at least 3 studies showing that you could produce more mosaics and more biochemicals with one media or the other. And also low lactate versus high lactate also seems to have an impact on chromosome abnormalities. And definitely plastics, this is something well known for a long time. There are plastics that produce chromosomal abnormalities, so we have to be very careful in which plastics do we use in the lab. But also, is it possible that some biopsies, if they are not performed properly, they can create false profiles that would be abnormal. For instance, in this sequence, as you could see, depending on the quality of the sample, it begins to produce chaotic profiles that could be classified as mosaic. Meanwhile, it could be caused by the biopsy itself. So we need to be careful about that. So overall, the results of all the clinical randomized trials that have been performed with PGT all point out that there is a significant improvement in results, at least in some age groups, definitely in all of them that were above 35 years of age. But the largest one was the STAR study. This was what we'll call a real-world study. There were 34 IVF centers involved, 9 PGT labs using the same platform. However, it excluded patients that were older than 40 with repeated implantation failure, repeated pregnancy loss. These are 3 groups that obviously are benefited from PGT. And also it included more young patients than older patients. And what we found is that when you transfer a euploid embryo, they implant equally well at any age, so 49% and 51% for these 2 age groups. And we found a significant improvement in results in the older group, from 37% in the controls to 51% in the PGS. However, there was no improvement in the younger group. This, however, is exactly the same as we see in the SARD database. As you know, the SARD database comprises most of the cycles produced in the US. So it's a huge database of IVF cycles. And if you check this last report, 2018, you'll see that if you select for PGT, you will see that in the young group, there is no difference. But in the group 35 and older, there is a significant improvement in ongoing pregnancy rates when we do PGT. Also, you could see that there is a significant reduction in miscarriages in this SARD database, and this also really translates into an improvement in live birth rates. Now, in the STAR study and in many of the papers that have been published, you have in the younger group aneuploidy rates that range from 20 to 40% or more. But however, we don't see an improvement, and this is very puzzling. So my hypothesis is that there were a couple of things that didn't were not done according to what we would do it today. First, it was that mosaics were not replaced in that study, so that eliminated about 8% of the embryos that could have been transferred, at least in the first transfer. But then the rest, if I calculate, and this is obviously a gross estimate of the maximum potential of a euploid embryo, which would be around 75%. The rest of what's missing, why these embryos did not implant, when we would expect that if the diagnosis should have improved results as much as we would expect. There is probably 17% of embryos, of potential of implantation that is unexplained, and to me it has to be the embryo biopsy. As I said, this is a real-world study. We see exactly the same thing in SART, and therefore, although some centers and a couple of papers and studies show that blastocyst biopsy is not damaging, that's only in a couple of centers. There haven't been studies that are real world, and I think that unless proven the contrary, I think still that blastocyst biopsy, if it's not performed correctly, it can damage embryos, and for that you need to go then to 35 and older, where you have more abnormalities to have a potential effect, beneficial effect of the technique. So what has improved and what has not improved since the STAR study? One, I think we treat mosaics better now. We know which ones to transfer and which ones to deselect. And also we have better methods of analysis that make fewer, that are correlating really pregnancy outcome with the profile of the analysis like PGT-A2, which is trained not on how we classify embryos with previous platforms, but on which embryos do implant and which don't implant. What has not improved is embryo biopsy, and actually probably it's going the other way, since the more people do PGT, the more cases you have to do in a clinic, and almost every embryologist has to now do embryo biopsy, and therefore, if it's not well standardized, some embryos may be damaged. The potential improvements to solve that, it's obviously to do non-invasive PGT. And this is, I'll talk briefly about that. This is just to show the results again from NYU, showing that by using PGT-A 0.2, you had a high percentage of euploids reported, and clinical outcomes improve versus the previous platform that was used in the STAR study. So regarding non-invasive PGT, there have been also a bunch of studies published so far, some of them with 100% correlation between the blastocyst biopsy and the non-invasive testing. Those tend to analyze at the same time blastocyst fluid and spent media. However, the biggest study is the first one by Rubio et al. From 2020, in which it's a larger study, over 1,000 embryos analyzed, and the correlation there, it's only 78%. So again, when you and this is a multi-center study. So when you expand a technique into all the labs, then is when you start seeing problems, and this could be caused by contamination and how the samples are obtained. There was a report by Huang et al. In 2019 saying that next-gen sequencing actually is more accurate than de facto than biopsy. However, I think that the study was flawed because they use different techniques to compare different platforms to compare the results. So the non-invasive PGT was analyzed with one method, and the de facto then biopsies were analyzed with 4 different methods. If you put all these papers together, you see that there is no difference between one or the other. So there are a bunch of unanswered questions with non-invasive PGT. For instance, you need to the accumulation needs to be more stringent to avoid contamination, maternal contamination, and that could have a negative effect on the embryo. You need to shrink the embryos in order to get blastocele fluid that could damage them. Most of the studies that had the best results are freezing the embryos, like in all PGT, but obviously you are obtaining DNA from those embryos because some cells die when you freeze and thaw embryos. And then it requires, or at least it seems that it's recommended that you culture the embryos to day 6, and this obviously for the lab it's a big change in protocol. And finally, I haven't seen a single study yet comparing non-invasive PGT with a control group. All the studies are doing at the same time non-invasive PGT and de facto and biopsy. So we still don't know if non-invasive PGT is going to improve results because there is no biopsy, or we're going to obtain the same results or worse. There is not a single study yet comparing non-invasive PGT with controls, and definitely we want to see that, right? And just to finalize, in addition of non-invasive PGT, there is another method that we have developed to select embryos, and this is using metabolomics. Metabolomics basically analyzes the secretion of the embryos in the sperm media, and is the closest omics to phenotype. And what we've seen with this technique is that we get a very good correlation with pregnancy. This is obviously retrospective, and we're doing a prospective study soon. But at least retrospective, we have a great accuracy identifying embryos that will implant and embryos that will not implant, irrespective if they are euploid or not. So we have a 97% correlation with that. This was presented at ISRM and got a prize this year. Was presented by Sara Cabello. And also it can detect very accurately aneuploidy or aneuploid embryos. It doesn't distinguish which aneuploid it is, but it distinguishes that they are aneuploid with 95% accuracy. So if you combine both things, because as you know, even after PGT, the best method, the maximum implantation potential that I've seen is around 75%. So 30% of euploid embryos don't implant. So if we can, with metabolomics, identify those with this index, so you can identify which are euploid, and then of the ones that are euploid, which ones are going to implant and which ones not implant for other reasons that are metabolic and are not chromosomally related. So obviously we need many more data and prospective studies to finish the validation of this platform, but it has, I think, a lot of potential. And also, it's easier to use than non-invasive PGT. For instance, it does not need to culture the embryos in small droplets. You don't need to culture the embryos to day 6. It can be transported at room temperature because they are very stable at room temperature. And it could be done in-house or could be outsourced. So we will see which of these methods, non-invasive PGT, metabolomics, or AI morphogenetics, give us the most information, or if we need to combine them all to have the best embryo selection. But definitely there is a lot of potential in non-invasive techniques. And that's it. Thank you very much. If you have any questions, I'm not going to be available for questions during the talk, but you can always email me with any questions that you have. And here you have my email. Thank you very much for your attention.
Hi, and first I'd like to thank the organisers for inviting me to talk at this Congress course on pre-implantation genetic testing. In this short out how Cooper Genomics is doing PGT-A, and then move on to how we're looking at non-invasive PGT-A as a field and our own internal data. So PGT-A is pre-implantation genetic testing for aneuploidy. Basically taking embryo biopsies and counting the numbers of chromosomes in a biopsy to see whether they're going to be normal, euploid, or abnormal, aneuploid, and then selecting embryos on. This is different from monogenic testing, what used to be known as PGT, and testing for translocations. So this really refers to just testing for the right numbers of chromosomes, testing for aneuploidy. So this is the PGT-A process as we've been doing it for many, many years. IVF, an embryo biopsy, the embryo vitrified, we run the test, and then we inform the clinician and the embryologist of which embryos are euploid normal, which ones are aneuploid. That's the simple process. The bit that's key here is the biopsy. So for many years, we first started taking one cell from a day 3 embryo, and then we moved on to taking 3 to 5 cells, maybe 5 to 10 cells from a day 5 onwards biopsy, what we call trophectoderm biopsy, which is what you can see in the picture here. So non-invasive, I'll just discuss a little bit later, but this is the key step change in this process. The rest of the process is fairly similar. So just stepping back very slightly, what's the theory behind PGT-A? Well, it's quite controversial, but in some ways very simple. What we're looking for is embryos with the right number of chromosomes. Here you can see an embryo with 46 chromosomes, and that is more likely to result in a successful pregnancy with an embryo with the wrong number of chromosomes. This particular embryo has 47 chromosomes. I chose chromosome 10 because it's not particularly controversial, but if you look at an embryo with 47 chromosomes and 3 copies of chromosome 10, there's never been a human being born with 3 copies of chromosome 10 in all their cells. So we know that that is not an embryo that you should choose to transfer. So what else can happen? Well, if you do have aneuploidy, you might get failed implantation, you might get miscarriage, or you might get genetic disease like trisomy 21, Down syndrome, and other such disorders. But this is where we are here, and this is the simple basis that we're trying to choose embryo biopsies with the right numbers of chromosomes. Now, it's never that easy because there's other things like mosaicism that I'm not going to talk about here, but certainly this is the basic theory. And over the years, we've done hundreds of thousands, if not millions of biopsies, and you can see that you get things like this graph here, where as maternal age goes up to the right from 35 to 42, the number of normal euploid embryos decreases from roughly half down to 13%. So you can see it's harder to choose a embryo suitable for transfer as maternal age goes on, and that's what we expect as fertility decreases with, maternal age into the late 30s, early 40s. And one of the primary reasons for this is aneuploidy, and we can see that going up here. Mosaicism, not for this talk, but an interesting subject nevertheless. So that's the issue and how we've been addressing it. I'll just talk very briefly about our PGT-A platforms, because it's going to be interesting as how we've applied that to the issue of non-invasive PGT-A. So we have this platform called PGT-AI, AI standing for artificial intelligence. So this was built on a different premise. So what we did was you have to have a model normal system of to control to see whether you've got gains or losses of chromosomes. And people have done that in the past using things like cell lines to get a baseline, but we took a different approach here, and we took 1,000 embryo biopsies that resulted in live births or sustained pregnancies, and that became our baseline. And from that we could then decide whether things were gained, extra chromosome, or lost chromosome, and we then went on to validate that with sequencing data from 10,000 embryos. And this is all done statistically. There's really no human intervention, so it tries to remove the subjectivity of people analyzing this data, and it avoids errors like transcription when you're writing the results. And this just shows you the way that we do things now. We do a biopsy, we amplify that biopsy, we run it on a next generation sequencer, we create a mathematical model, the AI chooses to say whether that embryo is euploid or aneuploid, and writes the report and goes to the clinician. Really quite an advanced system. We've moved on from that initial system to sequencing and a more advanced AI. So exactly what does that do and how does that differentiate? Well, without going into too many details, because this talk isn't particularly about our sequencing, it's more about non-invasive, we sequence about 10 times more than we used to sequence. We sequence from both ends of the DNA, and one of the things that this allows us to do, so we get roughly 8 to 10 million read pairs in a sequencing reaction for every embryo, and we're able to count both gains or losses of chromosomes, what we call copy number changes, but also SNPs, individual base pairs. So we have two independent methods for confirming whether a chromosome is euploid or aneuploid. It also allows us, the way we can use it, to look for things that you wouldn't be able to see just by counting the chromosomes. Haploid, that's where you have 23 chromosomes, and triploidy, where you have 69 chromosomes. Either male triploidy, which is 69 XYY or XXY, or female triploidy, which is 69 XXX. So it has unique features in that we can do two detection methods at the same time for any sample. We can also look at the origin of aneuploidy, and coming up we'll also be able to look whether the correct gametes were used to confirm parentage. The other thing which is useful as well actually is maternal cell contamination. So we can see whether that biopsy was just from the embryo or whether there was any DNA from the cumulus cells. I'll come back onto that when we talk about non-invasive PGT-A. So we use the same platform as before. We sequence much more accurately. We do our two tests of counting the chromosomes, copy number variation, and SNPs, and it gives us these two independent methods. And just as an aside, we've also seen actually this technology is benefiting in outcomes, and we have a webinar from our latest data presented at ASRM. So this is the basic summary: two independent methods, deeper data analysis, triploidy and maternal cell contamination, allows for parent of origin testing, so we can say whether an antibody was maternal or paternal in origin, and you can validate to see whether your 2PN check was correct. So that's the basic summary of the field of PGT-A in a few moments, and a little bit of the discussion about our technology. But let's talk about non-invasive PGT-A. So we know that taking a biopsy has to be done very carefully. It has to be done by a skilled embryologist, and there's some evidence that taking a biopsy from the 8-cell embryo at day 3, the blastomere, can be detrimental to the development of the embryo and result in lower implantation. There's less evidence that taking a biopsy of the trophectoderm at day 5, 6, 7 is so detrimental to the embryo. I think there's good evidence to show that it isn't, but it's distinct, absolutely 100% proof, and it has to be done well. The trophectoderm goes on to form the placenta, so the idea is that it's less harmful to the embryo, which is the inner cell mass, which goes on to produce the fetus. So there's been some discussion for a while if we could do something that didn't involve taking part of the embryo. This is non-invasive PGT-A. So the whole field of non-invasive biology is fascinating. There's a whole raft of applications of this, not just in reproductive pre-implantation genetics, but also in other areas of reproductive biology. The one that you might have heard of most is non-invasive prenatal testing, where later on in the pregnancy, DNA leaks from the placenta into the maternal bloodstream, and you can take maternal blood and use that to screen pregnancies for things like Down syndrome. Also, really interesting observations, things like cancers leak DNA into the bloodstream, and you can use blood tests now to screen for cancers, even cancers of unknown origin. You can use it for kidney function, to look at how transplants are working, heart disease. The number of applications is growing. One of the really interesting applications, and the main thrust of this talk, is to use non-invasive biology techniques to replace invasive biology for PGT-A. So what do we mean? Well, this little diagram here shows you us looking at a blastocyst under a microscope on the left here and taking some cells from the biopsy. But what we can also say now quite clearly is that as embryos grow, they secrete DNA from the embryo into the embryo culture media. And if you take some of that culture media, there's very, very small amounts of DNA, but you can take that DNA and analyze it as an alternative to the invasive trophectoderm biopsy. This information has been known for some time, 7, 8 years. So it's clearly not the easiest test to develop because the information has been known for some time, and people have taken samples from the blastocele fluid. That's the interior of the hollow ball of the trophectoderm, or from the media itself. And there are particular things that you have to look at to do this, but it's an interesting field with a huge number of research publications coming out, and some people offering this as alternative testing to a trophectoderm biopsy. This particular graphic, just taken from the paper of Kuznetsov et al., which came out a couple of years ago, shows the alternatives. You have trophectoderm biopsy at the bottom left here, where we're taking the cells from the biopsy. And in the red box above there, you can see taking the culture media from an embryo. Usually, you grow the embryo and you'll do a change of media at day 3 to day 4, and then culture that embryo to day 5 to day 7. Take the embryo out of the culture media, vitrify it, and then test the remaining culture media. The process largely at that point, whether you've taken the DNA in the culture media or the DNA in the biopsy is the same. You amplify the DNA, we use sensitive next generation sequencing techniques to count the chromosomes, and then you might have an embryo selection to say whether there is a euploid or aneuploid embryo. That's the theory. There have been, as I said, large numbers of publications here, from the early publications that used blastoceal fluid, that fluid from the interior of the blastocyst, like the Januarola publication, to the very first publications that showed that there was DNA in culture media and you could get an amplification, albeit with very low success rates, from Shmonky et al. And then you can see there have been, to that point and well into 2020, a large number of publications. What most of these publications have done is take a trophectoderm biopsy at the same time as taking a sample from the culture media and compared it for concordance, and with the objective that you should have high levels of concordance between the culture media and the trophectoderm biopsy, not least for gender. That's pretty important. It can't really be a different gender between the two biopsies, but for all aneuploidies. And you can see that getting sort of over 80% towards 90% is probably the limits of the technology where we are at the moment. And that's something that I think is going to be a challenge for us. So this is from a paper of Rubio et al. And I just put it down here because it also shows the difference between culturing from day 5 to day 6 or 7. And you can see that there was about 115 blastocysts analyzed here for the cell culture media. And the concordance increases from day 5 to day 6, 7, with complete concordance with sex in the low 60s to the mid 80s. And the reason for this simply is that there is more cells in that day 6, 7 embryo than there is in the day 5 embryo, and hence we think just more DNA is shared, and actually you're going past the sort of limits of detection of DNA amplification and sequencing at day 5 to having enough DNA to make a result at day 6, 7. And actually others have shown if you go to day 7, the concordance gets even higher. The problem is, and there's always a problem, embryologists like to culture embryos really to day 5, maybe to day 6, but certainly they don't want to deal with hatching blasts at day 7. So although day 7 might be the ideal time for the embryologist, for the non-invasive PGT-A lab, day 5 might be the ideal time for the embryologist, and that is a little bit of a dichotomy. So there are issues with non-invasive PGT-A that we have to overcome. First of all is maternal cell contamination. So when you get that oocyte, and especially for ICSI, you strip it of the cumulus cells to do your ICSI, it's very hard to get rid of all that cumulus cell DNA. And that DNA is maternal in origin. And it can persist to the point of when you do your sample culture media collection, there's still maternal cell contamination there. And it's one of the reasons why we do that wash at day 3 or day 4. And it can lead to false positives of euploids that are 46XX or discrepancies between sex. So that is clearly a problem, to remove as much of that maternal cell contamination or deal with it in some way. Also, time in culture media to get high success. High success means high levels of amplification, high levels of reported results. And that's very hard, frankly. And I think most publications, if not all of them, have shown that's very hard to do with day 5. And people are moving towards day 6 or day 7 culture. Day 6 is still somewhat compromised for the embryologist, though. A lot of embryologists like to culture just to day 5 and vitrify or transfer. So there's issues there with that. Another one is culture media droplet size. So put simply, if you can culture in your embryo in a smaller volume, then you can put all that volume into the WGA, and increase the relative concentration of DNA you have to amplify. If the culture media droplet size is large, you can only use a proportion of that to amplify the DNA, and you've effectively diluted out the DNA from that embryo. So an embryologist might want to do 50 microliter droplet size, but for the non-invasive PGT-A lab, their ideal might be 10 microliters. And the problem with small droplets is you can get rapid changes in pH and they're harder to handle. So again, there's this push and pull between what's good for non-invasive PGT-A and what the embryologists like. The other thing as well, at least once you've got to the media change at day 3, day 4, you have to culture in single embryo droplets. And quite a lot of embryologists like to do group cultures of embryos because they feel that there's community embryos that help them grow. So single embryo culture is frowned upon by some, but fine with others. And then we have that media change. So, you know, some people think that anything where you're taking the embryo out of the incubator, doing a manipulation isn't great to embryo development. And then what we've also seen is an increased no result rate compared to invasive biopsy. So in our hands, our no result rate for a trifectoderm biopsy is just over 2%. Whereas most people are reporting no result rates of 12, 15%, which means that, you know, 1 in 10 of your embryos, maybe 1 in 8 of your embryos isn't going to give you a result. And nobody likes to see that in a test. So what we'll need robust amplification in order to get a test that's accepted by embryologists and clinicians. We know from the publications that DNA concentration is a significant determination of non-invasive PGT-A success, but how much, and can we quantify that? We know our best concordance of cell culture media trifectoderm across a lot of papers is about 80%, 90% at sort of the top level. Is this actually the limits of biology? You know, is the cell culture media the same DNA as trifectoderm DNA, or does it represent the inner cell mass? It's a question that we haven't really resolved. It could be if it is representative of the inner cell mass, then it's never going to be 100% of trifectoderm. I mean, we have publications where we've looked at inner cell mass versus trifectoderm and seen in the high 90s concordance. So can we get to that level? Is it the spent culture media that's the problem, or is it a biology problem? And I think this is just saying it's an era of intense research into non-invasive embryo testing. And it's something that we've been doing here at Cooper Genomics. So we've been taking our technology, and one of the things that's really important here is we've been doing maternal cell contamination testing for some time, and that applies beautifully to non-invasive prenatal testing. So we did some initial studies, validations to get this working, but in a white paper that we released at ASRM, we describe an all-comers study where we went to 4 centers. We gave them no real criteria for this. We let them make their own criteria. So you can see that center C and D did the media wash at day 3, center EF did it at day 4, and then there was harvesting either at day 5, day 6, day 7, or for center F at day 6, day 7. What we did do, though, is we asked for cheek brush kits. So we got maternal and paternal DNA, and we need that in order to look at the maternal cell contamination and measure that. There was about 470 media samples in total. We had about 2% of them fail to amplify, and about 10% gave us no result. So roughly in the high 80s for actual results that we could then go on and look at. So this is some of the data. So one of the things we first did is we developed our own test, that was able to quantify the DNA direct for the media, how much DNA was there. And this is what we call preamp. So we were able to look directly at the media. It's a bit of a quirk of the the calculation that it appears some stuff is below zero, but that's just in relation to the curve that is outputted. But you can see here in the initial samples, if there was a no result, it's very close to zero, and that was statistically significant. Preamp is after WGA, and again you can see if there was no results, there was less DNA than after amplification, as you might expect. Also, we looked at DNA concentration as a determinant of concordance if it was a result we believed. In the preamp DNA, there was a trend, but not a statistically significant trend, to see the concordant results were slightly more DNA than the non-concordant results, but it's not clear-cut. And after amplification, again, it's not clear-cut. We looked at some other things. Before amplification, we looked at how long the embryos were in culture and how much DNA was produced. And you can clearly see in the first graph to the left that the day 5 embryos had statistically significantly less DNA than the day 6 and day 7 embryos. And there was no statistical significance between the day 6, day 7 embryos. After amplification, that trend continues. And you can even titrate it to time in culture quite nicely. So you can see the longer you culture, the more DNA you get, unsurprisingly. And that results in better results for those day 7 embryos. Is it a function of embryo quality, how much DNA you have there? So we looked at expansion grade, we looked at inner cell mass grade, and we looked at trophectoderm grade. Inner cell mass might be slightly better for the best inner cell masses, having slightly more DNA, but I mean, none of these are particularly striking graphs that you would lay your hand on to say that the better embryos produce more DNA. In fact, there's been some evidence presented at ASRM from the Zuves group which shows the other way, that the aneuploid embryos produced a little bit more DNA. I think it's hard to call this one. The other thing that we did was we looked at how maternal cell contamination affected the results. So in the top pie chart, you can see these were embryos that were reported as euploid female from the non-invasive PGT-A results. And in the pie chart is what their results were for trophectoderm biopsy. So half of them, only half of them came back as euploid female. So they were the concordant ones. You had some, a fifth, that were aneuploid trophectoderm. So actually the non-invasive result missed an aneuploidy. Then you have mosaic trophectoderm, again that they missed. And then even more slightly concerning possibly is the ones that were reported as male in the trophectoderm. What we also did below was when we then went on to remove the ones that had maternal cell contamination and improve these results. This time, 2/3 of those embryos were concordant for gender and for euploid. But you can still see it's not a great result. Our maternal cell contamination test is very sensitive. You can see if there is extra chromosomes in any particular way, whether there's extra X or extra Y, and you can quantify this out. So that it's really important when you look at the day of collection. So samples with high contamination of maternal DNA was more than 50% at day 5, but went down to under 20% at day 6 and less at day 7. And this is one of the reasons why we think you get a better concordance at day 6 and day 7. Simply, there's very little DNA and high levels of maternal DNA at day 5. Putting this all together, how did our test do? Well, you can see as you went on the top left-hand bar here, when you went from day 5 to day 6, day 7, concordance increased. And clearly day 7 is pretty damn good, 90% concordance. Problem is, of course, that people don't culture embryos to that point. And if you remove the maternal cell contamination, the results get a little bit better, up to 90%. But day 5 really is troubling and not particularly much better than day 6. When we did that by different centers, you can see that there's real differences as well. And clearly there are embryological differences between these different centers that give this difference. So center F really never got above 60%, whereas centers C, D, and E, particularly with the maternal cell contamination removed, were all over 75%. And if you looked at their day 6, day 7s, you'd see over 80%. So it's a compromise as things stand. So day 6, day 7 is better than day 5, and you have to get the embryology right. But overall, from our results, and particularly considering that we're the only people at the moment that can really remove these maternal cell contaminated samples, we're at 76%, which is not really good enough for a test as things stand. Things might improve, but it's problematic. So in summary, we have a robust amplification. We can amplify 98% of samples, and there's some versatility in embryology protocols. We don't have to have a change on day 3 or don't have to have a change on day 4, and we don't require specific things. All our samples came from 25 microliter droplets. Still 10% of samples did not result in informative results. So 12% in total are not going to give you a result, and that's a tough thing to say to somebody before they start a test. We analysed 470 samples from 6 IVF centres. DNA concentration, as others have found, is a significant determination of non-invasive PGT-A success. There is a threshold to the current technology whereby if it's below that threshold, you are not going to get a result that either amplifies or is reduced in noise so much that you can read it or is concordant. DNA concentration and timing might reflect or be indicative of embryo biology. Clearly, day 5 embryos don't have as much DNA in the media as day 6 or day 7 and still have an amount of maternal cell contamination which limits high detection. So also concordance is about 80% in the best case. Maybe we could go up to 90% in day 7s, but we're never going to do day 7s. So there is a potential for improvement of embryology and informatics, but it's also that question of, can it ever be as high as trophectoderm and inner cell mass? Because where's the DNA coming from? Nobody really knows that. So where are we? Well, clearly it's an interesting time. There are people who have released tests. Some of those tests have been controversial. At Cooper, we haven't released a test yet. We're still looking at this area. We still want to get the tests improved to the point that we think they are robust and reliable. And this is really just the tip of the iceberg of research into non-invasive PGT-A. And I think it's going to be an interesting run for the next few years. And with that, I'd like to thank the organisers, and I hope you've enjoyed this presentation.
Hi, my name is Avner Hirschlag, and it is my pleasure to present this next half hour on an update on pre-implantation genetic testing for monogenic disease. A recent patient of mine, 30 years old, had a husband with myotonic dystrophy. The affected family members include brother, a sister, a brother, a father, 4 paternal uncles. And we biopsied the embryos. There was only 1 normal embryo, and the patient conceived. The parent has a disease, and the child will no longer have it. This is why we do PGT-A. So what I'd like to discuss in this presentation includes the following: the significance of expanded genetic screening. I'd like to touch upon the ethical dilemmas of PGT-A for late onset disease, to recognize the importance of detecting X-linked disease in patients and egg donors. I'd like to propose ways to increase cancer gene detection, debate the issue of transferring affected embryos, and last but not least, discuss what is next for PGT-A. So a recent case I had are patients, both of them in medicine. One is a doctor, one is a nurse, and they came to me, already had one child, and they had already been screened in a very well-known institution outside of New York. The wife was the only one who was tested for genetics. She had no pathogenic mutations, and the husband wasn't tested. So I insisted on testing both of them with an expanded panel that we use. It's over 280 genes. And in fact, we found that the wife had an unusual mutation for cystic fibrosis. We screened the husband, a physician, and we found that he actually had the Delta 508 mutation. So, of course, they needed PGT-A, and that's just to remind us that the CFTR mutations, there are more than 1,700 mutations. So in a study that we published quite recently, we just compared two panels that had a lower and a higher number of genes tested. And we found that the couple incidence, so the incidence of where both husband and wife carried a mutation for the same gene, more than doubled, almost tripled when you increase the number of genes screened. So about half of the couples would have been missed with the lower level of the panel. So I'd like to talk about what we do with Huntington's disease with PGT-A. A patient that came to me very soon after her father passed away at the age of 64. Very sad history with him passing from Huntington's disease, and the mother and maternal grandfather also died from presumably Huntington's disease. So the patient wanted to have genetic screening of her embryos so she will not have a child sick with Huntington's, but did not want to know whether she has the gene or not. And this is to remind us of this is the Huntington brain versus the normal brain. And here is the abnormal gene. It codes for Huntingtin protein. And you can see that there's a difference in the CAG repeats and therefore a change in the protein that leads to neuron degeneration. And there's a difference in the general history of the disease, which starts with some prodromal symptoms. As you know, the typical thing is the chorea, kind of the dance of death, if you want, preceding further deterioration, impairment on the motor, cognitive, and dementia fronts, and ultimately death. And you can see that the course is variable, and the average age would be, the mean age would be 45 for the typical adult onset. This woman came to us at the age of 33. So what about PGT-M for adult onset disease. So the ASRM committee supports doing PGT-M for adult onset disease because of the following reasons: reproductive liberty, the right of the child to an open future. Some people interpret open future a different way, like saying, oh, open future for an embryo means that you don't manipulate it genetically, where we're not manipulating, but we are diagnosing a disease that could kill him in what would otherwise be the middle of life expectancy. Families that don't have that, that don't have PGT-M, will be stressed until the age of 18, which is the age the academic, the pediatrics academic is recommending to, for the first time, to do genetic testing for the child. Other considerations are the lifetime cost of the of taking care of a diseased person, and it is thought that discard of embryos via PGT-M is more ethically acceptable than prenatal diagnosis followed by termination. Arguments against PGT-M cite, what if effective treatment comes up? Well, for Huntington's, we can say that so far that hasn't happened, but the way science progresses, you don't know. And then the other thing is, who are we to determine that the normal life for several decades is unworthy? The next thing is obviously variable expressivity. Now, if you talk about adult onset disease, and we'll talk about BRCA a little more, there are genes that increase the risk for disease, but it is uncertain that there will be a disease for sure, in the BRCA case, cancer. And then another issue is, are we devaluing the lives of the parents? So if you have a parent with a disease, like I showed you the very first case, the myotonic dystrophy, by trying to create a child who doesn't have it, how does it make the parent feel? You could look at it both sides, because if a parent is suffering from a disease, maybe they really want their child not to have it. But on the other hand, many parents want the child to be like them. Another issue is, unfortunately, still misdiagnosis, and another unfortunate issue is access to care and the fact that it's expensive. So how do we defend the fact that we are, that the patient does not want to know if she has the disease? We know that knowing that you have Huntington's disease, for example, is associated with depression and even suicide cases. So the testing that is prevalent now is exclusion testing. And in that testing, all the embryos that might be affected are excluded. And if neither parent is affected, it's actually superfluous and you're losing embryos. Because we didn't test the, if you want, the index case, and therefore we don't really know if she has Huntington's or not. But the advantage is that her genetic status will not be known, not even to the staff, the embryologists, the geneticists, and therefore you don't have a non-disclosure situation, which a previous approach involved. So what we do basically is that in the genetics lab, in the Huntington case, it is chromosome 4, and you have the affected allele here of the father. So in fact, what is going to happen is that you have embryos that are at high risk and embryos that are at low risk that do not have the affected allele from the father. Only the low risk ones will be used for IVF, and therefore we can be sure that the disease is not transmitted to the embryo at the cost of losing half of the embryos, not knowing whether they are affected or not. So the patient has the right not to know with her autonomy, and she doesn't want to have an unencumbered and undesired knowledge, which may foreshadow very unpleasant life and death. Her plans for life may be affected. As we said before, she may be depressed. And autonomy as it relates to genetics is the right to choose to know or not to know one's genetic status. Interestingly, an abstract in the last ASRM showed a group that reviewed a group that had 25 patients that underwent this kind of genetic testing of embryos, exclusion-based. Most of them, the great majority, were Huntington's disease. You see here 19 cases. But look at all the other terrible diseases that they excluded for: spinocerebellar ataxia, and then polycystic kidney, amyloidosis, and Creutzfeldt-Jakob. This is the genetic type of the mad cow disease. So the abstract was not about that. The abstract wanted to show if you do exclusion, how many of them end up having at least one euploid embryo, because they also tested for chromosomes. And luckily, the great majority, you can say 3/4, did have at least one euploid embryo. And by the way, that, as expected, that changed with age, so that for younger women, less than 30 years of age, and remember, these patients come because of genetics, not because of infertility typically, it was 83%. 5 out of 6 patients had a euploid embryo to transfer. And of course, the chances of pregnancy are very, very high in these cases, euploid embryo in a young woman. And then it went down a little bit with age. It was only 60% for women over 35 years of age. This was an abstract at ASRM, but I think it has a lot of very valuable information. So what about X-linked disease? So sometimes, unfortunately, X-linked disease is discovered only when a child is affected. And in this case, my patient, the child born completely normal, within several days died of brain hemorrhage. He had the severe type of hemophilia A. There was absolutely no family history. And as we know, and this is the point of this presentation, X-linked genes are actually hidden in women, sometimes for many years. She requested PGT-A and A. They wanted to have a boy who that the X chromosome does not carry hemophilia. And as we know, unfortunately, many parents who lose a child want a quote-unquote replacement child. And in fact, they had a live-born baby boy and did not bleed on circumcision, which I personally attended. Usually the problem with the genetic issue with hemophilia is a very big inversion of intron 1 and 22, which makes it very difficult to include it in genetic screening testing. And as you can see, these are the different genotypes of severe hemophilia, and about 45% of them are inversions, and then we have all the rest. And just to recall, as we know, we call that the royal disease, not royal at all when someone has it, but it came from, it crossed Europe from Queen Victoria of England, and because there were intermarriages between different royal houses, crossed Europe, and then ended up in Russia with Alexis, the son of the Tsar. And some people say was the background of the Russian Revolution. So I'd like to make a case for screening for X-linked diseases. Not so simple technically, But how frequent is it? Well, Fragile X, we do screen for almost everybody, and that is the incidence of a Fragile X mutation is 1 in 5,000 live birth. Well, hemophilia is 1 in 5,000 male live births. So it's not that uncommon. Duchenne's muscular dystrophy is in 1 in 3,500 to 1 in 5,000. What do we screen for in comparison? Cystic fibrosis is one example that is included pretty much in every panel that everybody does. And that is 1 in 3,700. And SMA, or spinal muscular atrophy, is 1 in 10,000. So we had a case where a sister donated to her sister and had a de novo mutation, and the child was born with hemophilia. Fragile X is also X-linked, but a different story. We are looking at the CGG repeats, and here is a case that had 75 CGG repeats, and the risk for expansion, as we know the full expansion is over 200, was 47%. However, and this is something that many practitioners have not picked up yet, that you have to do a reflex test for AGG interruptions. And when you have one AGG interruption, you have a certain reduction in the chance of expansion, and 2 AGG interruptions have a further reduction. Now, she had 2 AGG interruptions, and therefore this woman went from 75 repeats with 47% chance for expansion to only 1% expansion, which of course would not justify doing PGD or PGT-M for the FMR1 gene. And we should just remember that it also, the FMR1 gene is also associated with a decrease in ovarian reserve, and also with ataxia tremor syndrome. So this shows you a study that we did from the SART statistics that showed the incidence of X-linked conditions that got to PGT-M. Of course, by far, the most common one was Fragile X, but then you see Duchenne's muscular dystrophy, hemophilia A, and also adrenoleukodystrophy and hemophilia B. So the next case is cancer. So this patient, an Ashkenazi Jew, was a carrier for BRCA2, had breast cancer with a modified radical mastectomy, and came for fertility preservation, and had an unsuccessful transfer of 1 embryo. And of course, this is the cancer risk for BRCA1 and BRCA2, which you can see is beyond breast and ovarian. Also, remember, it affects males as well, and is not sex-linked, so you can get it in the male as well as the female. So this patient had a husband with who was only 36, but already had colon and kidney cancer. We screened him for cancer genetics and found that he was a carrier of Lynch syndrome. The Lynch syndrome is divided into different mutations. About half are MSH2. He had a bad one. It's the MLH1, which has a higher chance of cancer, as you can see in his case. So we did IVF on this couple. Remember, she was BRCA2 after chemotherapy, after she already failed elsewhere, transfer of one embryo that was tested for the BRCA, but not for the Lynch. So we tested for Lynch, for BRCA, and we did PGT-A for chromosomes. So, and both these cancer genes are dominant. So the chance, what is the chance of finding an unaffected euploid embryo? Well, we did have one, and she delivered a viable boy without the genetic load of both parents. Just to remind us of this work, which was great, from Israel, on the incidence of the BRCA genes and the fact that this was done on Ashkenazi Jewish men without a history of cancer. And they found from this very high number, over 8,000 tested, they actually found a high number of carriers, 175. And of course, when you find carriers, and these are completely without disease and without the history, you have to test the family, and you're going to find more. So in Ashkenazi Jews, the gene is very common, considered to be 1 in 40, and they all should be tested. In the United States, it is considered to be between 1 in 300 and 1 in 500. And this is a picture of Mary Claire King, who actually found the BRCA1 gene and was honored by President Obama. There are other cancer genes. This couple came with a history. Both of them are, by the way, geneticists, and he is a carrier of the familial adenomatous polyposis, the FAP gene that, of course, leads to colon cancer. And we got 2 unaffected embryos, but they were, one had a degraded DNA. We didn't know the chromosomes, and the other one was monosomy, and they requested a transfer of a euploid embryo that was affected by the FAP gene. So this is one case. And then the other case is a woman who was 40 years old and had cancer at the age of 35, was BRCA1. We tested her embryos for the BRCA. We transferred one male embryo that was not affected by BRCA, and she had a boy. But then she had 2 euploid embryos, and she wanted the female that was affected by BRCA to be transferred. And that generated a huge discussion in our group. And the question is, why would parents request the transfer of affected embryos? And you could find many reasons, including if they're the only remaining embryos. That would probably be the main one. Second one would be either religious or psychological belief. The third one is the intentional diminishment, the fact that the parents express the gene and want their child to be the same. You may not be able to see this well, but this is from NYU. In this study at JARG, they showed all the different genetic conditions that they agreed to transfer affected embryos. So you see here that it's autosomal dominant, recessive, and X-linked. They basically have, again, BRCA1 and 2, so that's quite common, but also have Lynch, similar to our patient, and others. Big problem, big headache for us. So the committee opinion of the ASRM said that it's acceptable for physicians to refuse to transfer affected embryos if it is a life-threatening condition. However, it is acceptable after extensive counseling to transfer embryos that are affected by genes where the disease is treatable or effectively manageable. So the provider's refusal to transfer is ethical, and as usual in American ethics, we always say if you have a reason not to treat the patient, you should probably make a referral to someone who would do that. And of course, there is a huge spectrum of diseases going here from green to red of the severity of such diseases. So what is ahead for PGT-M? I'd like to show you two very recent graphics. This one, the ASHRA consortium, is very, very lengthy. They came up with a huge summary of everything that has to do with PGT-M now and in the future. And I chose only this graphic to show that maybe one of the main movements has been from targeted amplification. Targeted meaning targeted to the mutation that patients have, to whole genome amplification. And then the next graphic, again from this year, shows the overview of the past, present, and future methods of PGT-M. And as you can see here, some of the things we all know, the move in the biopsy method, and then the genetic analysis milestones, reducing the work that has to be done prior to actually doing a case. But more importantly, using to whole genome amplification, which hopefully will reduce the need to test family members and maybe to none at all. And one of the most important things that I expect this to help us do is identify de novo mutations, those mutations that you don't know about and that you want to prevent in the offspring, such as the hemophilia mutation that I described and many others. So to sum up, expanded genetic screening may be what precedes PGT-M, and it increases the detection of preventable genetic disease, and I would encourage all of you to use it. Screening patients for X-linked diseases will prevent genetic calamities, even in egg donors. Remember that the X-linked disease is hiding in females. The expansion risk for Fragile X is reduced by AGG interruptions. Exclusion PGT-M for adult onset disease allows us to diagnose the embryos and not the parent according to their request. I encourage a wider screening for cancer genes, and PGT-M testing should be a high priority in cancer prevention. Transferring affected embryos is ethically challenging. And last but not least, as PGT-M transitions to whole genome amplification, it will become simpler, faster, and hopefully cheaper with wider access. It will also allow the diagnosis of de novo mutations in the embryo. I'd like to thank you for listening. Thank you very much.
Well, thank you very much for the organisers of the conference for inviting me to give a presentation. I'm sorry I'm not meeting any of you in person on this occasion, hopefully next year. I've been asked to speak a little bit about some new DNA sequencing approaches that we can use in the context of pre-implantation genetic testing. I'll just disclose that I do work at a laboratory that offers pre-implantation genetic testing amongst other kind of genetic testing services. So during the course of this lecture, I'll talk a little bit about how PGT, pre-implantation genetic testing, how that has evolved over the years, with a particular emphasis on how it's moved towards next generation sequencing. I'll talk a little bit about aneuploidy detection, analysis of mutations and polymorphisms, and how we can combine the different types of data that next generation sequencing gives us in order to improve the accuracy of the testing that we do in the IVF lab. I'll also do an introduction to what's often referred to as third generation sequencing. This is like the latest evolution of the next generation sequencing methodologies, and maybe say a few words about future prospects in this area. So in terms of the evolution of pre-implantation genetic testing, of course, this has been with us now for 30 odd years, and began with PCR for looking at single gene disorders, and techniques like fluorescence in situ hybridization, or FISH, for looking at chromosome copy number. And for many years, these two applications, looking at genes using PCR for PGT-M, and then looking at chromosomes, have used different technologies, and so were difficult to combine together. But there's been this continuing effort to really improve the amount of information we get, and also to improve the accuracy. And this is what's really led us towards next generation sequencing, and potentially the fusion of our abilities to look at genes and also chromosomes. So one of the key things that led us down this pathway was the development of whole genome amplification. And this is a methodology that essentially increases the amount of DNA available from this minute sample. In the case of PGT, that we might biopsy from an embryo. It could just be a single cell, for example. Of course, we could potentially look at several different bits of the genome using things like multiplex PCR, but that has quite a few limitations, and it can be hard to apply to large numbers of loci, and only ever allows us to look at small individual pieces of the genome. So the whole genome amplification kind of enriched the total amount of genomic DNA present, allowing us the possibility to really look at an almost unlimited number of target sequences. That was actually first applied in a PGT context all the way back in 1996, although we didn't actually publish that until a couple of years after. Of course, it's been mostly used not for looking at mutations, but actually looking at the amounts of DNA, looking at to give us a handle really on chromosome copy number. And this again, was developed in the late 1990s, and really initially as a research tool, because really most of these methods were taking too long to apply to embryos, and freezing technologies, at least for biopsied embryos, really weren't sufficiently good to extend the length of time available for testing. So initially a research tool, but has over time, of course, become widely used for looking at chromosome copy numbers in embryos during PGT-A. The next big evolution really was to actually introduce the next generation sequencing to look at these amplified DNAs, usually whole genome amplified material, although sometimes using targeted methods that amplify potentially thousands of individual sites within the genome. So this potentially provides information not only on DNA sequence, but also on chromosome copy number. It allows for extremely high throughput if necessary, and that really helps to reduce the costs of analyzing individual embryos. We reported the first birth, or at least the first birth in the Western Hemisphere, using a next generation sequencing methodology to screen embryos for aneuploidy back in 2014. And essentially the underlying methods have not changed dramatically since that time. And the DNA is removed from the cells that we're going to test. There's not enough DNA in that single cell or few cells to visualize it directly. And so, again, either a whole genome amplification or a massive targeted PCR is used to give us access to many pieces of the genome. Those pieces are broken into fragments, and essentially we attempt to learn the DNA sequence of each one of them. So these fragments of DNA sequence are often referred to as reads, and at the end of the next generation sequencing procedure, we end up with literally millions of them. Now, to you or I, looking at this huge amount of information is a little bit meaningless. You know, how can you make any sense of it? But what we can do is feed it through a computer, and the computer can compare the sequence of each of these reads to the known sequence of the human genome in a process that's usually referred to as alignment, and essentially tell us which of all the chromosomes did that one piece of DNA sequence come from? Where did that read come from? And so we now know the origin of that one read. Which chromosome was it derived from? Which piece of which chromosome was it derived from? And we end up with literally thousands of fragments of DNA sequence on each of the chromosomes, or derived from each of the chromosomes. And we can count them and learn exactly how many fragments we got. And what we've learned is that when you've got a normal number of copies of a chromosome, say 2 copies, you get a certain number of reads that you would expect to see. But if you find more reads than you were anticipating, that's usually indicative of a gain of that chromosome. It's not something like a trisomy, for example. Whereas if you don't see as many reads as you were expecting, that is indicative of a chromosome loss. So most likely a monosomy. It's important to note that this kind of next generation sequencing approach is sometimes they call it genome sequencing, but really you're not sequencing the entirety of the genome. In fact, this is really better referred to as low-pass genome sequencing, in which you're typically only getting less than 0.1% of all the DNA sequence in the genome. That's quite important. It's more than enough sequence information to count the number of copies of chromosomes, but it's insufficient to tell us really anything about the sequence of individual genes, because the chances are a gene you're interested in won't have been sequenced. And so this is kind of useful because it means that you don't accidentally learn additional information about your sample that perhaps had never been requested by the patients. So we don't find incidental findings as such. That said, getting this information can give you some more data that can be useful, because you are getting bits of DNA sequence information. So people have developed methods like haplorhythmicity, for example, where you actually do look at single nucleotide polymorphisms in the genome as well, in order to get not just copy number information, but also potentially information about the inheritance of disorders via a kind of linkage analysis approach. If you're using a more targeted methodology, you can reproducibly, for your amplification, you can reproducibly gather information on individual single nucleotide polymorphisms. And I'll show you how that can be useful. Here's the actual PGT-A methodology that is used at the Foundation for Embryonic Competence and also at Juno Genetics. And you can see that we're measuring here the quantity of DNA at thousands of individual sites across the genome. Each site is denoted by just a small dot here. And this can tell us the copy number of the chromosomes. So if they fall along this sort of central line here, there's the expected 2 copies of the chromosome. Ones that come down here, there's just 1 copy, and also there's 3 copies if they are on this line here. So you can quite easily see that you've got a trisomy 16 here, a trisomy 18, you've actually got a monosomy 22, which I haven't noted here, a single X and a single Y, so it's a male specimen with 3 different aneuploidies in this case. So this is just, as I'd mentioned to you before, counting the number of reads attributable to different parts of different chromosomes to get an idea of the amount of DNA present. As I mentioned, though, you can get this additional information on the status of polymorphisms that maybe are also within these sequenced fragments. So we're learning the genotype of these fragments. This is from the same sample. So we're looking at these single nucleotide polymorphisms. In other words, they are sites in the genome where just one nucleotide has changed. It can be one thing or another, a G or an A, a T or a C, and so on. And what you'd expect, of course, is that some of these polymorphisms are going to be homozygous for one allele or the other, whereas others will be heterozygous. So this plot that we see here, all the polymorphisms that are essentially being denoted as AA here, homozygous, given along the top. All the polymorphisms which are BB are given along the bottom here, and those which are heterozygous, AB, are given along the middle of the plot here. And so you can see that you have an example, two chromosomes like this, with just showing three polymorphisms here. Some are homozygous AA, some are homozygous BB, and they'll be noted along the bottom, and the AB ones will be noted in the middle. Okay, that's a nice confirmation that we indeed have what we're expecting to see for most of these chromosomes. But what about if we had, say, a trisomy? Well, in this case, we aren't going to have any sites that are AA. We will have some that are still only composed of A, though. They'll actually be AAA. So these are just detecting allele type A. Some will only have allele type B detected, although in reality they won't be BB, they'll be BBB. But the key thing is that none of the sites will be heterozygous AB, because our actual embryo in a trisomic state could only be AAB, or, as in the example I'm showing you here, ABB. And so what you see is a splitting of the graph here with no sites that are entirely AB, but instead these occupations of sites denoting AAB or ABB. So it gives you, with an independent set of information, a confirmation of your initial diagnosis. And this, you can see, I mean, of course, having two sets of information is always useful for verification of your result, but actually this data goes beyond that. Say, for example, we have a result like this. If we're just looking using low-pass sequencing, which has been the tradition for PGT-A methodologies over the last 15 years or so, we would almost certainly call this a normal female. There's no Y chromosome, 2 copies of the exon of all the autosomes, or so it appears. But actually, if we look at the polymorphisms, look, we don't see any which are AB. In fact, we're getting that split that I showed you on the previous example for every single chromosome. And of course, the reason for that is that it does have 3 copies of every chromosome. It's a triploid sample. So these sorts of samples have gone unnoticed typically in PGT-A for the last few years because the technologies simply weren't able to detect them. So this is what you're really seeing: AAA at the top, triple B at the bottom, ABB here, and AAB just there. No AB calls. Here's another example. Again, you probably guessed this to be a normal female, but actually, in this case, can you notice what's wrong with this one? Not triploid this time. In fact, most of the chromosomes look completely fine, until you notice that actually chromosome 1 doesn't have any heterozygous SNPs at all, and yet its copy number seems to be essentially the same as the others. And that's because this embryo actually has a uniparental disomy for chromosome 1. In other words, 2 copies of that chromosome, but both derived from the same parent. In fact, this is an isodisomy where both of them are identical copies. Depending on the chromosome affected, this could have quite severe consequences for the embryo if there are imprinted genes, for example, on that chromosome, or recessive gene mutations on that chromosome. One more example. Here you might think that we've got an instance of mosaicism. This chromosome number 6 here, if it was monosomy, it really should come down to this line. If it was normal, it should be on this line, but it's sort of neither one nor the other. It's some way in between. So many labs would report this as mosaic for a monosomy for chromosome 6. However, the truth is revealed when we look at the polymorphisms. And here you get this kind of snowstorm effect going on. And this is because there is not just one genome in our tube. There's actually been some kind of DNA contamination here. And in fact, you can suspect that it's probably a female contaminant. So maybe from a cumulus cell or something like that, that was accidentally sampled along with the biopsy specimen. And that presence of two distinct genomes in the same tube is what gives you this sort of very distinctive snowstorm effect on the graph. The reality is that this embryo probably wasn't mosaic. Now, of course, we often would recommend the transfer of mosaic embryos these days, as it's increasingly appreciated that so many mosaic embryos have a good chance of making a completely normal baby. But if you did transfer this one, it probably would be inadvisable simply because it probably is a male with a full monosomy for chromosome 6. The addition of the normal female DNA has had the effect of pushing the monosomy back towards normality. And you can actually see that also there was probably a hint that there was something a bit odd here as well, because the sex chromosomes are not quite where they should be. As this is likely to be male, the addition of female DNA has pushed the X from one copy towards 2, and it's also depressed the Y, pushing it towards 0 copies, as it would be in the female DNA. So that's kind of where we stand right now with current sequencing technologies. We've managed to utilize these two threads of distinct information they give us on chromosome copy number and DNA sequence to get some really accurate forms of pre-implantation genetic testing for aneuploidy at least. But how else could we use it? Well, the latest innovation in DNA sequencing is what's sometimes referred to as third-generation sequencing. And these mostly focus around next-generation sequencing methodologies, so in other words, methodologies that can generate huge amounts of DNA sequence information pretty quickly and at relatively low cost, combined with an ability to do extremely long sequence reads. So many of the PGT-A methodologies that use next-generation sequencing today sequence very short pieces of DNA, from maybe 30 nucleotides up to maybe 150 or so, but little more than that. And in fact, to go much beyond a couple of hundred nucleotides starts to get progressively more difficult using the next generation sequencing technologies that have been around for the last few years. These new methodologies can potentially sequence for kilobases, those are thousands of base pairs of DNA, or even megabases in some cases, going for millions of base pairs of DNA. Some of the methods have also succeeded in eliminating the very expensive and quite large, in laboratory terms, sequencing equipment. So here's one example from Oxford Nanopore Technologies, which is a well-known one because it's able to connect to a computer just by a USB port. And so you can see it's a very small sort of handheld device that you can use for sequencing, and also has the advantage of giving you these very, very long sequence reads. These have already been applied in a PGT context, mostly in the context of pre-implantation genetic testing for aneuploidy, where really they've been touted as a way, at least this Oxford Nanopore variant has been touted as a way of maybe reducing costs by eliminating some of the high-end big-ticket equipment. But they actually also have some real potential to assist us with pre-implantation genetic testing for monogenic diseases, and that's what I would like to concentrate on really for the rest of this talk, because that's where we've been exploring them. Now, with PGT-M, we're trying to avoid the transmission of an inherited disorder caused by mutation in an individual gene. But we don't just do a PCR across the mutation site and just detect the mutation. We usually look at other pieces of DNA too. And that's because if you've got, say, a situation like this with a mother and a father, maybe the mother has a mutation on this chromosome here. If they have an affected child, maybe again, this one has inherited the blue chromosome from the mother and therefore has the mutation. Now, we could just try to detect the mutation site. Here's an affected embryo. If everything works perfectly, we'll detect that mutation there, and we'll be able to do our diagnosis correctly. But as you're probably all aware, there's a possibility when you're amplifying from a very small amount of DNA that only one of the two alleles present successfully amplifies. So you may actually fail to amplify the mutation site. This is allele dropout, and maybe only amplify from the normal chromosome. That means that when you look at the DNA, you only detect normal DNA, and you think that the embryo is normal, where if this was a dominant disorder, it would be affected. So because of this, as well as looking at the mutation site, we usually look at linked polymorphisms. So these are variations in the DNA sequence. Again, like we discussed earlier, they could be one kind of homozygote or another, or they could be heterozygous. And they don't cause the disease, but they are located close to the mutant gene and therefore are usually inherited along with it. And in this particular example, you can see that the presence of an A allele at this second position is indicative of the mutant chromosome because it's not present on the mother's normal chromosome nor on either of the father's chromosomes. So this is indicative of the presence of the mutant chromosome. Similarly, this B at the last position here. So if we looked at these in the embryo, even though we failed to amplify the mutation site, we're still able to diagnose the embryo as affected because we know that that particular chromosome is present. The only issue is there are challenges with this. It might be quite difficult sometimes to find an informative polymorphism that's actually close to the mutation. Not every nucleotide in the genome is variable. They only occur typically every few thousand nucleotides. So what do you do? Well, you can check databases that list all the known polymorphisms. But the problem with that is you're likely going to have to try out several of them before you find one that is actually informative in your family. And that means designing PCR primers, doing PCRs, doing genotyping, often just finding that the locus is not informative and having to move on to the next one. So that's a bit time-consuming and laborious and wasteful of resources. Maybe a more streamlined approach is you could use microarrays. There are microarrays available that look at thousands of single nucleotide polymorphisms scattered across the genome in one go. So that's certainly a valid approach. The only issue with that is that, again, you're not testing all the mutations in the genome. You're only testing a fraction of them. And again, some of the polymorphisms that are found to be informative may be relatively distant from the actual mutation site. And of course, the more distant it is, the more likely that recombination during meiosis will separate the polymorphism, that informative allele, from the mutation. So that can be problematic. For every million base pairs of DNA, there's about a 1% chance of recombination occurring. So of course you want to be as close as possible to the mutant gene. The final and perhaps most difficult issue is that suitable relatives may not be available for you to work out which allele of the polymorphism is actually on the same chromosome as the mutation. If you know that the mother is affected with a dominant disorder, she has type A on one chromosome and type B on the other, which is the one that's going with the mutation? The only way to find out is, as I showed you in the previous slide, is to look at another affected member of the family and see which one they've got, and then hopefully you can deduce that all the affected individuals always have the same allele of a particular polymorphism. The problem is that sometimes no relatives are available. About a quarter of all the PGT-M cases we do are for de novo mutations. So by definition, there's no one else in the family that has that mutation. It's just newly arisen in that generation. Other families, maybe the couple don't want to share with the rest of their family that they're undergoing IVF and PGT-M. So they won't allow you to approach other family members. Or other family members may be deceased, perhaps because of the condition they're carrying, and therefore there's no DNA available for you to test. So a way that you can get around all of these issues, we've found, is to use long-range sequencing that's delivered by technologies like PacBio systems or nanopore technology. The approach we've taken is something like this. Here is your DNA from your patient who's asked you to do PGT-M for them. They have a pathogenic variant on one of their chromosomes. And what we've done is we have amplified using PCR very large fragments, so about 10,000 base pairs going in one direction, and then in a separate reaction, about 10,000 base pairs going in the other direction. So really giving us almost 20,000 base pairs of flanking DNA. We've then used this very long-range sequencing to actually read the DNA sequence of these amplified DNAs and reading them in single long reads. So instead of using conventional next-generation sequencing, which would have given us the sequence information but in lots of tiny fragments, this in a single contiguous piece of information. So what we've seen using this is that when we've applied it, we've found one or more informative polymorphisms for almost all the families we've looked at, about 97% of them. On average, we find about, in this 20 kb section, we find about 12 informative polymorphisms, and this is in about 30 families that we've looked at so far. So how does that compare to some of these other approaches I've mentioned to you, like looking with a microarray? Well, we found that compared to that, the polymorphisms we're identifying are 100 times closer. So with a microarray here, we're seeing typically downstream on average almost half a megabase distance and about half a megabase, or about a third of a megabase distance upstream. This is within these same families. Compared to the long-read sequencing, which is typically finding a polymorphism within 3,000 base pairs, so close to the mutation that you can be pretty certain that this will never be separated by recombination. And so it's almost as good as looking at the mutation site itself in terms of diagnosis and accuracy. The other issue is if you're using databases to look for SNPs, well, you'll probably find that there's more SNPs in databases than there are on the microarray. So that gives you a good chance of maybe finding some of those ones that I've just mentioned to you that we found with the long-read sequencing. But the problem is that still most of them are going to turn out to be uninformative. So on average, we found that 54% of the informative SNPs that we found with long-range sequencing have a minor allele frequency of less than 0.1. That means that these are, if you looked in a database, you would see that the chances of these SNPs being heterozygous is so low that you probably wouldn't even bother to look at them. You would probably concentrate on ones that had much higher minor allele frequencies, meaning that they're much more often heterozygous and therefore informative. In fact, for almost 30% of the mutations, no informative SNPs had a minor allele frequency in databases that was more than 0.1. So it means that you just would never really choose to look at these SNPs. The chance of success with using them is too low. We also found, by doing this, 13 novel intragenic SNPs. So these are highly informative for us, polymorphisms, which don't exist in any database. They're actually within the gene itself, and so couldn't be better for this kind of linkage analysis, just as good as a mutation in terms of diagnostics, yet not present in any database or any array. So again, you know, by looking in the actual patient's DNA, you're really learning everything you need to. The final advantage is in terms of phasing the polymorphisms with the mutations, as I'd mentioned before. We're seeing everything in a single long contiguous read. So what this graph is showing, what this figure is showing, is each of these grey blocks, you can't see them because they're all sort of condensed together, but each pixel, essentially, pixel line is a single read. And where it's gray, it's no different from just normal sequence. There's no polymorphism. But where you get colors like this, you have a heterozygous polymorphism. So here, we actually have two right next to each other, heterozygous polymorphisms. Here's another one, and here's our mutation. And you can see every time we have a read that's red, remember these are thousands of reads, they've all been stacked on top of each other, but every time they're red here for the mutation, brown here for the SNP, red, and I can't quite even make out the other color there, probably another brown one next to it. So it's telling you that if red is your mutation, then you can expect to see brown here and red there. Whereas for the normal copy of the gene, maybe that's denoted by the brown nucleotide here, you can expect to see a blue here and there. So without ever looking at another family member, you've learnt which alleles of the polymorphism are associated with the mutation. This is just an example of one of the families showing you the kind of data we got. Here you've got the actual mutation site. I think this was in the neurofibromatosis gene, if I remember correctly. And you can see all of these informative polymorphisms that we found all within a very short space of DNA. So all of these potentially giving us very useful data. Now these can potentially be looked at during routine next generation sequencing or by other conventional PGT-M approaches. You could design primers for them if you wanted to. So I think this is an extremely useful addition to the way that we're developing PGT-M at the moment. I'll leave it there just because I know that I'm up to my time limit, but just to say, these technologies are still evolving. It's highly likely that we will see a complete fusion of PGT-A methodologies with PGT-M so that really a single technology delivers all of this information for us, and that will certainly help us with reducing costs and the efficiency of PGT in general. The possibilities of entire genome sequencing are really just on the horizon for us. Of course, they've been a reality for a long time in other areas of genetics now for quite a few years. But for those of us working on very restricted amounts of DNA samples, that limitation has delayed things somewhat. But realistically, the possibilities of whole genome sequencing are really just on the horizon now. And so we do need to consider, of course, how we're going to use this information and what kind of information we actually want. Do we want to really know about the entirety of the genome, discovering things that maybe are relevant to the parent's health, even though they're looking in their embryos, and finding that probably no embryo is entirely normal. So it's going to raise some interesting questions, but I think that's probably for another lecture on another time. So I'd just like to acknowledge my group in Oxford at Juno Genetics, and in particular, Megan Lever, who's a DPhil student there, just finishing up her PhD, who did most of the long-read sequencing work that I've mentioned today, and our collaborators over at the Foundation for Embryonic Competence, Chaim Jallis and Xin Tao, who have both been really helpful also in this project. So thank you very much for listening, and I hope to see you all soon.
The highlight, hopefully, of our course. It has become very relevant to discuss human genome editing in embryos this year, this specific year, because of new different events that have kind of confluented. One of them is the Nobel Prize awarded this year to doctors Doudna and Charpentier. I think it's the first time that two women were awarded the Nobel Prize without a male partaking in it. And this was long awaited for. And just as this Nobel Prize was awarded, several other things have happened. One of them was in September. There was an international consensus group, mainly from the US and the UK, but we'll talk about that a little bit later, that discussed the practicality and the ethics of doing CRISPR editing embryos at this point in time. And then in October came out this study. It actually came out a few days ago in Cell Online. And that is a study from Columbia where they tried to eliminate a blindness gene. So this is the gene EYS, located on the very beginning of the long arm of chromosome number 6, and try through CRISPR technology correct that gene and in embryos. So it was donor eggs and donor sperm, and they were trying to correct the embryos and the gene in the embryos. And what they saw, their observations, was that the most common repair outcome happened very fast, actually, in the zygote, and the restoration was without mosaicism. However, about half of the breaks were not repaired, and resulted in that same paternal allele that we didn't want, that they didn't want after mitosis, loss of one of both of the chromosomal arms. And they had off-target mutations, actually, in chromosome number 16, and loss of, and chromosomal loss. And this is the summary of their findings. So on one hand, the repair happened within hours, and the end joining provided an efficient way, end meaning that it's where the, I guess, the segment of DNA was cut. But then, on the other hand, they had chromosomal loss and off-target effects. And the summary is given here, where you see the summary of the entire experiment. Maybe at this point, the panel wants to comment.
So Amber, I would comment that I think the summary is good, but it's not even quite as good as we might think, because the repairs were not all uniformly non-mosaic in the repaired blastocyst. So moving from injecting the repair enzymes into the two-cell embryo obviously is a very, very likely to result in mosaicism. You didn't completely resolve the mosaic embryo problem with going to zygotes. So there's so many different things that actually happen to those embryos. It's a fascinating paper, but it's a very complicated set of results for those embryos.
I'd like to add that in this particular case, the mutation was a frame shift. That means that a couple of nucleotides are missing, causing a frame shift. Not to introduce a corrected copy of the gene. The trial here was actually to remove an uneven number of nucleotides, resulting in a shorter gene, but keeping it within frame. Now, this type of correction is not always beneficial. So even assuming one reaches 100% efficiency and no mosaicism and no off-targets, the question in this particular experiment is whether actually removing a certain number of nucleotides to reinstall the frame, the reading frame will actually result in therapy.
Yeah,
that's just relevant to this study.
Yeah, I think those are very good summaries of the limitations of this study. We've done quite a lot of work looking at CRISPR in embryos, and it's true that you can achieve very high efficiencies where the vast majority of cells experience an edit. But there are lots of subtleties, as Tony mentioned. This is a very complex thing. You can get over a lot of the mosaicism certainly by doing your CRISPR editing at the time of fertilization. But these reagents have a half-life, so even when you do that, there's sometimes residual activity that goes on for one or even a couple of cell cycles, certainly. So there are all these complexities. I think you can envisage that you could reach optimizations where you could be pretty sure about reducing many of the mosaic outcomes that have been seen in previous studies. But as Yuval said, this was a bit of an unusual mutation in which a whole bunch of fairly random kind of, well, not random, but reproducible indels causing a loss or a gain of one or more nucleotides could actually result in something of a correction of the massive defect in this gene caused by a frameshift mutation. Most mutations are not like that. And you would need to be also doing some kind of homology-directed repair with some kind of introduced template to actually introduce a new nucleotide in exchange for a defective one. That this paper goes nowhere near that, and that would be the kind of mutation that you'd probably want to fix most often.
So I have a question to you guys. Based on what Yuval pointed out, and I think that Dagan kind of seconded, it's obvious that this was basically catastrophic, and that this was elimination of a certain sequence, the, if you want, pathogenic gene without actually doing any correction. Why did they choose to do it? Could they have actually corrected it and changed the study model, and would it have given us a better result?
I wouldn't say catastrophic. I'm just pointing out the fact that in this particular case, no corrected gene was introduced using some sort of template, which would be applicable to most mutation types. And as I mentioned, so I'm not judging this experiment. These are just very examples of technical issues that certainly need to be addressed. I think the take-home message from this study is what Dagan says, that that this, even in the zygote, this will not necessarily keep within the zygote, but may propagate. The effect may propagate into further mitosis.
I want to say just what I meant by catastrophic, first of all, not as a criticism of the study, because I think that this in vitro study contributes a lot to our understanding and to moving the technology forward. And I think it was done with that intent, without even any intent to produce a pregnancy. But to me, when I look at it and I see that 50% had broken chromosome 6, plus there were off-target mutations, I would call that, quite extreme unwanted results.
Yeah, absolutely. I mean, with CRISPR, we've for a long time been concerned about the so-called off-target effects. We go for one locus to try and alter it, to repair it, perhaps, and we accidentally cause a cut somewhere else in the genome that wasn't intended. Now, I think people are getting better and better at their design of guide RNAs and CRISPR experiments, so that very often these sorts of off-target effects are few, if any, detectable. So that seems to be something that maybe at many loci you could overcome with sufficient optimization. But this takes it to another whole level of problem in that you get the right site, you're introducing your double-strand DNA break just where you want it to, but the cell isn't doing its job of then fixing it. And this seems to be a feature which is quite unique to early human embryos. You know, we've done these sorts of experiments many times in cell lines, and it's very rare to repair. But in the embryos, it's extremely common. We were involved with a study with Kathy Nayakan back in 2017, doing CRISPR on early human embryos, and we saw exactly the same thing as they've reported here, where very often the actual site that we targeted, we didn't see any off-target effects at all, but the site that we targeted often didn't get repaired, leading to segmental abnormalities or even whole chromosome losses within those particular embryos. So this does seem to be a feature of human embryos at this early stage of development.
So Dagan, I want to take us all to another experiment. Are you all familiar with this guy?
Yeah.
Okay, so maybe you can actually...
Where is he now?
I didn't recognize him without the orange suit.
Oh, okay.
And the ball and chain.
Okay, so previously this got a lot of attention in the media, and I think in the courts, even in China, I believe. And maybe you guys can comment on this. So this was actually an experiment very diametrically opposed to the very well-controlled and ethical way that they ran the study at Columbia. Here is a physician, a scientist, probably not a physician, I'm not sure, who actually created pregnancies that he said were based on CRISPR of embryos. So I'll just say clinically what it is, and then I'd like for you guys to comment on it. So he basically was trying to eliminate a gene that causes, that exposes a person to HIV, which is called CCR5, which, as you can see, is pretty common in the European populations, etc. And he took 7 pairs of men and women, and all the men were HIV positive, and he offered them free IVF. The consent said AIDS vaccine development program. Vaccine is a very hot word these days. And the sperm from the men was washed to get rid of HIV as much as possible. And they basically CRISPR'd 22 embryos, 16 were edited successfully, 11 implanted, and they had 1 pregnancy, twin girls, so I assume they put 2, and Lulu and Nana were born. So apparently in one embryo that became a baby, both copies of CCR5 were disabled, and in the other one, only 1 copy was disabled. Comments?
I think it's a good example of how not to do things right. And as far as I heard, he was sentenced. So this is the reason why discussions like we're having now, but certainly consensus statements and interventions by different societies and organizations to control this, because I think one needs to remember, first, do no harm. So I think that things like that will probably not happen in the near future.
Right.
Well, also, you know, it's a very strange
choice.
Again, a very strange choice. Not, you know, there are very good IVF protocols, as I understand it, to wash sperm to really massively reduce the risk of HIV transmission. And there are clearly, very, very good treatments for HIV now. So it was a very strange choice. And also there are some thoughts that CCR5 also has other functionalities in intelligence and other things, and there was some question marks, even more ethical question marks, as to why he was doing this rather than trying to make these children, resistant to HIV. So it was terrible that he went straight to doing this in germline, and also just, I think, if you want to talk about non-maleficence, this is almost a perfect example of this.
Yeah. So we'll get to it in a minute. And Tony, thank you. This was an important comment, and we have a slide on it, in fact, on what CCR5 does that is actually positive. And the whole thing of why, choose this gene also will come up. So we would like to discuss the ethics of gene editing in light of the recent advancements and what can be done. And I think that the example from China was how people can run ahead of any kind of consensus because the science is so we're going to discuss editing the genome from the 4 points of view that are usually exercised when we discuss ethics in medicine. The 4 points are respect for autonomy, beneficence, non-maleficence, and justice. And I'd like each one of our faculty to take the lead in one perspective. So the first one is autonomy. I'd like Yuval to take the lead, please.
Yeah. So, regarding autonomy, autonomy is often perceived as the right of the patient to choose. So, physician should offer all alternatives and let the patients make their own autonomous decision. But one of the major parts of real autonomy is for the patient to make an informed choice. So autonomy is not just making the choice itself, but being properly informed. And being properly informed requires that the procedure in question be clear from any coercion or coaxing, and for the patients to make the right decision, the patient must understand all the risks and all the benefits of the procedure and the likelihood of success and so on. And I think this actually harbors the greatest opposition to offering this technology, because I think we have no idea regarding the benefits, the long-term outcomes, and the complications. So I think there's no way one could practice this ethically without being aware of the consequences. And I think it will take quite a long time to be certain of all these aspects. And I believe it will take quite a few more years for us to be certain that the technology is clear. And one thing that we have not discussed is the conditions which actually would require this. So this is another part of informing the patients. The patients should be aware that there are other options like PGT and so on, and there are very rare and extreme circumstances in genetics when there are no options for a certain couple of having their own biological normal kids. For instance, if both parents are affected with a genetic condition, autosomal recessive genetic condition, for instance, hearing loss or blindness. If they both have the same recessive condition, 100% of their children will have that condition. But then once these people reach reproductive age and are able to make their own choices, should these individuals be eliminated from future generations? So these are the aspects that need to be discussed.
Okay, so Yuval, what does the embryo have any rights? We're now assuming that the technical parts have been sorted out. Let's say we now have an ideal technology that has overcome these hardships that we were talking about, the off-target mutations and the unwanted results, and we have a perfect CRISPR. We can fix any single gene. So does the
theoretical position, but this, I'm saying that I don't see any particular reason to prevent this type of treatment as long as it is safe and as long as it will comply with all aspects of ethics, as you will discuss in the future. But assuming that, I don't see any reason why one would not intervene. We've seen this type of theoretical opposition to IVF and PGT. So in theory, this is just another extension of our capabilities as long as we comply with these standards and with people. So scientific standards to the highest degree, and of course, considering ethics. And of course, even if we comply with all this, there will be some opposition. People say this is intervening with God's work, or some say this is intervening with human heritage, with all its diversity. But I think from a technical point of view, if all things are taken care of, I don't see any real reason to oppose this.
Okay, so my question is, and I'd like the other members of the panel also to voice their opinion. Let's look at this slide, and for a minute, tell me how you feel about, and this is a general thing about what we do with embryos, okay? It's a general question. Does the embryo have rights? Can you, do the parents have full custody over the decision-making process regarding the genetic future of their offspring? If you were, we were all once embryos, how would you have felt like had your parents engineered your genome?
Well, I guess if I was an embryo that was affected with a genetic disorder and my parents had chosen to engineer my genome, I might still be happier than if they'd done PGT or prenatal testing and chosen not to have me at all. So, I think, it's one of those slightly, I guess, counterintuitive things, but in some respects, you could consider genome editing to be less ethically challenging than some things like PGT or prenatal testing. And if you want to follow, say a strict Catholic doctrine, then, by the time the sperm meet the egg, there's the individual with the soul and everything, and the discard of that individual, regardless of whether they're affected with a condition, is probably something that you would want to avoid. Whereas potentially, if you had CRISPR and it was completely safe to use, perhaps no embryo would need to be discarded, or so you could argue from that perspective that it actually maybe is less ethically challenging than some other things. Of course, I'm glossing over a lot of other points while saying that, and I acknowledge that.
Yeah, Tony.
Yeah, it's a deep ethical question. I'm not sure whether I'm quite comfortable, but I think that in practical terms, although the embryo should have a decision on this, it is the parents that decide. And as long as they have full informed consent, then I'm that is a reasonable position. I think the problem is informed, because we don't know. It would have to be in a hypothetical situation where it was safe and effective and long-term safe and effective for future germlines. And if it was in that situation, then yes, I would be comfortable with the parents having the informed decision, because that's the only practical way.
I also have a question regarding something you said before, Yuval. I think you mentioned coercion. And in informed consent, obviously, one of the principles is that the patient should not be coerced. So, for example, in that Chinese experiment, or more than experiment, they gave free IVF. Would that be considered coercion?
Now you're asking the lawyer in me. Yes, I assume in a country where access to IVF is not available to everyone, then it is a form of coercion, certainly. I don't see it as that's the least of our problems with this study.
Right.
But one must remember that if we go back to the rights of the unborn or unconceived embryo, one must remember that the choice of cases don't even allow for a selection. So in a case of a couple who has an autosomal dominant condition or autosomal recessive, there's still enough normal embryos to be had in most cases. And so if there are absolutely no choice, then I would see that as an option, as the only option the parents will have. And then I think there is, as Dagan said, I think it's less morally objectable.
Okay. So this is just to show you the different developments here. As Yuval said, there is a legal thing here, and we don't have a reproductive lawyer on our panel, but you can see that this is the development of personhood, if you want, and you can see that the more you go towards the adult, the more of a person you are. And of course, you have the religious views, which Dagan mentioned, and also philosophical and moral meanings. And we'll just go ahead, but I just want to say that the issue of personhood in embryos is quite complicated and really varies from culture to culture and from religion to religion. Okay, why don't we move a little bit further, and Dagan, why don't you take the lead here?
Workaround. I mean, what is the benefit to a patient of having this? I mean, we've got prenatal testing and had it for many years for most conditions. We have PGT, and we're very efficient now at making highly accurate tests for, again, most conditions that a patient might want to identify in their embryos. So do we really even need these sorts of things? Well, the answer is yes, potentially, again, if it was safe and everything. There are some instances in which we can't efficiently do PGT. There's a significant proportion of cases, maybe 10, 15%, where you don't find any embryos available for transfer. That was even higher if you're talking about a dominant disorder where a greater proportion of the embryos are affected. And actually, since we've started combining PGT-M, looking at mutations in single genes, with looking for chromosome abnormalities, which are of course very common in our early embryos, you get even more cycles where there's no embryos which are both considered viable, euploid, and free of the condition. So, these days an even higher proportion of PGT-M cycles actually end up having no embryos suitable for transfer. So again, that brings in the desirability of being able to potentially, if you like, fix the defect to make more of the embryos transferable. Another thing is that, of course, PGT depends on IVF, and so in a typical IVF cycle, not all the embryos are going to be viable anyway. Even if you're only looking with morphology, sometimes you find that the one embryo from that cycle that is actually normal in terms of a single gene mutation actually is the worst looking embryo, or the one that you probably think has the least chance of making a baby. So again, if you could repair a defect in all of the embryos, you could then genuinely select the embryo that seems to be developing the best, and therefore is most likely to produce a viable pregnancy. So we've got issues like that. And as Yuval mentioned, there are rare cases where we have two patients who are both affected with a recessive disorder. So, again, you can have these kinds of problems, or even rarer, some, cancer predispositions, you can sometimes have a dominant condition in a homozygous form, although very occasionally. So there are these sort of situations where PGT or even prenatal testing can't really assist, and so it'd be highly desirable to have a way of fixing a genetic defect of this type. We also, of course, have patients who, for their own either religious or personal philosophical reasons, are opposed to discarding any embryos. And so again, this would be an option for them potentially.
Yes. So these two situations that are mentioned in 3 and 4 here are really rare. However, what I've heard is that sometimes, let's say you're talking about deafness, sometimes patients affected by the same disease tend to socially gather and have a higher chance of choosing each other for life mates, so that the random genetics all of a sudden shows its challenging face, and therefore it could happen. Go ahead, please, Dagan.
Yeah, you're absolutely right, and deafness is an excellent example of that. The deaf community really has a kind of culture and community of its own, so that can quite often be the case. And of course, we've had some interesting ethical discussions when a couple has even wanted to have a child that shared the deafness with them so that they could be more part of that community. Those are all sort of very key points. On the slide that you have here, of course, you've got some specific questions about how this could be used in terms of fertility treatment. I guess very often here we wouldn't be talking so much about necessarily treating the embryos, but maybe a treatment on the patients that could then be passed into the embryos. You mentioned here the issue of chromosomal translocations, which of course have a reproductive impact in terms of both affected children, but also a very common instance of pregnancy loss. If you could eliminate that from parental gametes, then of course it would therefore also be eliminated from the embryos and go forth, hopefully to a viable pregnancy. What other examples have you got here? Some other gene conditions that you could repair. The CDK2 one is an interesting one. As you know, there have been some studies looking in male mice at manipulating that gene in order to restore spermatogenesis. So, by extrapolation, that sort of approach may be again applicable to azoospermic men. So there is some basic research that's been done in this area with potential clinical consequences. Again, many of these you might be actually interacting with the reproductive tissues rather than later embryos. You wouldn't be trying to fix infertility in the embryo, you'd be trying to fix it in the parent, and then that would then potentially be contained in that parent's germline going forward. So it is still germline editing of the genome, but maybe not at the actual embryonic stage. And given the kind of sort of catastrophic impact on some of the chromosomal stability that we've seen in some studies, that might be a more desirable way to go. I also mentioned a correction of Y chromosome deletion again. These are all factors that can impact, in this case, function. So yeah, those are all quite attractive areas that you could look at. Of course, editing of somatic cells has been a very promising area of CRISPR research and perhaps less controversial, although of course with potential off-target effects or failure to repair double-strand breaks, you do maybe have questions about tumorigenicity of some of these approaches. But yeah, I don't know, Havna, whether you wanted to pick up on any particular one of these, these being more sort of somatic treatments.
Right. It's interesting that it has RP here, retinitis pigmentosa, and the gene that they, that we started our conversation was related to RP as well. So it's just a list of genes that people have tried. And of course, think about what we could do with Alzheimer's if really the ApoE gene, I think it's especially ApoE4, could be eliminated from the population. But I'd like to just...
This is just...
yeah.
I mean, I'm glad that you brought up these examples in the last two slides, but I'd like to bring you back to this committee opinion. And in their recommendation number 4, they state that should a country decide to use limited to circumstances, and the first one is use limited to serious monogenic diseases, and a serious monogenic disease is defined as one that causes severe morbidity or premature death. Now, I would argue...
Okay.
I would argue that most of the conditions that we see here do not really conform with this recommendation, because it would be extremely rare for a parent to be of reproductive fitness having a severe morbidity or a condition causing premature death. And a lot of the examples that we have discussed do not necessarily apply. This does not necessarily apply to them. Certainly not conditions like Alzheimer and myocardial infarction genes. These are all polygenic conditions or involved with environmental factors. So I don't think any of these would apply should we even begin to consider this type of treatment. So again, I go back to very rare conditions where certainly early onset blindness, like Leber's congenital amaurosis causing blindness from death, not a progressive condition, and so on.
I just want to remind you that, first of all, we'll get to the recommendations at the end. So, Yuval, you're right. These are the recommendations, and we'll talk about it more. But we're talking about an emerging technology. If you think about how people talked about IVF when it was started, and how much resistance there was, and how much people said that it would be the rare cases that would actually require that. I'm thinking that acceptance of this technology as it applies to us will be very gradual. And I mean, even if we are able to our field is totally able, the scientists and the physicians totally able to control it, it will be probably very gradual, and application will first be in the very extreme cases. But imagine that this technology became like what ICSI is now, or what even PGT-M is now, where it's become a routine. Would you have even thought about it when before Louise Brown was born in 1978, that in 1990 they'll start doing PGT, and in 2020 we're talking about huge changes and doing WGA and stuff. So just a reminder that I totally agree. These are not things we should go for now. but in the future. And this actually brings up what I think you, Tony, mentioned before, and that is actually getting rid of the CCR5 gene, which is what was done in China, actually gets rid of some of the neurological advantages of the gene. I just wanted to show this and we'll move on. So the last thing is the most fun thing, and that is eugenics. So you want to continue with that, Dagan? It's still your territory.
Well, eugenics isn't my territory. You can keep that one. Maybe we as, what is it, Yuval and I as the token Jews here can relate to it a little more. By the way, I live in Cold Spring Harbor in New York, across from the genetics lab. And guess where eugenics, where Hitler got his inspiration? In Cold Spring Harbor, in the United States, is where eugenics started. And they had a registry for families and all kinds of things. Started in America, not even in Germany. So, eugenics is divided into the negative eugenics versus the positive one. Negative eugenics is obviously anyone that's different than the, the desired race and look and, characteristics should be eliminated. So you can say that about embryos, that, you can eliminate all the undesired traits. The positive eugenics is, for example, happened in Singapore, and that is where they actually incentivize educated couples to have children and disincentivized couples that did not have, that were of a lower social class to have children. And then there is the whole thing about genomic upgrade with the Genius sperm bank that was tried in America and never succeeded. It didn't work for some reason. But in any case, I think we all feel strongly about it. Any comments before we move on about eugenics? Yeah, I mean, I think you've covered it sort of quite well. I mean, I also, I studied genetics at University College London, and the genetics laboratory at that time, and the genetics department was based within the Galton laboratory. And of course, Francis Galton, a cousin of Darwin, was also a big proponent of eugenic ideas. So yes, it's those kinds of ideas have been a bit pervasive through the scientific community decades ago, at least. Hopefully not so much these days. But yeah, I think that the sort of genomic upgrade point that you've got there is one of the most telling ones, that when people have had a choice with things like sperm or egg donors, in fact, how often, in a sense, they're already doing eugenic processes by opting for certain characteristics. People always, of course, worried that PGT might be used for eugenic purposes, but happily, that hasn't really turned out to be the case. Partly because who would choose to go through something as uncertain as an IVF cycle and as potentially stressful and difficult as IVF combined with PGT if they didn't have a really serious reason for needing to do it. And also the issue of every time you select for something, you reduce the number of embryos available for transfer. If you've only got one or two that might be viable to begin with, then once you've selected for one or two things, you'll be very lucky to find anything else remaining. So some of these more complex or polygenic traits like athleticism and intelligence are almost unselectable. So I guess there is a risk that CRISPR might make these things more easier to do, but hopefully guidelines and legislation will prevent that.
I highly recommend a very, very small book written by Professor Sandel from Harvard, and it's called The Case Against Perfection. And he makes the distinction between curing and improving And of course, we have this whole issue of designer babies. And he even gives the example of the Williams girls. And this is how you try to improve nature in a way by training. This is not even genetics. And then people who have tried to actually work on the IQ based on the dopamine receptors. And that's the ultimate, right? So, okay, so now, Tony, please, that's your territory. It's like we say, we physicians swear to first do no harm, right? So maybe you can tackle it from the scientific point of view, and this actually goes back to the CRISPR technology.
So, yeah, non-maleficence, first do no harm. I think as the current technology stands for CRISPR, and we've got to remember it's a very fast-moving field, and there's a tremendous number of developments, but as it stands, the argument against CRISPR for non-maleficence is fairly clear. And I think the Zucchero paper that we discussed before almost is a kind of full house of all the things that could go wrong, that really, should give us cause for holding back for germline editing. So you can put the kind of issues into kind of three categories. On-target effects, so where the correction of the error hasn't been perfect on the target. Off-target effects, which we saw in the Zucchero paper from the chromosome 16 changes, and then from mosaicism, whereby you don't actually get the correction in all the cells in the embryo. Also, a lot of this comes back to the treatment that you're looking for, and it was very nicely described by Dagan and Yuval in terms of the particular circumstances where you couldn't have alternatives. And I think it's very important when you look at non-maleficence whether there are suitable alternatives. And we do have alternatives in PGT-M for the vast majority of things. So you should use them if you have doubts about the actual treatment using CRISPR and then the long-term effects as well. So it's at the moment a fairly easy argument to make of we shouldn't be doing CRISPR because of non-maleficence. The other thing which is interesting as well is when you look at these experiments, they were able to take affected sperm, but unless you take the very small number of conditions that Dagan, I think, described where there are no alternatives, most of the conditions are going dominance, and it's very hard technically at the moment to be able to treat a zygote and actually know which ones are affected. And hence you would be treating unaffected or carrier zygotes. So that's a very clear case of non-maleficence. So there's some very interesting questions with the current technology, and you can see on the slides here, mosaicism can cause a tremendous amount of efforts, and I think that's something that we're still learning so much that to use the technology as it stands at the moment is ethically challenging.
Right. So,
I have a question.
Yes.
Let's assume that one can create a zygote and at a very early stage perform reproductive cloning. So actually make many copies of the same zygote. So actually developing into an embryo, disintegrating it, and then creating artificial zona pellucida. And then this may enable us to bypass some of the risks. And then at a blastocyst stage, one could actually do validity checks that are required for on-target, off-target, mosaicism, and so on. So in theory, by combining additional technologies, one could bypass at least some of these concerns. do you think, you're the scientist, do you think it is possible to consider something like this?
I just love the way that we're talking about something that's ethically challenging like CRISPR, and now you've thrown cloning in on top of it. Thanks for that, Yuval. That's brilliant. But no, I mean, I think you're absolutely right. With the uncertainties around this technology, you would have to still be doing things like PGT in tandem with it for the foreseeable future. I
was going to say, Dagan, you must look at the amount of work in the Zucchero paper and the amount of investigations that they've had to do in order to see whether their CRISPR treatments have worked and whether they're effective, and think that it's an incredible amount of work. It's hard to see practically how we're going to put that in place, never mind, in terms of effectiveness. In your case, Yuval, you've added a new level of non-maleficence, because now you have to tell me whether cloning is working before we actually move on to anything else. So, yeah.
I'd like to just move on, because this is fascinating, and I think we could talk for a very, very long time. The last type of criteria for ethical judgment of medical practice and new technologies has to do with justice. And the first is obvious with any technology that we have, is access, and is the fair distribution of resources. And we know it from IVF, we know it from PGT, whether it is A or M. We struggle with it in every country in a different way, but access is almost never to everybody. In addition, of course, we want to respect the patient's right to refuse, and there have to be morally acceptable laws in that country that allow it, and obviously that has not happened yet. We know that what was done in China was ended up in Chinese law being considered illegal. And this is the book I recommended to you. And what I'd like to do now, in kind of getting close to closing, is for each of us to cite you. So what happened is, we said that this was very timely, our discussion, because there's the Nobel Prize awarded to the CRISPR inventors. There is the interesting work out of Colombia of CRISPRing and embryos, and there is also this international commission that on the clinical use of human germline genome editing, which is now called HHGE. Start getting used to it, and it was made up of the three academies: the National Academy of Science in the US, the National Academy of Medicine in the US, and the Royal Society in the UK. So it's a British USA collaboration, and in addition, 10 countries. So it's actually 4 continents. They came up with, it's very, very long report, came out September of this year, and it has, first of all, it's voluminous. It's like 18 pages, but they have 11 recommendations. So what I chose was just several of them that I think are very, very important, and I'd like each of you to present some of them. So Yuval, you go first.
I think we discussed that safety is not yet established. This certainly is part of making autonomous decision requiring informed consent. I've discussed this previously, and it also hinges on non-maleficence, because if safety is not established, then we cannot discuss this yet. So certainly these two are the main points to oppose this at this point in time.
Right. Now, Dagan?
Which one do you want me to cover?
Just this slide.
Oh, okay. Sorry. Yeah, I mean, of course, this is talking about what would be appropriate to actually use this technology for. So as we've already discussed in the earlier in our earlier discussions about some of the definitions which Yuval mentioned, how you would define a disease that would be appropriate to look for. And yeah, I think we can, I think with a lot of this, including the public discussions and interactions, which Yuval was just mentioning, we can also look to how the possibility of repair of mitochondrial DNA diseases was developed in the UK, where there was, this is of course using the concept of either spindle transfer or pronuclear transfer in order to essentially replace the entire cytoplasm, including all the mitochondria, for conditions where there's a mitochondrial DNA mutation. And that went through an extended process of public engagement before ultimately going before Parliament, and there actually being a change in the law to allow that particular kind of, if you want that, you could even consider that a form of germline genome editing.
Yeah, I think it's important on this slide, I'm sorry, Dagan, that in number 4, you see, the commission was definitely, we're not ready for prime time, no CRISPR period until further notice. But they do give some outlines as to where we go in the next step. So in number 4 here, I think what's important is that they are laying out some of the foundations for, if you want, criteria for these unusual cases where we may, it may be considered in the future. And they say things like, no option for a genetically related child that does not have the disease, very poor options because the proportion of unaffected embryos is less than 25%, which is a really interesting foundation. So, Tony, that's you now.
Sorry, I was just going to comment on that last point, and I'm sure Dagan will agree. 25% of embryos suitable for transfer, when you're doing PGT-M with PGT-A or double condition PGT-M or PGT-M where we have a translocation and a monogenic disease, that's not an unusual circumstance to have less than 25%. I mean, it really isn't. One failed IVF cycle is not unusual.
And they say they should have failed one IVF, one PGT-M cycle. But
I totally agree.
It's unfortunate that they didn't have the 4 of us in that commission.
No, I totally. Same thing occurred to me, that 25% seem to be setting the bar quite low, really. Plenty of people would fall within that.
Okay.
But again, all things have to fall in place. So it's not enough to be 25%, but it has to be a serious condition. So
absolutely,
it's going to be difficult to find these cases. But I'm sure that by the time that we work out the glitches in this technology, we'll have some candidates, that's for sure. So I'm sure they're out there.
Okay, so Tony, can you elaborate on this slide?
Yeah, so this is an interesting slide, Amber, because this is really the commission here setting the bar for what they see as the recommendations before we can move ahead. So only the intended edits, no other modifications, no additional variants to the editing process at off-target sites, no mosaicism, suitable grade pregnancy to establish suitable grade to establish a pregnancy, and have aneuploidy rates no higher than expected. From where we are right now, that's a pretty high bar that we're going to have to develop the CRISPR technology before we'll be able to apply it, because it fails on most of them most of the time for most of the things we've looked at. So, I think that there will be certain things that are going to be more amenable to it in terms of, your kind of point mutation type disorders, rather than the strange double strand break technology that they implemented in the first one. But even so, that's a fairly high bar to get past before we can actually implement it.
Right. But it's a good thing that they did set up a bar. And the last thing that I picked, again, you can see how many recommendations there are here of a very large panel, but they are actually establishing an advisory panel that will kind of, I think, escort all the efforts for further research and will supervise it. And I think that that's a good thing, and hopefully they will have a very balanced composition of this committee, and I will recommend the members of this panel, of course. So just to kind of show you, this is interesting. Also came out this year is, and I don't know if you knew that, but there is actually a CRISPR journal. So in there you see that these are the policies worldwide. They looked at I think it's 96 countries. And what you can see here is that in terms of policies regarding germline editing, not for reproduction, you see that 56 countries did not have any information at all. And then you have 11 countries that actually permit it. And then the rest are kind of intermediate or prohibited. And that's the map. So the map here, it's interesting because green is permitted. Okay, so remember this map when you compare it to the next one, which is what is the status of policies regarding human genome editing for reproduction in the same number of countries. And what you see here is a very, very different picture. 70 countries it's prohibited. There's no country that it's actually allowed. And you have some either exceptions or intermediate. And you see in this map, there's no green at all. It's all red, but that's not political, so don't mistake it for anything. So with that, we want to close with a video that came from courtesy of Yuval.
CRISPR-Cas9, bring me a gene, encoding for a specific protein. Make a few snips at this coded locus. You work so well inside a streptococcus. Cas9, I'm so alone without your scissors in my chromosome. Cut me up and do it clear. CRISPR-Cas9, bring me a gene. CRISPR-Cas9, give me a gene, a virus sequence you've already seen, chopped into bits and stored as genomic, with clustered babies that are palindromic. Cas9, bind with this code, use it to target infections of old, immunize like a vaccine. CRISPR-Cas9, give me a gene. CRISPR-Cas9, cut me a gene with a precision that I've never seen. Unzip a strand and interrogate it. Seek out your sequence until you locate it. Cas9, lock into place and do your job as endonuclease. Chop just like a guillotine. CRISPR-Cas9, get me a gene. Snip, snap. CRISPR-Cas9. CRISPR-Cas9, bring me a gene by commandeering my repair routine. strength to match your severed location. For some homologous recombination. Cas9, cheap and precise, rewriting genomes from microbes to mice and soothe the humble human being. CRISPR-Cas9. Give us a gene, give us a miracle like the one Nazarene, 'cause giving the lame their legs and the blind their sight is moving different dystrophy and retinitis. Oh, with CRISPR-Cas9, why did you fall? Outside our power and inside our soul, that really good inside a scene. This terrible, wonderful power unsettling arms of torture and ethically metal is every congenital melody better to fit into warrant genetics and better to mod by men in the manner of categories of a mammoth or make a radical medical means to eradicate aging or cancer or make a fanatic a massive epidemic or weapon to bury a single mosquito to wipe a malaria send a viral infection to bury a cure to the symptom of HIV carrier of diseases for freedom of chemical for nature and accident failed to discover and try to be other than all that we ever have been.
I'd like to thank everybody. What a wonderful, wonderful panel we had. I think we tackled a lot of different aspects of this very important issue. And I'm sure that people worldwide through our Zoom conference will benefit from it. And to be continued, and hopefully see you in Paris a year from now.
you.